Sure.
Right here, that's just what.
Perfect. Okay, thanks so much, Nal. Good morning. Welcome, everybody. Everybody grab a seat here. All right. Good morning, everybody. This is the Gastroesophageal Cancer Education Symposium. I'd like to welcome everybody. On behalf of my co-director, Dr. Shanda Blackman, and myself, Dr. Travis Grotz, we'd like to invite you to this symposium for patients and caregivers. We're also in collaboration with our partners with Debbie's Dream Foundation and our patient panelists. We have to acknowledge our commercial supports. So we have our national platinum sponsors, our Bristol Myers Squibb and Merck. Our national silver sponsors are Stellus and Taiho Oncology. Our national bronze sponsors are Zymeworks. So they've helped make this possible. We also have exhibitors out in the atrium with Bristol Myers and Squibb. And so the goals today are to review some of the up-to-date information on diagnosis of both gastric and esophageal cancer. We're going to talk a little bit about surgical interventions, some new emerging therapies, some of the research that we're doing here and across the world for patients with esophageal and gastric cancers. We'll also dive into some of the psychosocial issues that patients and caregivers often have to deal with gastric and esophageal cancer. And we'll talk a little bit about some of the practical approaches to survivorship. So just some housekeeping rules. Mayo Clinic's got no smoking policy, so there's no smoking in the building. This is being live streamed and is available online and be archived both at Mayo and both at Debbie's Dream Foundation, so there's no need for any taping or photography. We ask this to minimize distractions, that you silence your electronic devices. We do have some meals and snacks and breaks provided for you. So I hope you got some coffee and some breakfast this morning. There'll be another break session early this morning, as well as lunch. And then we'll be having a cooking demo this afternoon. We ask that you eat and drink out in the atrium. It's a much larger area. You can distance, and so you can take your mask off and eat. And try not to eat or drink in the auditorium here. So we do have quite a few participants through Zoom, so thank you for joining us as well. Now is a great time for those people to familiarize themselves with the Zoom features and speakers and the slide sizes. They can submit questions through the Zoom Q&A, and we will get those questions, and we'll try to answer those for you. If you have any technical issues, we do have some support. If you can email Dorinda Johnson at that email, she can help you. We'll have, each speaker will have about 30 minutes, and so they'll give their presentation. If there's some time left over, they'll answer questions directly. There'll be a breakout session after a couple speakers. There'll be a combination of both having patients out here to share their stories with us, but also a time for you to ask questions to the speakers as well. People online can go ahead and submit questions through the Zoom. Anybody in the audience can, we have some paper cards you can write questions down if you want. You can raise your hand and let us know if you have any questions. So some COVID-19 guidelines, we want this to be a safe experience for everybody. So the people who are in attendance, we ask that you wear a mask at all times, including here. We ask you to use non-vented masks. We've tried to space everybody out to help with social distancing as much as possible. There's hand sanitization available everywhere, and so it's highly encouraged. With speakers who have been vaccinated, we blocked off the front row. So for clarity of speaking, you can take your mask off briefly while you give your presentation, and then put it back on when you get into the audience. Again, if you have any questions, you can stop by the registration desk out there where we have both Shannon and Dorinda, or if you're online, you can email them as well. All right, and I hope everybody enjoys the symposium. We got a great schedule today. I hope you'll find it very engaging and informative. And without further ado, I'd like to invite Jennifer Higgins Spears up here with DDF. She's going to share a little bit about what DDF is and what they've done for patients with gastric cancer.
Hello, everyone. Thank you, everyone, for joining us today for our Gastroesophageal Educational Symposium, jointly sponsored by Mayo Clinic and Debbie's Dream Foundation Curing Stomach Cancer. Also, thank you to the physicians, patients, and caregivers who have assisted in organizing and participating in this event. Andrea Eidelman is the CEO of Debbie's Dream Foundation. She unfortunately cannot be here with us today. I will be presenting on her behalf. My name is Jennifer Higgins Spires, and I am a 12-year stage 1 survivor of stomach cancer. I'm also a chapter leader in Boston and a prep mentor to services from DDF that you will be hearing about later in this presentation. Thank you to our generous sponsors, platinum sponsors, Bristol Myers Squibb and Merck, silver sponsors, Astellas and Taiho Oncology, and bronze sponsor, Zymeworks. Our mission is to raise awareness about stomach cancer, advance funding for research, and provide education, support nationally and internationally to patients, caregivers, and families. Our ultimate goal is to make a cure for stomach cancer a reality. DDF was founded by Debbie Zellman in 2009, 1 year after she was diagnosed with stage 4 incurable stomach cancer. A 40-year-old mother of 3 and a practicing attorney, Debbie had no symptoms or risk factors for the disease. At the time of her diagnosis, she was given a 4% chance to live for 5 years. Debbie fought for 9.5 years, facing many recurrences and harsh treatment regimens. When she was diagnosed, Debbie was surprised to learn that there were few treatment options available and little research taking place. So she founded DDF in 2009 to raise awareness for stomach cancer and advocate for increased funding for research. Sadly, Debbie passed away December 23, 2017, but her legacy continues through the foundation. DDF has partnered with the American Association for Cancer Research to offer grants for basic, translational, and clinical research in stomach cancer. The AACR ensures that research proposals are put through peer review mandated guidelines and criteria throughout the length of the grant. To date, DDF has funded grants totaling $1,200,000. DDF offers many free programs to the stomach cancer community. Some of our ongoing initiatives include our PrEP program, symposia, webinar series, and our nutrition education program. PrEP is one of our largest programs that encompass the general mission of the foundation in providing education and support nationally and internationally to the stomach cancer community. The PrEP program includes mentoring, advocacy and outreach, virtual support groups, and the Dream Makers Miracle Fund, as well as a clinical trials matching service and an online support community. As part of the PrEP program, we are able to connect those feeling alone in their diagnosis with others who know exactly what they are going through. Our mentoring program provides patients and their families with a mentor who is a patient, a survivor, a caregiver, based on age, location, stage, and biomarker. Our monthly support groups is led by a licensed clinician and is a huge resource for newly diagnosed patients. We also have an online support discussion community where patients can remain anonymous and seek support and guidance from each other. Under PrEP, our Dream Makers Miracle Fund was a new 2020 initiative. We were able to grant wishes to patients and their families to create lasting memories. Here are some pictures from our award winners. The Feast family went to Disney World. Joey Feast was diagnosed at age 17 of stomach cancer. 6 years ago, his brother died of stomach cancer, and he was only 20 years old. So stomach cancer has affected their family tremendously. We are also able to grant Kenny Ricard his bucket list wish of skydiving, which was featured on the local news. Additionally, through this initiative, we were able to host a toy giveaway this past December. DDF is privileged to have given gifts to children under 18 years old. As part of our mission, we advocate for early detection and provide community education and outreach to physicians, nurse navigators, hospitals, legislators, and disparate communities affected by stomach cancer. We also have 32 chapter leaders throughout the states and overseas who are strong advocates and spread awareness to their local community about this cancer. Each year, patient advocates come together at Capitol Hill for our annual Debbie's Dream Advocacy Day with the ultimate goal of securing funding from the Department of Defense's peer-reviewed cancer research program, which allocates funds for cancer research. Last year, our webinar series program hosted 6 educational webinars. This year, the series launched in January, featuring Dr. Craig Lockhart discussing perioperative chemotherapy. In February, NCCN spoke on the stomach cancer guidelines. In July, Dr. Laguna spoke on HIPEC. In each September, we host our clinical trial updates webinar, and at the end of the year, we will be partnering with Cancer Care to present on how to talk to your children about the stomach cancer diagnosis. We hosted 3 successful online symposia events last year. This year, our symposia series launched in June when we partnered with the Korean Cancer Association to host a virtual event highlighting gastric cancer treatment in the East and West and address how to bridge the gap in care. We are excited today to host our first live symposium event here at the Mayo Clinic in Minnesota, and in November, we will be traveling to South Korea for our international symposia event. Stomach cancer patients and caregivers need simplified answers to help them maintain proper nutrition post-diagnosis and gastrectomy. We offer education around nutrition through our webinars, symposia, recipe books, and content from our website to help empower our patients. In May, DDF launched a new stomach cancer hotline in partnership with Cancer Care, where licensed social workers will be able to connect with patients to address the financial, emotional, and practical challenges that face our stomach cancer community. In 2020, we launched the COVID program, which continues this year. The pandemic brings about many new challenges for stomach cancer patients and their support systems. We are able to provide COVID educational webinars, free COVID kits, and meal delivery through Instacart. Additionally, DDF launched the Mind, Body, Spirit Mental Health series on Facebook Live. Our programming content is reviewed by our esteemed Scientific Medical Advisory Board. Also, our members host educational webinars and contribute to our symposia events year-round. Again, we would like to thank our program chairs, Dr. Travis Grotz and Dr. Shanda Blackman, for all their hard work and dedication. Also, thank you to the physicians, patients, and caregivers that have assisted in organizing and participating in this event. And thank you again to our generous sponsors who helped make this event possible. Platinum sponsors Bristol Myers Squibb and Merck. Silver sponsors Taiho Oncology and Astellas, and bronze sponsors Zymeworks. If you would like to learn about getting more involved with DDF, you can visit our website at www.debbiesdream.org. Thank you.
Thank you so much, Jennifer and Andrea, for everything you do with DDF. I mean, it's just an amazing resource if people haven't seen that yet. So much advocacy, so much information there for you, for caregivers and family members as well. Without further ado, we'll get started with our first speaker. So I have the distinct pleasure of inviting Dr. Lisa Boardman to the podium to talk to us about understanding genetic and environmental risk factors for gastroesophageal cancer. She's a professor in the Department of Medicine, and specifically in our Mayo Clinic Gastroenterology and Hepatology Division. She leads our GI neoplasia clinic, where she is actively involved in clinically and in research in early diagnosis and screening for GI cancers. Thank you, Dr. Boardman.
Good morning, and thank you for this opportunity to speak about this area. It's an area of patients who I see in my practice, and then also have an interest in a research setting. So today I'm going to talk to you about trying to understand the genetic and environmental risks that might predispose someone to developing esophageal or gastric cancer. I don't have anything to disclose in this discussion. So the main objectives are going to be, what are the environmental exposures, which sometimes are modifiable, and what are the potential underlying genetic conditions that might lead someone to develop gastric or esophageal cancer. When I began this talk, it became very clear that there's really some major themes here. One of the themes is that most of these cancers develop through a mechanism in which people first have the normal lining, so wherever it is in the GI tract, changes. And in this situation, it changes to developing what's called metaplasia. And metaplasia is where, if in the esophagus you should have a certain type of esophageal cell, it changes to a different type of cell. That's not a cancerous cell, it's just a cell that's in the wrong place. And by being in the wrong place, it means it's going to get exposed to something that it's not equipped to handle. And because of that, then it goes on to the next stage, which is of developing dysplasia. And dysplasia is really when we start to get into the precancerous lesion. In dysplasia, what happens is that there's some DNA damage that happens, and so dysplasia begins as low grade, so maybe the nucleus isn't quite in the same position, maybe it's starting to change the way the shape of the cell looks, and then it becomes more progressive in moderate or advanced severe dysplasia. And then what happens is cancer can develop. And when cancer develops, then it develops the ability to become invasive or spread. So I'm going to take, for example, esophageal squamous cell cancer. So with esophageal squamous cell cancer, the defect actually happens in the basal cell. It starts to become hyperplastic. That means it becomes enlarged. And then we start to go through these stages where you get it becomes a little not like normal, then it becomes more not like normal and more like cancer, and then in fact becomes the invasive cancer. For esophageal squamous cell cancers, which are those cancers that are typically in the upper third of the esophagus, tobacco and alcohol are the big offenders, and they're worse if they're done together. And they're worst based off of kind of like dose. So the more smoking someone does and the more alcohol they drink, that increases the risk. The other thing we see is that the certain foods that contain nitrosos, like from meat, and we'll see that nitric oxide is important, a risk factor. Pickled vegetables, toxin-producing fungus, betel nuts in certain cultures are chewed, and those create a high risk for that. And even drinking like very hot drinks that scald the upper esophagus. There's some esophageal diseases that predispose. One is tylosis, which is a very rare condition. It's a hereditary condition, and what people do is they present with really thickened skin on the palms of their hands and on the soles of their feet. And in addition to that hyperkeratosis, they have a 40 to 90% chance of actually developing squamous esophageal cancer by the age of 70. If someone's had a lye injury, like accidentally drank lye or other type of caustic injury, or if they have achalasia, and that's where the esophagus isn't really able to empty and relax well. I think it's important to realize too, so another kind of common theme that we'll see is that the microbiome matters. And the main thing I just wanted to bring up, that this microbe called Fusobacterium nucleatum is seen to be in patients who have higher stage squamous cell esophageal cancer, and it's also associated with the worst prognosis. From moving kind of down the esophagus near to the stomach is esophageal adenocarcinoma. Again, it goes through the same sort of progression of developing a change. The cells start to change. Those cells aren't equipped to deal with acid. Acid is a bad thing in the esophagus. Acid's okay in the stomach. Then it starts to become dysplastic and then becomes esophageal adenocarcinoma. And this is often preceded by a Barrett's esophagus. And Barrett's esophagus is a disease we see most in white men. It's also associated with people who, as I mentioned, acid, so GERD, hiatal hernia. It's more likely, again, to occur, it's about 2 to 3 times more likely to occur in white men as opposed to, or white people as opposed to African American people. Obesity, which probably contributes through the increased abdominal pressure leading to more acid, but there's probably other things like inflammation that happens. Smoking increases the risk. Things like I mentioned before with the achalasia, again, anything that increases the acid. And then red meats and processed meats may contribute, although I think that's not 100% proven, as is alcohol is not 100% proven to increase the Barrett's esophagus risk. You can see, kind of just to illustrate, with the Barrett's esophagus, if you get the Barrett's esophagus, which is just the cells changing from the cells that should be there to more intestinal type, then that risk of turning to cancer is 0.5%, but it gets higher as it becomes high-grade dysplasia, low-grade dysplasia to high-grade dysplasia. Moving to the stomach, in gastric cancer, for almost all gastric cancers, we see this, again, this process. And what we see often as a precursor lesion is the intestinal metaplasia. Intestinal metaplasia can be of 2 types, and you may have heard of this. It's type 1 or type 2, and it depends on what it looks like under the microscope and whether it has, what it produces. So type 1 is called complete versus type 2, which is incomplete, and the type 2 makes a different type of sialomucin. And that's often evaluated with getting multiple biopsies to look for that cause. I do want to bring up, though, that atrophic gastritis is often a predecessor for this. And atrophic gastritis, if it's autoimmune, in fact, often only happens in a certain part of the stomach. That's because chronic atrophic gastritis is related to damage to the parietal cells, and they're only in certain parts of the stomach, like the fundus in the body. And that's one where we might not necessarily see the intestinal metaplasia. But the other reasons for atrophic gastritis, H. pylori itself can cause it, which is one of the microbiome things that we'll talk about a little bit more in a minute. When we talk about gastric cancer risk, just for the stomach in general, typically it's a disease of older age, but as Jennifer just presented, it can occur in younger people, and it can occur in younger people. Sometimes we know the reason. We'll talk a bit about what genetic things might predispose. But I'd say in general, we're seeing this increase in younger onset or earlier onset of cancers throughout the GI tract. And most of the time, we're not going to know if that's caused. We don't know what the genetic cause is. Gastric cancer is more likely in men. I mentioned associated with tobacco smoking. I mentioned H. pylori, and we'll talk about that a bit more. Salty, processed foods. So in general, processed foods, as you read, they're not good for any part of your body. So, and it's also true with the stomach. Importance of family history, which we'll talk more about with genetics. People who are getting less physical activity, less fiber intake, maybe taking a lower fruit and vegetable intake, because that's not giving you as much antioxidants, and maybe that reflects also a diet that's focusing more on animal and meat, red meat in particular being a big culprit. And then if you've had prior radiation to the chest, perhaps from having had another cancer. The incidence of cardia cancer risk, which is up here, is higher in white people. It's less frequent in African Americans and Asian population. And it's not related to socioeconomic status, but in anywhere else in the stomach, it's less common in white people, but more common in minorities, and it's increased for people based on having a lower socioeconomic status. I bring up too that some of the things that we take, so for instance, if you had a risk of Barrett's, you might be put on a proton pump inhibitor, or if you have reflux, you might be put on a proton pump inhibitor. That's trying to get the acid down in the stomach to prevent it from irritating the esophagus. Well, that's good for the esophagus, but it's not necessarily good for the stomach. And so proton pump inhibitors lead to a change in what the microbiome is in the stomach that may make a person more predisposed to developing gastric cancer. And this progression occurs sort of throughout. So what happens is the microbiome becomes less diverse. So there's, instead of having many different species, we start to get fewer, and they sort of focus more on the ones that are more likely to be pathogenic. So the H. pylori is, as we know, related to ulcer formation, but also an increased risk of gastric cancer. Ironically, if you have H. pylori, it actually protects you from esophageal cancer, probably related to the fact that the H. pylori leads to lower acid in the stomach. So it's a tricky balancing game that's happening. And that H. pylori takes the acid down. It also likes an iron deficient state. So in fact, it often will lead to iron deficiency, which is interesting. It sort of becomes the command center for your stomach if you have an H. pylori infection. It also then leads to less diverse microbiome, and it leads to ones that you lose the ability to metabolize nitrogen properly, and that nitric oxide is really damaging to the stomach lining. So I'm going to switch now to the genetic conditions. There are autosomal, I just want to kind of go over in general what genetics are. Autosomal dominant, which is what, like that condition I mentioned, which was the tylosis, is when someone inherits a mutation from just one parent, and they just have to have one copy of that gene being mutated that'll increase the risk. And so a person who carries that mutation has the potential that each of their children will have a 50% risk they're going to get that disease-causing disease-causing mutation. Most known hereditary cancer syndromes are autosomal dominant, and it may be that they have other ways that we get them that aren't autosomal dominant, but those I think are the easiest ones for us to see, because you'll see a clear sort of number of family members that are affected on multiple generations. And then there's autosomal recessive. Typically with autosomal recessive, what's happened is each parent carries a mutation, and that one mutation alone isn't enough. You have to inherit it from both parents. And in that case, the chances that a child, if they had both parents having that autosomal recessive mutation, would have a 25% chance of getting that disease. This is not specific for gender, so males and females have an equal risk if it's autosomal dominant. But I think a really important thing, and that we see a lot, and particularly obvious in our CDH1 mutation patients, is that with CDH1 mutations, we'll often have kindreds where the family members, I'll have a patient come in who's 35 with gastric cancer, has a CDH1 mutation. We test that person's parents. They have the dad may have the mutation but has not gotten gastric cancer. Or there may be relatives that have maybe so distant. And so that becomes really complicated for that, how to convey what that risk is for a person and for a family member to understand. And so I'm going to discuss a few other hereditary conditions that can lead to gastric cancer, and then talk a little bit more about hereditary diffuse gastric cancer. So FAP is familial adenomatous polyposis caused by mutation in this gene called APC. And people with that often get colorectal cancer, but we knew people had a higher risk of getting gastric cancer. We thought related possibly to some growth of cystic fundic glands, but what it also we're seeing is there's been this condition we didn't really know called GAPS, which was where people had gastric adenomatous polyposis. And it turns out it's actually a specific mutation, the APC gene. And those people seem to get more gastric cancer and don't necessarily manifest what we think of as FAP, which is multiple polyps in the colon, which also increase the cancer risk. Another one is Peutz-Jeghers syndrome, very rare. Those people might notice multiple sort of freckles or pigment on their lips, maybe around their eyes, on the palms and soles. They have an increased risk of multiple cancers. P10 hematomatous tumor syndrome, also sometimes you might hear of it as Cowden, predisposes to some other cancers, but also does have the potential for an increased risk of gastric cancer, as does juvenile polyposis, which can be caused by 2 different genes. When we talk about hereditary diffuse gastric cancer, that's caused by a mutation in the CDH1 gene. That is an autosomal dominant condition with the expression that we would expect a person who has that mutation, if they're a man, to have about a 63% chance, and if they're a woman, an 83% chance of developing gastric cancer by the time they're 80. People can start to, that risk starts to increase at about age 20. The optimal time to have your gastrectomy isn't at age 80. It's better to have done it at a younger age. I'm sure we'll hear more about how challenging it is to diagnose it. So I just want to share with you a patient I saw literally a month ago who found out her brother had stomach cancer, so she had her workup. They both have that CDH1 mutation. So she had her, she'd had an upper endoscopy. They went in and they did 80 biopsies of the stomach. They were reviewed here. Nothing showed anything other than maybe a little bit of cell atypia. And then I just heard back that she had undergone her gastrectomy, and she has stomach cancer. And so that's the danger with that condition, and why that one I think is one that we want to be very aware of. It affects young people, and it's a very difficult condition to have, and also has such implications for family members. And so I believe everyone who has cancer should get a panel test done or directed testing. I think it's important to think about that if you have any loved one who has cancer, because the implications can be so important for the family and for the patient themselves. So I think, you want a healthcare provider and genetic counseling team to carefully assess what your cancer risk is. See if there's maybe someone in the family's already been tested. I've had that happen quite a bit, where it turns out, my uncle had it. We didn't realize what it was. It applies to me. There's risk calculators that you can use, and it's important to choose a good test. And I just want you to be aware that the testing has really changed. It used to be we'd do one gene at a time. It was expensive. Then we would try to do the next one if the most likely culprit wasn't identified. And then that was called cascade testing. But now with next-gen sequencing, for a very reasonable price, you can get an Invitae panel done for $250 out of pocket is the max they'll make you pay. And it will test a variety of different genetic mutations. And because we're not great at always telling just based off what someone's diagnosis is, this gives us a wider perspective and allows us to find things that we weren't finding before. The multi-gene testing is cheaper. It's more likely to find a gene that's associated with cancer. It's maybe more useful, particularly in patients that don't have a particularly alarming family history. Maybe they don't have any family history of cancers. And, or if they're not clear, this looks like it could be this condition, might be that condition. Or if a lot of times people's families just aren't as big, or their knowledge of their family is just not as big. And so that's another time where that panel testing can be so beneficial. And the only thing I'd say as a caveat is, and I discuss this with all my patients, is your answers are going to come back either all 83 genes are normal, you don't have any mutations, or they're going to find a mutation. The most likely thing, if we find something, is going to be called a variant of unknown significance. And that to me is akin to like when you buy a desk to assemble from IKEA. You make the desk and you're so happy, it looks so good, and then you find that extra bolt. And you don't know if that bolt's going to matter. You don't know And so with the variant of unknown significance, that means we don't know, and time will tell. The benefit is that you will be contacted if that variant of unsignificance does become what we call pathogenic, meaning it could cause disease. And we don't recommend it if you know your family member has a CDH1 mutation, or if you so clearly have a condition, for instance, called Lynch syndrome, which I didn't mention, but which also can cause risk for gastric cancer. And then just to say, as we saw, younger people can get this condition. So I think it's important to be aware for the patient who may still want to be having children in the future. We know that the chemotherapy could have impact fertility, and there's lots of approaches for this. You can, for men, cryopreservation of the sperm. For women, embryo cryopreservation, even using oocytes that are unfertilized. For instance, if the person doesn't have a partner with whom they want to have a child at this point. Sometimes even because, as we've seen, I think from the case that Jennifer talked about with the family where people are getting this even in their teens, is that perhaps a young woman hasn't even gone through where she'd have oocytes that would be viable. So sometimes they can even do ovarian tissue cryopreservation. And then if you're taking certain types of chemo, they can give you medicines to protect the ovaries from failure. And I just want to stress again, the impact is so important for the familial cancer risk, because it might help a family member get diagnosed and get into the proper screening. It might lead to prophylactic interventions, say for instance with the CDH1 mutation, getting a gastrectomy before cancer develops, or being in a better breast cancer screening. It can lead to predictive genetic testing for those other family members. It might help guide chemo prevention or even chemo or surgical options. And then pre-implantation genetics, which is where if you know what a mutation is that you harbor, you can actually select to have an in vitro fertilization to implant an embryo that you know is not going to carry that mutation on. And I've had that, many patients have that done, and it's really been a big source of relief for them to know that their child won't have to go through what they went through. So just in summary, environmental and genetic risk factors, the majority of modifiable risk factors really are pretty much the same throughout the upper GI tract. Gender, meaning at the chromosomal level, is not modifiable. Race is not modifiable. Age is not modifiable. There are some socioeconomic differences. As I talked about, really gastric cancer is the one in which we know the most about the genetics, but for esophageal squamous cell and adenocarcinoma, it's very likely we see familial aggregates, but those genetics haven't yet been identified. So thank you for joining us and listening to that discussion.
Thank you, Dr. Boardman, for that great talk. I think I learned quite a bit during that. I hope all the other participants did. It's always nice to have it presented in a simplified and understandable manner, and the way that you laid it out was really beautiful. Thank you. Our next speaker is someone that I look up to. He joins us every Thursday morning for our esophageal and gastric tumor board. He always has insightful comments, and I think he's a tremendous resource here at Mayo Clinic. Dr. Ken Wang is professor of the Department of Gastroenterology and Hepatology here at Mayo Clinic in Rochester. He has clinical interests including Barrett's esophagus, esophageal cancer, and pancreatic cancer. He performs endoscopic interventions for early esophageal and gastric cancer. He's the Russ and Kathy Van Cleve Professor of Gastroenterology Research at Mayo in Rochester, where he directs the Barrett's esophagus unit and is involved in the care of patients with esophageal cancer. He performs research into early esophageal cancer, including the reasons why the cancer occurs in the first place, how they progress on a genetic basis, the effect they have on the surrounding normal tissue, as well as how they escape from the body's defenses. He's fortunate to have received funding from NIH for the last 27 years to perform his research, which is no simple feat. And clinically, he performs endoscopic procedures to remove these early cancers, essentially scooping the cancer out from the inside or peeling it out or burning it out. He's been a pioneer in bringing new technology to the United States, including endoscopic methods of removing these tumors. He's been recognized both nationally by the American Endoscopy Society with their highest award, as well as internationally, being made a fellow of the Japanese Society of Gastrointestinal Endoscopy. He's been the president of the American Endoscopy Society, as well as the International Society for Diseases of the Esophagus. He's published over 300 articles and has lectured extensively nationally and internationally on esophageal dysplasia and cancer. I hope you'll all join me in welcoming Dr. Wang.
Thank you very much for that kind introduction. I didn't realize we were going to go into depth on that. My talk is just about over, so don't worry about it. I also never heard such a great definition of variants in genetics and their significance. That was remarkable, Lisa. These are my disclosures. So I'd like to take you back. Most of you in the audience, at least here, are probably too young to remember this, but in the year 1960, which I remember, JFK was age 43, elected US president by a majority of only 113,000 votes. We tend to forget that. Average cost of a new house was $12,000. Think about that. Gasoline was 25 cents a gallon. A new car was $2,700. OPEC was just created, and 3,500 US soldiers were first sent to Vietnam, a place I became intimately associated with. Now, also in 1960, the fiber optic endoscope was developed, the very first time that a flexible scope was introduced into the human body to examine the esophagus and stomach. Now, just to be clear, there was endoscopy prior to this, but if you can imagine, it was a rigid tube. You can tell there's bends in the esophagus. So rigid tubes were actually dangerous because, you know, you'd have to bend people's neck back to try and get it down. So the flexible endoscope was a huge advance. And there was a lot of rapid features added. And I'm going to talk about how we use this to both diagnose and treat esophageal cancer that Lisa has so kindly given a very good introduction for. So we diagnose it, we can stage it, and we can even treat early cancers. Shanda and Travis are both surgeons who then deal with later stages of the disease, and I think we'll hear later from oncologists who will deal with even more advanced stages. So the common presentation, just to go over this, is usually a male individual, usually in ages about 60, and presenting symptoms are inability to eat, weight loss, chest discomfort. Usually, as Lisa was pointing out, the medical history is significant for obesity, heartburn, smoking, and maybe a family history of esophageal cancer. The endoscopy is performed and usually reveals an obstructing tumor somewhere in the esophagus. And the endoscope is required because we need to take pieces of tissue from that tumor, and there's usually no easier way to do this. This is what the scope looks like. And it's about 160 centimeters in length, and you can see that this is highly magnified. The whole thing is about 0.6 inches. So, you know, that's not actually looking like this, but this is the working end. This is what they cram in there. There are light sources. These are 2 light bundles. This is a CCD chip that allows us to see. There is water, air irrigation, and suction, and this is also our therapeutic channel. This is where we do all of our endoscopic therapy, through this little piece of a 1/2-inch tube. So, you know, everything we look at, and you'll see pictures, looks like it's monstrous and huge. In all reality, when we pull it out of the patients, it's like a letdown. You know, you see this little tiny piece of tissue and everybody goes, you spent hours getting that out? Yeah, but it's a cancer, you know. But this is what I'm telling you. This is what it looks like. Say there's a cancer here, there's an opening to the stomach, and we could spend a long time doing this one. We probably won't because this has a divot in it, which makes it probably unresectable endoscopically. We take little pieces of tissue. Once again, you know, when they show you pictures, it looks like we're using an excavator, but in real life, it's very tiny pieces of tissue that we take. You know, flakes, if we dropped it someplace, you'd never find it. They vary in size. There's pediatric size, adult, jumbo, and they vary in aggressiveness, which determines, you see some of these have teeth, some of them don't, but they're all very small. And they're also rotatable so we can get the right angle to that tissue. But that's how it's diagnosed. Sometimes you will get reports where the pathologist, who Dr. Chin will be speaking next, will say we just don't have enough tissue. And that's because these little tiny forceps can't grab hold well enough to get that specimen that they need. Tumors are firm. Normal tissue is fairly loose, just like on the back of your hand, but tumors are very firm, and it's hard to get enough specimens sometimes. And if you get that frustrating report, that's probably what's happened. So going back, just to review, there's two different kinds of cancers, and they're actually treated differently, especially, you know, in different parts of the world. The squamous cell cancer, as Lisa pointed out, is usually middle upper esophagus. Risk factors are usually smoking and drinking. That's pretty established. There's still a male predominance. Esophageal cancer, whether adeno or squamous cell, is usually male. I notice there's a lot of females in the audience, so you're all spared. Geography, squamous cell cancers are much more prevalent in Asia and Africa, but also in certain subgroups of the population in North America. There's a predilection in certain racial groups, and it's something to be aware of. It's the most prevalent form, though, in the entire world. I'm privileged to be a member of the Japanese Society. They see a lot of squamous cell cancer, and they developed a lot of the techniques we use today to treat esophageal cancer. Adenocarcinomas are much more common in the West. Western Europe and North America, we published a vast amount of literature on this. Although you'll see reports coming from Asia now because their diet has changed to Western diets, and they're also getting Western diseases. Usually this is located in lower esophagus, and as was pointed out earlier, it's associated with heartburn, it's associated with obesity. And once again, it's highly male dominant. It is increasing in incidence, although the latest figures seem to indicate it may be plateauing in the West. Endoscopically, these are the precursor lesions. Now, you can't really see it that easily on usual white line endoscopy, so oftentimes we apply iodine, something called Lugol solution. And interestingly, normal cells will take up iodine. Neoplastic cells, or as it turns out, a new squamous growth, won't take up iodine. So the voiding areas, you'll see this in some reports, Lugol's voiding lesions, areas that don't take it up, are usually suspicious for dysplasia. Because in order to find this, we obviously can't biopsy the whole esophagus with those little tiny forceps. We take selected biopsies, and this is what we use. This is the cancer. This is the pre-malignant condition. This is Barrett's esophagus. It's not a very long one. These little tongues you can see are readily apparent. This is normal squamous mucosa. This is the columnar mucosa that we would target for biopsies. In this particular case, you wouldn't need really too much because there isn't that much Barrett's there. But you can see in this case, there isn't a lot of Barrett's either, and there's a little tiny nodule which turns out to be cancer. Those are the things that are ideal for endoscopy because it's very small, we can get rid of it, you're in and out, you know, outpatient procedure, and your cancer is gone. That would be the ideal, that's what we're looking for the future. How do we use endoscopy to determine the cancer stage? Well, stage is really how far the cancer has spread. And that's critical for prognosis. It's also critical for determining what treatment you should receive. If the tumor goes deep, there's a high likelihood of spread, and then you get chemotherapy, you get radiation, and you'll see one of our excellent surgeons here. Lymph node status. Are there lymph nodes likely around the tumor or even further away? And there's lymph node stages go 0, 2, and then there's metastatic stage that we actually see, say, a metastasis in the liver or something like that. Obviously, more lymph nodes you see, whether it's in other organs, those are advanced stage tumors, some of which even preclude surgery, and you would be seeing our medical oncologists. Now, the endoscopic ultrasound was actually developed through a collaboration between the Stanford Research Institute, which is associated with Stanford University, and actually this institution. In 1980, it was first developed and reports came out. It was a linear array instrument, and it was attached to the body of the endoscope. That was the first report ever of this instrument being done. Ultrasound, of course, had been available before then, but attaching to a scope was something different. And this has subsequently turned out to be a useful tool in staging tumors because we're right next to the tumor. It's right on the scope. We can actually see the tumor relatively well. But to be honest, for these very early stage cancers, the one I showed you with a little tiny dot, the ultrasound is it's hard to tell if that tumor actually penetrates 2 millimeters into the mucosa versus 1. You know, you're talking about the thickness of the white of your fingernail. That thin. Women may be bigger than that, but very, very thin amounts of tissues, that's all that's involved. So that makes it difficult, but it's good for regional lymph nodes. And we use it because its strength, like I said, some T-staging, lymph nodes. We can also perform fine needle aspirates or biopsies of these lymph nodes. So if we suspect they're positive, we can actually get the tissue out and have the pathologist confirm that. We can use high resolutions. We can change the frequency, which allows us to see deeper or more shallowly to determine staging. And this is just some numbers. It tells you what the sensitivity specificity is. And you can see sensitivity isn't high for T1 cancers. You know, we're just not that good to be able to discern it. And you can see it's looking at shadows, which is often very boring, even for physicians. This thickening here would represent a tumor. And you can see it kind of extends from here to here. It does not involve the depth to the muscularis propria, which is here. That's the outer layer of the esophagus. So this is probably a submucosal cancer. It penetrates not that far. We would probably take it out endoscopically, but it might penetrate deep enough that more therapy might be required, even surgery if it got deep enough and had signs that it had spread. Even though there's no signs of it clinically with PET scans, CT scans, and so forth, you still might take it out just because there's a high risk of spread. They talk about lymph node stations. You don't need to certainly memorize all of them. Lord knows we have to. But you have to, you know, there's a whole bunch of stations of lymph nodes that refer to where they're located. So our surgical colleagues, our radiation colleagues will know where to channel their energies when it comes to that. But if you look at reports, that's what you'll see. That's what it means. There are involved or suspicious lymph nodes. Now, like I mentioned, the endoscopic ultrasound is actually able to take a needle that goes out of it and stab something like a lymph node. This is actually the celiac plexus, but if there was a lymph node in that area, we could FNA it. This is what a lymph node looks like. It's a little round ball. And usually malignant lymph nodes tend to round up, and we can see them. Now, other things we can do, people with cirrhosis or liver disease, things like that, we actually can also do Doppler ultrasound, and these are blood vessels around the lesion. Obviously, we can try to avoid those or design our approach with the needle to avoid these blood vessels. How accurate are we? This is a recent meta-analysis of over 1,019 patients, 19 studies all had ultrasound followed by tissue confirmation of depth. Sensitivity specificity in this study was actually fairly high. The meta-analysis shows sensitivity and specificity of over 85% for early stage cancer. And these likelihood ratios, just kind of the odds that it's true, are fairly good as well. Now, one thing you might wonder, we do multiple tests to stage cancers, and a lot of them do the same thing. You wonder, why do you need so many? And the problem is that no single test is that good. Ultrasound's good for regional disease, but it can't tell you if there's a metastasis in the bone, which the CT PET scans can show up. But if the CT PET is totally negative, so this is no negative patients, 117 of them, EUS was positive for metastatic disease in 33%. So a third of those patients that had negative CT PETs turned out to already have metastasis on ultrasound. And that's what happens. Patients often think you gotta have made a mistake, right? The CT PET was negative, I'm clear. It's clear to a point. Nothing is perfect, and it's something patients have to be aware of. And it's why we do multiple testing to see if we can pick these up. Because obviously, if you have lymph nodes, as is shown in the survival curve, it makes a big difference. You do not live as long. So, and your therapy would change. If you didn't have lymph nodes, the surgeons could take you directly to surgery. And one thing to keep in mind, and this is just to show you how technology changes, early CT scans, back in the day, 16-slice CT scans, which aren't even found anymore except for in museums, this is what it looked like. Now we have 64 slice, and we have continuous slice spiral CTs that give you just absolutely unbelievable resolution. So sometimes when you go on the internet and you Google CT scan, you'll pull up studies that don't look very good, but they're from a long time ago. And technology has changed quite a bit. So, as patients, you have to keep that in mind. A study in 2012 that showed this is unlikely to be accurate in 2021. So something to keep in mind. Same thing with ultrasound. This is what, the bland blasé FNA was before. This is using elastography, which we now have in our ultrasound machines, only in the last few years. And you can see high density areas that we might target are totally oblivious in this one. You can't tell, it's all the same. Here you can see the tumor, which is actually all through here. We can make variations out of that, and things have improved. So, that's the other thing. You can't trust Google entirely. Maybe not at all, but that's something else. We also have other technologies, volumetric laser endomicroscopy. It's a fancy term. It allows us to actually see the really superficial disease. Instead of using photons like in CT scans or gamma radiation, we actually use light. This uses infrared light. It actually pulls back. It's designed for the esophagus, and it can scan 8 centimeters of esophagus, and it takes 1,200 cross-sectional images, much like a CT scan. So 1,200 slices in 8 centimeters, which is roughly like 4 inches. So we get a pretty detailed view, and we can lay it out so that, we can get a 3-dimensional view of this. This just shows you what it looks like. Normal squamous mucosa looks like this. This is the muscularis mucosae. And this is about at the level the pathologist can see it. And we also see some areas of buried cancer. This is a cancer here. And the thing of it is, to the optical system, our usual endoscope, it looked normal. But underneath it was cancer. We call this buried cancers because there's this layer of normal squamous epithelium. And often we're asked to look for these because, like in recurrent cancers or things like that. Areas of dysplasia, which Lisa talked to you about, Dr. Chin will follow up. They're kind of oblivious to the endoscope. It's hard to see them. But this can show the glandular structures underneath them. And this area here with a lot of like Swiss cheese type effect, that's an area of high-grade dysplasia that we can target. This system's kind of cool. It's almost like Star Trek. You can press a button and actually 2 laser beams shoot out and mark the tissue because, like I said, you can't tell it visually that anything's wrong. And then the laser actually puts 2 dots next to it so you can tell where that region is for further therapy or biopsy. So the endoscopic treatments, they vary. Part of this comes from the fact that squamous cancers, especially in Asia, have been shown to metastasize more, spread earlier than adenocarcinomas. You know, if you have a squamous cell cancer, the treatment of choice in Asia is resection. They will go to it and they'll remove that area, carefully dissect out anything that looks abnormal endoscopically. It's not necessarily what's done in this country because A, we're not that experienced with resection. Well, in particular, the technology hasn't quite transferred 100% here yet. Certain centers, and that's one of the efforts I've done when I was in charge of our endoscopy society, was to bring this over to this country. And there's a number of centers now that do it, but in Asia it's routine. And it just bothered me that we had 2 different standards of therapy depending on where you happen to be in the world. Radiofrequency ablation has been used, especially if there's extensive dysplasia, like everywhere. It's uncommon, but that's a cautery device. You basically can burn the tissue. And then cryotherapy, which is a freezing technology. You can see the reason we have technology is because they don't all respond to one thing. Well, generally resection's relatively foolproof because it's cut out. But with ablation and with cryotherapy, if one doesn't work, we usually switch to the other. And cryotherapy is one of my personal favorites because it doesn't hurt. Thermal therapy, people have pain afterwards. Cryotherapy usually doesn't bother you. I would take the fact that you're here, that you're used to winter, and you guys know if you get a frostbite, bad things happen, but it's usually not too painful. Barrett's esophagus, on the other hand, the precursor to adenocarcinoma, is predominantly treated with radiofrequency ablation or burning. If that fails, cryotherapy, and if that fails, then we go to endoscopic resection. So it's almost reverse order compared to squamous dysplasia in this country, well, in the world. One thing we like about resection is we get more definitive diagnosis as to staging. We actually get our pathologists like Dr. Chen to look at the specimens and tell us how deep it went and did we get it all. One problem with just burning or freezing tissue is you really don't know. You've treated the mucosa, things look like they've gone away, but you don't know. Things like buried tissue that you didn't quite find, things like that is a problem. So we tend to be very careful about that. But endoscopic mucosal resection or endoscopic submucosal dissection, which really just matters because of the tools we use and the size of specimens we can collect, are pretty accurate. And this was a series of patients, 7 patients treated with resection followed by esophagectomy, actually surgical removal, and there was only incorrect staging in 1 patient. It's a safe technique. This is my personal data from a while back, about 8 years ago. We had done 1,388 mucosal resections in 681 patients. We had no perforations. In other words, when we cut through, we didn't cut all the way through, which is always the problem. And we only had 1.2% bleeding afterwards. Only 1 of those ever ended up at surgery. It's really helpful in diagnosis. This was a case which ordinarily you would assume should go to surgery because the patient had trouble swallowing. Difficulty swallowing is usually associated with later stage disease, not early stage disease. But what was weird was this was like a really big polypoid, like a marble in the esophagus. And that was what was causing the problem. It hadn't really grown all over the place. It had grown in, and we were able to cut this out using endoscopic submucosal dissection. There's tons of tools from these. They all come from Japan because, like I say, that's where this technique was developed. And the reason you use these is one, personal preference. All of these are named after the professors that developed them, except for maybe this one. And you can cut this out, and you can see we can just, go around it, cut the tissue out, and then you can send that to the pathologist. And it turned out it was an early stage cancer. The patient didn't have to go to surgery. And that's a nice thing for the patient because they don't lose their esophagus. Of course, our surgeons may feel differently. Articulating knives, we find, are easier. This is something I've worked on for a while now, and these are all publications from our group. Basically, they're scissor-type devices. One of the problems in this country is we don't get as many early cancers as they do in Asia, because in Asia, they actually screen for early cancers. That's not actually recommended in this country because the incidence of disease is low. So, when that happens, if you try to screen, you end up with false positives, you end up with, unnecessary procedures, worry, when you don't really have to have this done. So the articulating knives, I thought, was one of the things we should bring, because in areas where people aren't that familiar with this technique, it's easier to apply. So we've looked at it. It's easier to use in novices. It's safe, hardly any complications. And also, in Asia, it's kind of interesting. If they have a resection done, the patient stays in the hospital for a week. Now, why is that? Obviously, patients get the seriousness. This is a big deal. But reimbursement in Japan is tied to time in the hospital. So, if they keep the patient a week, they get paid more. So that's one of the reasons. So here, we naturally adopted their techniques, so we also adopted this habit of keeping them in the hospital. Once you start adopting that, it's hard to break it because, you think you're taking a big risk. But we found out that we could, and now our practice is not to keep them even overnight. It's an outpatient procedure because obviously in the States, we get paid less if they go in the hospital. This just shows you us cutting through. It looks kind of brutal and ugly, but like I said, if you look at that scissor device is maybe a 1/4 inch long, so it's very tiny. And this just shows a case where we use these technologies. This is a lesion that's actually submucosal beneath the epithelium. And this is what it looks like on endoscopic ultrasound. You see this funny looking thing with all these little holes in it and stuff? Well, we had the same reaction, probably everybody did. What the heck is this? But it was in a location that was not normal, and we elected to try and remove this. And this just shows the endoscopic submucosal dissection. We inject fluid underneath it. We cut through the skin so we can see the submucosa. And like I say, these are millimeters we're talking about here. This looks much worse, but it's actually fairly small. And we just, cut our way through with this articulating knife. And the nice thing about this particular knife, one reason I like it, is because you can cauterize and cut with it. So, you can take care. You notice there's no blood in the field. Ordinarily with this procedure, you get a fair amount of bleeding. But because I can cauterize with it, there's essentially no bleeding. And I can just dissect underneath that lesion. It's actually, the lesion is, well, obviously it's right here now. But we just tunneled underneath it, we took it out, sent it to the pathologist. It's all encapsulated. This turned out to be an esophageal adenoma, which was buried in this area. It's kind of cool. That's maybe the second one I've ever seen. The other thing we can do if things get bad is we can actually take out the whole wall. And there's devices for this now. I won't get into too much detail, but you can basically place a metal clip and strangle that lesion and then just cut it right off. And this is actually the colon, and you can see double thickness of the wall there. And that's actually a full thickness resection. So that's doable. Unfortunately, most patients that present have, like I said, trouble swallowing. So sometimes if they're not going to undergo if they're not going to go chemotherapy or radiation soon, we can palliate them with a stent. That's usually what we do. And what a stent is this little tube here that's put in, and it's not fully expanded. We release it and it gradually expands and allows food to pass through. There are downsides to it. Obviously, as it expands, there's pressure and there's often discomfort with that. And the other problem is food can easily reflux then through that area. Oftentimes, these go through the gastroesophageal junction, and that means you have no sphincter, so people can't like bend over or have to be careful how they lay. So there are some negatives to it, but it certainly helps in eating. Cryotherapy is also done for palliation. You can see it here, freezing tissue. And there's a balloon type cryo device as well that we can use to treat Barrett's esophagus. It's fairly effective. So in summary, esophageal cancer is suspected based on symptoms, on imaging scans, on endoscopy, and it's proven with biopsies. We need to determine how far it spread with staging, and endoscopically, we apply endoscopic ultrasound. We can treat early cancers with resection, and if there's advanced cancers, we usually palliate with some ablative mechanism or with a stent. Thank you.
Do we have any questions for Dr. Wang?
No questions. I think we'll wait for the Q&A session.
Okay. Thank you, Dr. Wang. I think I've made it pretty obvious, but if I had esophageal cancer, I would want Dr. Wang to be scooping it out from the inside rather than me or Dr. Grotz taking it out surgically any day. Our next speaker is Dr. Chen. Dr. Zhongming Eric Chen is SAC in the Department of Laboratory Medicine and Pathology and Anatomic Pathology Division at Mayo Clinic here in Rochester, Minnesota. He's associate professor in the College of Medicine. His clinical interests include gastrointestinal pathology, liver pathology, and pancreaticobiliary pathology. He's a surgical pathologist who specializes in the diagnosis of gastrointestinal, liver, and pancreatic and biliary diseases and cancers. He's also active in research and education. His research focuses on the application of immunohistochemistry in the cancer diagnosis and predictive biomarker evaluation. He has over a decade of clinical experience, and he's published more than 60 peer-reviewed articles and has written more than 12 book chapters and co-edited 2 textbooks in the field of this specialty. Thank you again, Dr. Chen. We're really looking forward to your talk as well.
Thank you. Thank you for this opportunity, and thanks for Dr. Boardman and Dr. Wang's previous talk to elucidate pathologists' use in cancer treatment and cancer care. I have no disclosure. So I really appreciate this opportunity because pathologists are usually working behind the scene and to help patients directly to understand the pathologist's report is really a fundamental thing that I think we should do more often. So I will quickly introduce pathologists. I am one of them, the role in cancer treatment team. And I will briefly talk about how pathologists actually make their diagnosis, and then spending most of the time talking about the jargon, but those are the important terms and concepts of cancer-related diagnosis, specifically the cancer classification, grading, staging, and predictive biomarkers. As I said, working behind the scene doesn't mean that we are not constantly contacting surgeons, oncologists, and gastroenterologists like Dr. Lisa Botman and Dr. Wan. The role for us is to examine the tissue removed by surgical procedures, either resection or biopsies, and to be able to determine the precise type and severity of the cancer, and then provide that information and discuss the possible treatment therapy. In order to describe a little bit how we make the diagnosis, so I want to take you through a journey. Basically, after the tissue come out from the endoscopy suite or examine or from OR, operating room, the tissue arrived to the lab and how that is being done through the lab. Basically, there are several steps going through for pathologists to make a diagnosis. We have to do a gross examination, we have to do laboratory processing, and then finally do histologic examination. I will take you a little bit deep into each step. For a little biopsy, they may be very small, smaller than a grain of rice. We don't really have much to look for at the gross level. So those will be put into a cassette and sent to for further processing and mainly examine them on the microscope. But for a large specimen, for a resection specimen, the gross examination is a critical part of pathology evaluation. And this has to be done in a very, by very highly trained professionals, because not only you want to recognize the tumor and its relationship with the very important anatomical landmarks. For example, here I show a specimen including part of the esophagus and stomach. And for person to take care of this specimen knows a lot about how normally they should look and what is the parts that is abnormal and how they are related to. So this is a very important process, and we usually slice tissue into very thin slices so that we can look both inside and outside. And for example, like Dr. Boardman mentioned about some of the tumors that are very difficult, early tumors, for example, CHD1 mutation patients, that you cannot see them, obviously. So obviously those tumors needs to be even more carefully examined. These tissues are sampled and put into a process, which we call them laboratory processing. So it's a very complicated process, but the tissue goes through a lot of chemical reactions so that then the tissue water content in the tissue is completely removed. And that tissue, including DNA information, will be preserved and can be examined for example, decades later. And the tissue can also be, in that processed tissue, orientated and put into a cassette and in a paraffin block, and then we slice them into very thin slice, only micron, 3 or 4 micron thickness, and put that slice on a piece of glass and put them through a process called staining, because we need to have some dyes to allow us to observe cellular details under microscope. The end result of this is basically a glass slide with colorful tissue on them. Histologic evaluation is the key, and that's often done under microscope. And in the near future, this information can be digitalized. It's called digital pathology. And so that will have new impacts, because, for example, the procedure was done in Florida. The sample was processed there. At the same time, if the image is digitalized, someone in Minnesota, Rochester can look at it right away. And this also provides a foundation for later on, if there are more artificial intelligence-based algorithms that can increase the efficiency for pathologists to make accurate diagnosis. On the right side is what we observe on the microscope. So this is done by two stains, two dyes. One is hematoxylin, one is eosin. So that's called H&E histology. And each blue dots on there is a nucleus of one cell. And the pink things around those blue dots are the cell cytosomes. So the cells are arranged in such a way that it's very, very organized. They work in a very organized microenvironment and produce different cell types get together and produce a physiological function. This pattern is called histology. And pathologists are trained to recognize this pattern. In fact, thousands of these patterns, so that they can tell literally any parts of the body, tissue from any parts of the body, whether it's normal or abnormal. And it's this capacity or capability, skill, lets pathologists to be able to tell different types of cancer. So here I showed you different types of cancer: adenocarcinoma, squamous cell carcinoma, neuroendocrine cell carcinoma, or tumor, lymphoma, and sarcoma, and so on. But I want to get into a little bit detail to tell you how we will be able to tell them apart. For example, Dr. Wang had two patients, patient A and B, both have esophageal cancer. Took a little bit tissue from them and processed in the laboratory. On the microscope, although maybe under endoscopy, they look similar. On the microscope, they can be very, very different. As you can see on the left side, patient A had a tumor that cells line up on these lacuna space, and within the space, there are mucin. So this is an adenocarcinoma. On the other hand, patient B had a cancer that have these cells forming these little nests, and more clearly, there are these pink material. The cells produce pink material, and these are the same material that make us up your nail. We call them keratin. So this is squamous cell carcinoma. In gastric system, gastrointestinal system, the majority of cancer are adenocarcinoma, squamous cell carcinoma, neuroendocrine tumors. They are carcinoma category. Lymphoma, sarcoma, and others, including melanoma and others, are rare. Now, when the tumor stays in the place where it starts, grow in the place it starts, that's called primary. When the tumor spreads out to distant area, that's called a metastasis. Within a tumor, depending on the types, the morphology, the shape, and the composition of cells, we actually can tell that tumor may be worse behavior than some of the other tumors. And this concept is very important. It's called cancer grade. And this is, in fact, 100 years ago, a surgical pathologist in Mayo Clinic, Dr. Albert Broders, first initiated this concept. And it's truly a remarkable milestone in terms of cancer diagnosis, because he made the observation and he developed a system. It's a numerical system, and he graded cancers from the least to greatest malignancy. And here I show you several pictures of all squamous cell carcinoma. And the cancer that look like normal tissue, very similar to normal tissue, is well differentiated or grade low, so it's grade 1 on the left side. The tumor that composed of cancer cells that look very different from normal with necrosis, and that's high-grade cancer. And usually, high-grade cancer, they exert aggressive behavior. Something in between is moderately differentiated. So next time when you look at the path report, usually they will tell you well differentiated, moderate differentiated, or poorly differentiated, or high-grade cancer. I'm glad that both Dr. Boardman and Dr. Wan already elucidated into this important concept, dysplasia. Dysplasia is a precursorous condition. Before a full-blown cancer developed, there is a process, and this process can be illustrated here. So this is the example of Barrett's esophagus becoming low-grade dysplasia, becoming high-grade dysplasia, becoming mucosa, intramucosal adenocarcinoma. So this process, since you can see from the picture, they are different under microscope. And for trained eyes, they can tell them apart. And each stage means something different during the process. So we roughly put them into 3 categories. When it's only Barrett's without dysplasia, that's benign. Barrett's with dysplasia, that's transforming into cancer. And Barrett's obviously can develop full-blown cancer when the tumor cell starts to destroy the tissue and try to invade and spread. Histology is the basis. It's very powerful, so we can allow pathologists to tell a lot of things. But histology is not enough to, in certain circumstances, to accurately for cancer classification. And for tell primary cancer from metastatic cancer, which I will give you an example, or assessment predictive biomarkers. And it's not tell us whether it's a hereditary cancer syndrome or not. So we often rely on more advanced tests that we can put them down on tissue. So these include immunohistochemistry, in situ hybridization to look at DNA change, RNA change, electron microscopy to blow them up really high to see the subcellular level changes, and more often molecular changes that both Dr. Wan and Dr. Boardman already alluded today. I want to take a little bit time to talk about immunohistochemistry. So this is a unique technology where we utilize antibody-antigen binding capacity. That's a very specific immune property of antibody can recognize of something very, very specific, say example, a protein, and utilize that property, put them on the tissue so that we can label the cell to know whether the cell has one particular protein expression or not. And then do chemistry to enlighten that area so that become visible to us. So this is why called immunoprotein recognized by antibody, histo on the histology, and do chemistry to let them be able to seen by pathologists on the microscope. Give you an example. So this is a patient that has a gastric ulcer, and when Dr. Wan or his colleague looked at it, looks very malignant appearance. So take a tiny little specimen and send to pathologist. And under microscope, you can still recognize some residual stomach tissue, but majority of it is replaced by this malignant proliferation of cells. Now, based on looking at this, I would tell you that this is a malignant cancer, but I wouldn't be able to tell you whether this could be a gastric cancer, could be somewhere else. So what we do for this situation is to do immunostains. So look at the protein expression pattern in this particular tumor. And here I show you one particular stain. It's called a GATA3. It's a protein that does not usually express in gastric cancer. So in this case, when we apply this technology, we see there are cells. These are, in fact, little brown dots are nucleus of tumor cells, and they are positive for this protein expression. Based on that, we think this is not going to be a straightforward gastric cancer. In fact, a combination of many things together, we think and make the correct diagnosis. This is a metastatic, poorly differentiated carcinoma. We call it urothelial carcinoma. It's a carcinoma from the bladder. So it manifested as a gastric cancer. Cancer staging, Dr. Wen already mentioned, it's so important. It's basically determining the size and how far it spreads. For example, in here, there is a tumor growing in the stomach. The tumor starts and then destroys the tissue, and single cells may come into vessels, lymphatics, and they will spread out to the lymph nodes and even spread out widely throughout the body to, for example, distant organ, liver. When the tumor is localized, it's relatively early stage. When the tumor spreads out to the regional lymph nodes, it's still intermediate stage. When the tumor completely went out. So you want to catch tumor before it goes out. Early prevention, early intervention is the key for curing cancer. We use a standard system. It's called a TMA cancer staging system. So T for tumor, so that includes information from the tumor size, grades, and other important things, how deep the tumor goes into the tissue. N for lymph nodes, and M for metastasis. So for a tumor that when you look at your path report, they may tell you a T1, N0, M0. So that means the tumor is very early. It's a small tumor, that's not deeply invasive. Lymph nodes 0, no lymph nodes metastasis, no metastasis into distant organ. So that's a localized tumor. Now, again, it's so important to stage in such a way because gastric cancer, if you have a very advanced stage, maybe you have very little chance to make 5 years. But on the other hand, if it's localized, you have 70, 80% of making 5 years with proper treatment. Here shows you how we detect cancers in the pathway to spread out. They can show in this picture, this is cancer, a nest of cancer cells, but what it is, the location of this nest makes it unique is because it is in this lumen, and this lumen is a lymphatics. So by looking at this picture, we know that the cancer already has reached to the lymphatics, and there is a chance that this can already spread out. In this case, this is a different cancer, but this cancer gets into this particular location, which is a vessel. So that means this tumor can spread out through vessel and spread out to the different parts of the body. We routinely sample lymph nodes in resection specimens. We dissect them carefully, we collect them, and individually sample them. And you can see some of the lymph nodes. So this is the lymph node structure. There are lymphocytes and all these things, but partially replaced by something shouldn't be there. And this is the cancer. So this is a cancer-involved lymph node. Sometimes the cancer can be very, very tiny. So for example, here, the lymph node looks okay, but only after you carefully examine it, you start to see a tiny little focus of tumor cells. And that is an indication that there may be tumor spreading out. Now, in certain cases, more and more patients get treated, neoadjuvant therapy, and so on. So when this resection specimen come to us, there are lymph nodes that look abnormal. But when we take a close look on the microscope, there is no tumor cell. But what happens is leftover mucus material in there. Based on that, we know that previously there was tumor in this lymph node, or this would be an indication that tumor has spread out. This would be an example of a liver, and here is the normal liver, but it's replaced by something that supposedly shouldn't be there. And by immunohistochemistry, again, a different marker, we can tell what type of cancer spread into liver. And in this particular case, it's a squamous cell carcinoma that spread into the liver. Resection margin is a very important parameter because that assesses the completeness of tumor removal. So here I give you an example that Dr. Wen talked about, submucosa dissection of early stage tumor. So this is what happens after the specimen processed, put them under microscope. You can see that the cancer is here, these little space, and this is the place where the deepest the tissue are. So that's the resection margin where Dr. Wan showed that how that was dissected out from the esophagus. And I give you two circles here, one on this side, there is tiny ink here, and then one on this side. Side by side, you can tell that on the left side, there are tumor cells right touching the ink, which is the deepest side of the dissection. On this side, the tumor cells is far away from the deepest side. So for this, that means the status of the margin is involved. So that has the implication that there may be still leftover tumor beyond the point of dissection. And that has clinical treatment implication. So when it's completely removed, it's R1 resection, and if it's positive, there is a chance of residual cancer. I want to just get into the predictive biomarker assessment. So these are molecular changes happen to the tumor that we can detect and test for the probability of this particular tumor response to novel therapies. Currently, for gastric cancer, esophageal cancer, we test Pdl-1, we test HER2, we test a protein called DNA mismatch protein. And Pdl-1 clearly for immune checkpoint therapy, and HER2 for HER2-related therapy, and DNA mismatch repair proteins that can be also used as indicator because most of these tumor will respond to checkpoint inhibitor therapy. But on the other hand, this is also a very powerful tool to screening for one specific type of hereditary cancer syndrome. Here we show you one example of Pdl-1 expression, and you can see that the tumor cells are positive, and we have a formula that we can calculate out certain scores, and based on the scores can make a prediction whether the tumor is likely to respond or not. Want to spend a few minutes on this DNA mismatch repair protein, which is an important protein that helps you to correct the DNA DNA repair mistakes. And if it's missing, in this case, you can see the positive cells are having this protein, but the tumor cells are not having this protein. So the tumor is missing this capacity. And that is important because maybe this information will relate to Dr. Boardman, because for particularly this particular loss will indicate that maybe there is a chance that the patient has a Lynch syndrome, maybe further investigation needed. And also this particular tumor is likely to be able to respond for immune checkpoint therapy. So what we did was spend some time talk to you or explain the terms and concepts in pathology report. Cancer classification, cancer grade, dysplasia is a very important process. We can recognize early cancer, cancer staging, resection margins, and predictive biomarkers. Pathology report is summary of these information. And usually it has a final diagnosis component. It has all the information. And very importantly, there is a cancer staging information nowadays. We usually provided a synoptic format. Basically, this helps us. It's a checklist format so that ensure no matter where, what pathologists, they are doing the similar thing. Standardized terminology, and also in the future, this can be utilized for data analysis to discover new therapies and new treatment. That'll be it, and thank you again for letting me to explain how pathologists work.
All right. Well, thank you, everybody, for your time and attention, and thank you especially to Drs. Boardman, Dr. Wang, Dr. Chen. It was a very engaging and informative morning session. We'll take a quick break now, and then come back at 10:15. We'll have a patient panel up here to be able to talk a little about their story. And we'll also have the previous speakers come up here as well. So if you have any questions, bring those questions, and we'll have them field that. Thank you very much. Thank you. That was really good. Yeah, appreciate it.
I
Yeah.
was just trying to.
you talk into it, okay. And make sure you don't hold it like this. Please hold it like this. And then just don't hold it like this. Please hold it like this in front of your mouth.
Ask everybody to take a seat if they can. And then we have the privilege and honor to have three patients be here to share with us their story and maybe answer some questions, maybe from the patient or family caregiver kind of aspect of it. So I'll introduce. We have here to my left is Brooke, and then Brooke, and there's Gabby, and then Colt. And so, Brooke, why don't you just give us a little brief introduction to kind of your story and how cancer has affected you?
I am a 42-year-old hairdresser that had a client talk me into doing genetic testing due to the fact that my mother died at 50. I was 21. I kept avoiding it, and then finally I went ahead and had the genetic testing done. Come to find out, thinking that my mother died of breast cancer, that I would at least have BRCA1 maybe. It came back as CDH1. We do not have a history of gastric cancer in our family. We have colon, lung, breast, and then upon that, I was sent to Mayo Clinic where they told me I needed to have, could have a total gastrectomy or surveillance. I chose to do the total gastrectomy.
Thank you. And then Gabby?
I have a kind of similar story. I am an area native to the Rochester region, but I was the first in my family after my dad got prostate cancer to go forward with genetic testing. And we thought BRCA2, prostate cancer, breast cancer, it fit the profile. And it came back as CDH1. I was already here, so it made things a little quicker to get shuffled around. I had appointments with Dr. Boardman. I had appointments with Dr. Kendrick, who will speak later today. But now I'm 3 years post-gastrectomy. I had a mastectomy as well, and doing well from a preventative standpoint.
And I'm Colt Blunt. I was diagnosed with stage 3 gastric cancer it was on June 20th, 2019. I originally thought I just had some heartburn secondary to eating some bad cheese. Long story, it was cancer. And it came out of nowhere. I was healthy, I was in good shape. I had a family history of cancer, but it was not genetic apparently. I was very fortunate though to have a great response to FLOT chemotherapy, and I had a total gastrectomy almost 2 years ago now.
Great. Well, people think of some questions. Kind of a question for Gabby and Brooke. I think when you hear that you have, CDH1 mutation and you have a high risk of getting stomach cancer, I think obviously one of the challenges I think for all patients is just obviously the shock, and then you have a very normal functioning stomach, and how do you kind of prepare yourself, or how did you go through the process of, you almost kind of have to grieve, right? You're going to lose your stomach, you're going to lose a part of you. How do you kind of prepare for the procedure and for life after surgery?
I don't think you can prepare. I had anxiety until I got out of surgery. But the reason I did it is because I have 2 young children, a 15-year-old and a 3-year-old, both daughters, that I do not want to watch them go through cancer. I don't want them to lose their mother young like I was. And I am only 7 months post-gastrectomy and doing great.
I don't have children that I did it for, but I was kind of the first in my lineage. I was the first one that we found out that had the mutation. I had a lot of naysayers in my family, but in my head, I had thought with all the breast cancer in my family that it was probably something genetic. So it was easy for me as soon as middle school to know. I thought, ticking time bombs, cut them off, get it done. And when it came to the gastrectomy, it was a total shock, and a couple years ago even, there wasn't a lot on Google that wasn't misinformation. So I thought I'd never eat a raw strawberry again. But I felt kind of this pressure to set an example for my family, and I did really well with recovery. So for me, it was kind of helping everyone else navigate their way.
And I do have to say, I was the first in my family, and I didn't believe that I had it. I thought they were wrong. Since my sister, who is 3 years older than me, she tested, she had her gastrectomy October of last year. So she's 3 months ahead of me, but she was also positive for CDH1.
Yeah, and when you can't predict it. So I find out on the lagging end with doctor's notes and whatever, my breast physician had asked for a retest. My geneticist asked for a retest. I think Dr. Boardman asked for a retest just to make sure, due to the lack of family history that we found. But in less than 6 months after I was diagnosed, I lost a family member to gastric cancer, and found out he was a carrier as well. So you never know.
Any questions in our audience at all? Yeah.
Can you see, having now gone through this experience, from the standpoint of what we're providing you for care, were there things that would have made it better or easier for you to, be prepared? Were there things that you felt like maybe if you'd gotten an answer that would help? I mean, we know it's a horrible thing to have to be going through. I don't think we're always that gifted on how to communicate to the person who's going to experience it. So I would like to hear your feedback on that.
I feel like mentally I was a little more prepared for it than my family, but I was young, 20. My dad came with me to my appointments, who's the one that I ended up getting the mutation from, and a prostate cancer. He was going through his prostatectomy recovery when I had my appointments. I think that as a patient, I did okay. I think I got the information I needed. I was great. Caregivers, though, I think not always are so quick to adjust or adapt. I know my dad was like shouting with you in appointments, trying to say you were wrong or you were crazy about the recommendations. But for me, I felt comfortable. I actually felt really okay, and I adjusted quickly. It was that.
And I was pretty fortunate. I had Dr. Grotz as my surgeon, and my sister had Dr. Kendrick. So watching my sister go through it, and Dr. Kendrick, he explained, you can live with, well, Dr. Grotz too, and my GI here, you don't need a stomach. You don't need it. It's just a reservoir to hold food. So knowing that, I played that through my head. The hardest part was Google, which we probably should stay off of, and the support group where everybody tends to be a little bit more negative. I think everybody did great going through it with us, letting us know that letting my sister and I know that we can live without a stomach, and I live a completely normal life. I do have a few road bumps, but for the most part, I can't tell I don't have a stomach.
The best advice I got during my journey was from Dr. Kendrick, who said, don't listen to the people who are still on the
Amen.
Facebook group, because the people who are posting regularly are not the ones who are doing well. He said, you'll notice not a lot of my patients are posting regularly. And I said, you're right. It's a good thing.
It is true.
And now 2 years out, I'm not posting as frequently as I was after my surgery because I'm doing well. So not to put so much weight on what you see, because it's probably not what you'll get.
It's the Yelp effect.
Yeah.
People don't complain. They don't talk about a restaurant unless it's bad, usually.
Yeah, exactly.
Unless it's really good, and then they might say, well, yeah.
I go there.
Nothing in between.
And
Cool.
I just wanted to add, we have Mayo Clinic Connect, which has just opened up a section for patients with esophageal cancer and gastric cancer. We noticed that social media had a lot of incorrect things, and no full-time person is ever responsible for monitoring what goes on social media. And so we actually do try to make sure that the things that get shared on Mayo Clinic Connect allow patients to share notes and suggestions and stories with one another, but at the same time to make sure that it's factual and accurate and not disseminating urban legend. So Mayo Clinic Connect is a new way that survivors and caregivers can connect with one another, but it's sort of like the socially responsible social media that allows people to get in touch with one another. And that's been really helpful. I've just started engaging with that group to try to serve as a monitor to help provide information. And I think that's really important.
And you know, I actually have to have a stent and my connection put in on Monday. And the one thing I asked Dr. Kendrick this morning was, is it that painful? Because I put it on the group asking if anybody else had had it, and they tell me, don't do it, don't do it. Well, you know, I think I need to have it done. And like he said, everybody is different. So the people that were answering are the ones that had the issues, had the problems, telling me not to do it. I know what I need to do going forward. And for the most part, like I said, I feel great. So,
And you'll probably feel better when you can eat.
I probably will. I hope so.
And then Cole, kind of a question specifically for you. I mean, I think one of the hardest things, right, is we all think of, and you heard earlier today, you know, older people are the ones that typically get stomach cancer. And so I think young patients, as all three of you are very young, you know, you have these heartburn symptoms, you have this, you know, bad cheese, you have this. How do you convince yourself, or how do you know that there's something wrong, and how do you stand up for yourself? And how, because I think, you know, a lot of providers, right, most common thing a young guy has, you know, it was something you ate and kind of blow it off. So how did you have to be an advocate for yourself, and how did you know that you weren't, you know, making something up out of too much?
Yeah, that's actually, I was incredibly fortunate in that I had a physical scheduled already a few weeks later, and it was a new symptom, so I wrote it down, I took notes, and I mentioned it to my primary physician, and he said, you know, you're not one to complain, so I'm going to take it seriously. I'm going to send you for an endoscopy. I didn't have to advocate for myself at that point. When I was diagnosed, I absolutely did. But it is something that I really learned through the whole process, though, because everybody told me, including the GI doc who did my endoscopy, you're too young for this cancer. When they found the tumor, he said, that's just an ulcer, it's not cancerous. I asked him what the chance was of that. He said 1 in a million because you're too young. Not only are you too young, but I also diagnosed somebody 36 years old a week before. No way I'm going to get 2 in 2 weeks. We know how that turned out, unfortunately. But the big thing is just knowing if there's something that comes up that feels a little bit different, make sure you tell your doc. And if you have a doc that doesn't listen, and I'm sorry to say this to a room full of folks who are in the medical profession, if you have a doctor that absolutely will not listen to you, you should maybe talk to a different doctor. And I was very fortunate from that point forward to have a great team, though. But that's one of the things that I end up having to instill in the folks that I mentor is if you don't advocate for yourself, nobody will, unfortunately. There are folks who are going to be the exception where they have teams who are really responsive, really on top of things. But so often I see folks where they're told they're too young, or they're told they're going to have to wait or get in line or whatever it happens to be. And you really need to be your own advocate. Otherwise, you're going to just fall to the back of the queue.
Unfortunately, I feel like most of the advocacy for yourself has to come by after you're done with treatment or after you're done with surgery, and you have to come and try to explain to a primary care physician the intricacies that go into caring for somebody after gastrectomy. It's difficult to try to get the follow-up you need afterwards, so I feel like that's a large part of it. It doesn't stop at treatment or surgery.
Mm-hmm. That's a good point.
Your own advocate. We see this, you know, a lot with young onset, as I mentioned. This is happening throughout the GI tract and with other cancers. And so if we look at colon cancer patients, people who developed it under the age of 50, it took an average time to diagnose of like 250 days, compared to if you went in at 55 or 60, it might be 30 days average. And that makes a difference in how you're going to do. So
Absolutely.
100%, if your body feels different, I think what you did is you said, my chain, I feel something's different. This is new. That change is so important. And there's really a lack of awareness on the medical communities. I don't know if it's like denial that this can be happening, or it's just been, or we have a lag with education, right? You know, what was taught 10 years ago isn't true now. But I do, you know, really endorse that, and with your family members, you know, to encourage them. Same thing, if something feels wrong, keep pursuing it.
I've got a friend who I met through all of this, and he was diagnosed at same stage, about the same age. His course was very different as far as his diagnosis goes. I had a little bit of heartburn. I was very fortunate, got lucky, got caught super well, a lot earlier than it could have. In his case, he lost a bunch of weight. He had a lot of heartburn. He had kind of the classic reflux symptoms. He felt ill. He ended up having changes in his bowel habit. And after each change, he went to his doctor and he said, here's what I'm experiencing. And his doctor would say, lose weight, take, you know, Zantac, take some Tums, whatever it happened to be. And it would improve things a little bit every time, but they never got to the issue. So by the time he was finally diagnosed, he was throwing up and defecating blood. And unfortunately, with the advocacy work that I do, that's what I see most often, especially with young patients. They start off with symptoms like mine, and they progress. And a lot of times, they're going into the doctor, they're talking about it, they might even go to the emergency room, and it just takes so long. And that's why we're seeing these folks who are diagnosed so much later than they should be.
Absolutely.
Cool. There might be a question for you. I don't know. Did you have a feeding tube during your treatment?
I did, yeah.
Okay.
They implanted one during my surgery. I didn't have one leading up to surgery. So I did 4 rounds of FLOT prior to surgery. Somehow managed to gain 7 pounds because I was just, I don't know, eating buckets of lard or something. Afterwards, I definitely needed it. I lost a significant amount of weight, and I had a bit of an infection about a month after my surgery and was very thankful for having a feeding tube then.
Okay. Yeah, I think the question was leading up to that is how do you eat? I think they're trying to ask online, how do you eat and kind of transition to eating in less tube feeds? How do you eat and do tube feeds? I think that's what the question is
My
online.
sexy answer to that is always chew. People look at me, they go, how do you eat? I chew.
My favorite question is when they ask me if I need a bag, and I'm like, a bag of chips? Or are you asking me how do
I
I
would love
digest?
one, yeah.
I know. I eat, chew, and eat every couple hours.
Yeah, and I actually started off, even though I had the tube, I was eating just through my mouth for that first month, and it was actually only when I got that infection and my gut stopped working for a while that they were like, okay, well, we've got that fallback plan. Let's turn the feeding tube on, and it was fine.
Travis, I have a quick question.
Yeah.
So for each of the panelists, can you name one thing that is your thing that you never eat that doesn't go well? And then name one thing that's your go-to if you need to gain weight that does go well.
I can't do milkshakes anymore. I can do small amounts of ice cream, but I was told by one survivor, like, oh, drink milkshakes. You'll feel so much better because you're going to gain up. Nope, too much sugar, too much dairy, did not work out well. Stay away from those. To gain weight, I end up adding a lot of fats to my food, and I try to eat as much protein as possible. So the big thing that has worked out really well for me is I'll have basically a bed of wild rice or mixed grain rice. I'll add some oil and butter to that, some spices, and I'll throw some chicken thighs on top of it. Or if it's breakfast, I'll cook up 3 eggs and crack them over the top and eat that for a meal. And I was able to gain in the last year about 30 pounds. I had dropped from 230 at the time of diagnosis down to about 140 at the end of chemo. Second half of chemo was rough, but that was my weight gaining regimen.
Yeah, just for esophageal cancer patients, the rice doesn't go so well.
Yeah, rice doesn't go so well if you had a gastrectomy, if it's any sort of dry, or if you drink water after. Sometimes not great. So for me, I didn't eat ice cream for 2 years. I thought I got miserably ill shortly after my gastrectomy, and I had a lot of reactive hypoglycemia. But then I got with my partner who is an ice cream fiend. So that was my answer to this is ice cream, but now it's fine. Now I can have it in small quantities. I think you learn your limits and you stick to them pretty well. About 9 months after my gastrectomy, I was at my lowest weight since surgery, and I started putting half and half in my lattes instead of almond milk or regular milk. I gained probably 20 pounds in less than a month, and I haven't been able to get rid of it since. So I stopped with the half and half very quickly after I started, and I can't get rid of it. So if you have tips, it'd be great.
The one thing I do have to stay away from is pastries. For some reason, I mean, I can eat gummy bears, but I can't eat a piece of banana bread. It will definitely give me dumping syndrome. I am still only 7 months out. I gained quite a bit because, of course, you eat and eat and eat when you're told you're getting your stomach out. You eat everything you don't think you would ever eat.
70
I've never
pounds.
eaten a donut in my life, and I would go to the gas station and get a donut. So I'm still on the downward, losing weight. I have about 20 more pounds I need to go. But other than that, if I can't eat, if I don't feel very well, I tend to go towards the Premier protein shakes or something so I make sure I get my protein in. I am having a hard time where things are getting stuck. So especially when I'm dehydrated, I have a little bit more of an issue. So I tend to resort back to my protein shakes or yogurt but I have to keep it low sugar. Sugar is not good right now.
I know this might be a bad answer, but when I was post-op, Panera mac and cheese has a surprising amount of protein in it. That and McChickens went well. So I was eating a diet of McChickens and Panera mac and cheese for months, and it helped me not drop too miserably low.
Any questions at all in the audience? Go ahead.
I'd like to do what Shanda just did and ask you, what things about the operation you went through that you feared most that turned out not to be true, and which things occurred that you weren't told about that kind of surprised you that they occurred?
Both are food related for me. Nobody warned me that reactive hypoglycemia was a thing. So the first time I was out walking my dog and I got dizzy and sweaty and my feet started to get a little bit numb, I thought I was just going to die. Obviously, I figured things out eventually, but I had no idea that that was going to be the case. The other thing, too, is when I was originally told that this was the operation I was going to be moving towards, the first doctor to really broach the subject with me gave this description of like only being able to eat a tablespoon of food at a time, and I was going to have to like restrict calories, and it was just going to be like this really awful living. And that's not been my experience whatsoever. And I know that things have maybe gone a little bit more smoothly with me than it has for some others, but I think most people who watch, at least the folks here on the panel, eat, if they don't know that we've had a gastrectomy, they probably don't know that there's an issue. And I don't think anybody really stressed really what we're talking about here, that you can live a really good life and it doesn't impact you nearly as much as you might think it's going to, losing a major organ.
My thing that I went through with surgery, I didn't know that I would have such immense back pain. I had laparoscopic surgery. And it seems that all of the air that they put into me went to my back, and it was probably the most excruciating part of all of it. I was fine. My abdomen didn't feel bad. Nothing about the surgical site hurt, but everything went to my joints and my back, and I couldn't stand up without screaming, basically. But as soon as that went away, it's a couple days, and I was fine. I had a nurse that was a little tough one, and she made me go walking around the block too many times. So it dispersed quickly. The thing that I was expecting that didn't happen was, again, like cold food related. I thought I wouldn't eat certain things, or in my head I thought I would never eat cheesecake again. So I ate cheesecake for every day, basically, leading up to my surgery. And as a genetic factor, I had 7 months to prepare. So I think I gained maybe close to 80 pounds before my surgery.
With me, it is, I didn't think we'd be able to eat that much. With a gastric bypass patient, they still have a reservoir to hold food. I can eat and eat and eat. I mean, not huge meals at one time, but
Graze.
all day I can eat. It's crazy the amount of calories. I have to kind of watch it sometimes because I can easily get in 2,500 calories in a day.
You can gain after. That's something I didn't expect.
I'm still in the losing stage. 20 more pounds.
I would love to go back to that stage some days. I bought a bunch of clothes in anticipation, and they never fit me.
And I also teach aerobics. I did not think I would be able to go back to teaching and working out the way I do. It's exactly the same. I actually tend to have a little bit more energy, of course, because I've lost weight. But I think it's because I'm eating so much healthier. I've gotten that sugar out of my diet. But for the most part, like I said, I don't feel any different.
That's not my case. Interestingly, I struggle with fatigue pretty, I don't want to say severely, but I do have a lot of fatigue and issues with anemia and iron. It kind of hit right at, I think, the 2-year mark for me. And the 2-year mark for my sister. We both started struggling with low iron reservoirs. Ferritin was like 6, which is quite low. But I can't do as much physical activity as I used to.
Thank you. Any other questions at all in the audience? I think online there was a question probably for Dr. Wing, a little bit about surveillance for Barrett's. So there's a couple questions on here, just how often, what kind of surveillance, and then, kind of maybe the risk of Barrett's turning into cancer. I think kind of summarizes probably 3 or 4 of those questions online.
Yeah, thank you very much for those questions. Lisa kind of had a slide where she talked about the risks, and definitely non-dysplastic Barrett's. Sometimes it's altered a little bit if it's really long or there's a family history, so none of this is absolute. But the societies generally say between 3 and 5 years, is the interval if you have non-dysplastic Barrett's. It's all determined by Dr. Chen finding whether or not there's dysplasia present. If there is dysplasia present, then we monitor more frequently. And if you're at high-grade dysplasia, we usually treat you. It's almost always the case now because that has a very high risk of transforming, at least 20 or 30%. Low-grade dysplasia, now there's a tendency because of recent studies to treat those patients as well. But if you didn't want to be treated, you'd probably be followed at least yearly, and maybe a little more often, once again, depending on other modifying factors. But most of those with dysplasia now get treated with ablation, with radiofrequency ablation or cryotherapy.
Thank you. Any other questions at all for our panelists? All right. Well, thank you guys so much. Really appreciate hearing your stories and sharing everything with us. I really appreciate that.
No, no problem.
Yeah, thank you. Thanks.
He's routinely present with us on Thursday mornings for our esophageal tumor board that happens every Thursday morning. Dr. Yoon has led the nation in the pembrolizumab trial and continuously leads our group, giving us insight into how to do immunotherapy as we integrate that into the care and practice of our patients with esophageal cancer. Dr. Yoon is a GI oncologist and a researcher in the Division of Medical Oncology at Mayo Clinic in Rochester, Minnesota. He's Associate Professor of Oncology in the College of Medicine. He has an MD as well as a Master of Health and Science in Clinical Investigation. His clinical interests include gastroesophageal cancer and other GI cancers. He's a GI oncologist here again, and he also serves as co-chair of the Esophageal and Gastric Cancer Disease Group. He leads an NIH or R01 funded research program. That just means it's a very important research project that seeks to understand how immunotherapy affects the immune system in patients with gastroesophageal cancer. And he also leads and co-leads national and global immunotherapy clinical trials. He also serves on the guidelines panel for the NCCN, which is the National Comprehensive Cancer Network Gastric Esophageal Cancer Group, and he's a frequent speaker at internationally and nationally attended scientific and educational conferences. We're all very fortunate to have Dr. Yoon here to speak to us on immunotherapy for this type of cancer. Thank you, Dr. Yoon.
Thank you. Thank you for that very kind welcome. And it's a pleasure to be here this morning. And thank you to the organizers, Dr. Grotz and Dr. Blackman, for this opportunity to talk about this really interesting and promising area as it relates to gastroesophageal cancer. These are my disclosures. So I asked my wife, she had a very close family member affected by this cancer. So I asked her, what would you want to know about immunotherapy as a caregiver, as a patient? So she said, what is it? How effective is it? What's available to me right now, and what are its side effects? So my goal here is to really help with education, to help arm us, because this immunotherapy area is still relatively new, and it's particularly uncharted in gastric cancer, and there's still surprises with this type of therapy. So my goal is as I give us information is to help us more effectively advocate for those of us who have the disease as we navigate through the healthcare system. And before we get started, I want to tell you a little bit about myself in terms of how I got interested in this disease. So I was born in Korea, and then I immigrated to the States when I was 3 with my parents. We settled in Chicago. Then I did most of my education in the Northeast and came to Mayo Clinic as faculty about 15 years ago. Now, gastroesophageal cancer is not that common in the US, but in the world, it's the second most common cause of cancer death. And in Korea, it's one of the most common cancers. And in fact, most Koreans will know at least one person with gastric cancer, and personally, I've known 6 people. Now, even though gastric cancer is not that common in the US, the gastroesophageal junction cancer, as you've heard earlier this morning, is increasing in US and Western countries, and the G junction is that spot anatomically between the esophagus and the stomach. And there's a number of people diagnosed with this cancer in the US each year relative to other cancers, starting from the 1970s till about now. As you can see, GE junction cancer is rising faster in incidence compared to more common cancers like prostate, breast, lung, colon, in parallel with the increase in reflux and obesity. So as a trainee, I became interested in trying to help people with this cancer since I had some personal background, and it seemed like it was going to be a bigger problem here as time went on. So that's a little bit about how I got interested in this disease. So getting started, what is immunotherapy? In a nutshell, these are drugs that boost the body's natural immune system to kill cancer cells. And ever since I started practicing oncology, I don't think there's been as promising a class of anti-cancer agents as immunotherapy, so it's a very exciting time. Now, to understand what immunotherapy is, we need to understand the body's natural response to an invader, like a microbe, and how that response is exploited by some cancers. So first, it comes down to this key interaction between a killer T cell and other immune cells. Killer T cells are those immune cells that are directly able to kill invaders such as germs. They bind the microbe directly, this green part right there. After identifying it very specifically as foreign, then they secrete different enzymes that dissolve the microbe. Now, the ability of these T cells to bind only foreign agents is very precise, but it's not perfect. So the body has to have a way of restraining T cells, regulating them, so that the killer T cells don't go off and start dissolving normal cells that are far afield from the original invasion. And one major way that the body does this is by stamping other immune cells like macrophages, with a protein called Pdl-1. That's that blue thing. So then when the killer T cell starts migrating to locations that are far away from the original invasion, these other immune cells get stamped with Pdl-1. Then through Pdl-1, these immune cells can bind to the PD-1 receptor that already exists on the killer T cell. And once this immune cell binds the killer T cell at the PD-1 receptor, then this killer T cell is restrained. It's turned off, and it cannot kill other cells anymore, or not as well, whether it's a normal cell, can't kill a normal cell, can't kill a microbe, or a cancer cell either. So now let's bring this to the tissue level. So invaders like germs travel through the blood, they break through the tissue and start invading the body. Then the killer T cells that are specific to that germ start attacking and killing off the germs like they're supposed to do. There are other immune cells in the area, and because they're not stamped, they actually help the T cells do a better job of recognizing and killing the invaders. But as the infection is getting controlled, the body needs a way of making sure the killer T cells don't start expanding their killing area too much. So the body puts up a kind of a force field. I think of it as a force field around this area. It's this complex biological infrastructure, and anything outside the area gets stamped with Pdl-1. Then those stamped immune cells meet the killer T cells that are arriving, they bind them, turn them off, and in this way, the killer T cell attack is contained and restricted to the location of the original invasion. So it's a very precise system. The ultra-specific T cells target the invader, kill off the invader, but then they're restrained from causing collateral damage. Then after the infection is resolved, those T cells become memory cells. They rove around our bodies, and if that particular microbe ever comes back like a past virus, those memory T cells rapidly could expand and kill off the microbe without us even knowing about it. So this is great against microbes, but some gastric cancers have learned a way to co-opt this system to allow the cancer to continue to grow and to spread. So a cancer starts in the stomach, then let's say it spreads through the bloodstream, tries to lodge in the lungs, let's say. It makes a breach, invades the lung tissue. Some killer T cells may arrive, try to kill the cancer cells off. But before more arrive, the cancer has learned to put up a force field. And any immune cell outside the force field gets stamped with Pdl-1. And those stamped immune cells meet any killer T cells that may be arriving, binds them via the PD-1 receptor, and blocks them. The killer T cells that broke through, there are some, but they're not nearly enough to eradicate the tumor. So in this way, some gastric cancers continue to grow. Not all gastric cancers seem to use this pathway heavily, but the ones that do, if we look at a microscope at the tissue, we actually see the Pdl-1 expression in the immune cells, as Dr. Chen was saying earlier today. So here's an actual picture of a patient's GI tumor at the cellular tissue level, and it shows how the tumor is keeping out the killer T cells. At the bottom are the tumor cells. Each of these long blue ovals are tumor cells, and there's probably about 100 that you can see here. And these cancer cells are at the forward edge of the tumor as the tumor is trying to advance deeper into the tissue, which on this slide is going upward. That's going deeper into the tissue, which is the tumor is trying to do. And the tumor has put up this force field. The killer T cells, shown as the brown spots, have actually arrived in strong force in this particular person's tumor. But they're mostly stopped at this border, and they're prevented from entering through this Pdl-1 stamping process. And the actual Pdl-1 expression is not shown on this slide. There's a few killer T cells that manage to get through the force field, but not enough to eradicate the tumor. Now, having said that, if this immune response, these killer T cells weren't here at all, the tumor probably would have grown much faster. But this T cell army, this person's immune system, is at least slowing down the advance of the tumor. So knowing how a cancer can exploit our immune system, how is this related to immunotherapy? So for most immunotherapies, the game changer discovery was that if you can block PD-1 using a drug, you can unleash these killer T cells, and these unleashed killer T cells can powerfully kill tumor cells. So here's a situation where the T cell is blocked because other immune cells are stamped with Pdl-1. They bind to PD-1 in the T cell and then they block it. But if you give an immunotherapy drug, the drug binds PD-1 on the T cell, thereby unblocking the T cell, and the T cell is unleashed to go and kill cancer cells. So what are these immunotherapy drugs? The most common ones are called pembrolizumab, which has the trade name Keytruda, or nivolumab, also called Opdivo. They're given IV, outpatient, usually once every 2 to 3 weeks. They may be given with chemotherapy. They're generally well tolerated, though we'll go into the side effects a little bit more later. So what's immunotherapy? These are drugs that boost the body's natural immune system to kill cancer cells. So next, how effective is it in gastroesophageal cancer specifically? So in a nutshell, immunotherapy in its conventional use is very effective in about 10% of patients. For example, those who have DMMR tumors that Dr. Chen and Boardman and others have already talked about, which we'll get into a little bit more. It's a little effective in 40 to 50% of patients those patients who have Pdl-1 high tumors, they express Pdl-1. And it's not very effective in 50% of patients, and those are the patients who have Pdl-1 low tumors. So when we talk about effectiveness, there's no way to really talk about this except very candidly, and it requires talking about statistics, and it could be a sensitive topic because, as we know, statistics can't describe the full person, and there are people who beat the odds. But there are also hundreds and thousands of people who've been affected by this disease, and I think it could be helpful to hear what their lives can tell us as well. One thing being how long they lived after stage 4 cancer, after getting treatment. And so that's what this tells us. It's a survival curve, and it's one of the most helpful things to us as oncologists when we evaluate the effectiveness of a therapy. This particular curve measures the indicator of how long a patient lived, and that's much more important than if the tumor shrinks on a scan or a blood test result. So this survival curve is specifically for people with stage 4 metastatic disease. So it does not apply to people with stage 2, stage 3, or earlier disease where we don't have as much data on immunotherapy. So at the far left, everyone is alive, but as each patient passes away, almost always from the cancer, rather than as a side effect of chemotherapy, the curve dips down. So oncology as a practice started in the 1960s and 70s, and as you can see, the treatments were not very effective. If you draw an imaginary line from the 50% alive point all the way across, you can see that about half the people have passed away by about 6 months from the time of diagnosis. So when you ask your oncologist, how long do I've got to live? This is what oncologists are referring to, and that's the median survival. And back in the 70s, even up to the 90s, that was about 6 months. That means half the patients passed away earlier than 6 months, and then some group passed away after 6 months. But as you can see, there are always outliers. Even at 1.5 to 2 years, there's about 5 to 10% of patients still alive with stage 4 diagnosis right here. Then treatments got a little better over the years through many clinical trials that tested newer agents. But as you can see, the progress was still incremental. And during the 1990s to 2010s, many trials tried to push these survival curves higher, but each one failed to do so until this year with immunotherapy. So I don't know about you, but when I saw this curve, I was hoping for more, that adding immunotherapy to chemotherapy finally did push the curves up, but it was not a miracle drug for most people. It was an incremental improvement, but it was the first one in 10 years. So right now, as you can see on this curve, immunotherapy is only effective in patients with Pdl-1 high tumors, which are about half the patients. And it's only adding a few months of life. Now people are living a median of about 1 1/3 years. And 1 1/3 is still not that much, but it's better than the less than 6 months in the 1980s. And the patients with Pdl-1 low tumors did not live any longer from the addition of immunotherapy. So they were the same as patients who received regular chemotherapy as in 1995 to 2021. But having said that, this is still a very big advance, and it suggested that maybe our own immune systems were actually key that had been overlooked. And it suggested there could be real promise if we could do a better job of harnessing the immune system so that it could benefit even more people and with greater benefit for each person. So I think that's what makes this exciting. mostly because it opens the door to finding better ways to use the immune system against the cancers. And an example of this is the use of immunotherapy in patients whose tumors are so-called dMMR. In these patients, immunotherapy is quite effective, even in stage 4 disease. After 3 years, the median survival has not even been reached. So the question is, how can we get everyone to respond this way? What can we learn from this group of dMMR tumors? So why are dMMR tumors so vulnerable to immunotherapy? dMMR stands for deficient mismatch repair. And these dMMR tumors are vulnerable to immunotherapy because they carry these potent neoantigens on the surface of their tumor cells. And neoantigens are these proteins on the surface, and they're able to stimulate the body's immune system. And the neoantigens can stimulate it very powerfully for reasons that are not fully understood. And they arise because of many tiny DNA mutations. And that's what makes them unique. These tumors develop through the accumulation of these tiny mutations, whereas in other patients, they often have entire tracts of DNA are just missing, who are not dMMR. But these tiny mutations generate these neoantigens, and these neoantigens stimulate the immune system. And then these tumors, again, for reasons that are not fully understood, they really rely on this Pdl-1 force field mechanism to grow and spread. So these patients already have a lot of killer T cells surrounding the tumor, but they're getting blocked by Pdl-1 expression on the other immune cells. So by unleashing the T cells from Pdl-1 using a PD-1 blocker like immunotherapy, the killer T cells are finally unleashed, go, and they kill the tumor cells. But most patients don't have a dMMR tumor. So the question is, can we make them somehow that way? And that's one of the many approaches being studied right now. And here's just a small sampling. One is to create so-called neoantigens through different modalities like radiation, certain ways of giving existing chemo agents. Another approach is to block other so-called immune checkpoints besides PD-1. PD-1 is just one of many ways that tumors evade the immune system, other ones being TIGIT, LAG, CTLA-4. There's also vaccines intended to stimulate the immune response to kill cancer cells, engineering viruses so that they can kill cancer cells, as well as directly engineering a person's own T cells so they can recognize cancer cells better. This is so-called CAR T therapy, where we temporarily remove a person's T cells, re-engineer them to be able to be directed against the patient's tumor, and then put the new T cells back in the body. So at Mayo Clinic, we're studying a number of these approaches in gastric cancer in clinical trials. So we talked about what's immunotherapy, how effective is it? Now, which immunotherapy is available right now to me as a patient, and what are its side effects? The short answer is that immunotherapy that's available depends on the cancer stage. And it's summarized on this table. So this is the current standard of care, which I'll bring out one at a time. And the treatment's different based on whether you have early stage, locally advanced, or advanced, which is also called stage 4 metastatic. So for early stage, that means the tumor is not invaded very deeply, only T1 has not spread to the lymph nodes. Relatively few people have this early stage that I see, and there's no role for immunotherapy. This is treated with endoscopy or surgery alone. Next are patients with locally advanced disease. This is about 1/3 to almost half of patients. This means that the tumor has invaded more deeply, T2, T3, T4, or it's spread to the lymph nodes, but not beyond. And this is treated with chemotherapy or surgery. You heard about FLOP being given as one example of this, or chemotherapy plus radiation, followed by surgery. Now, for patients who receive chemoradiation followed by surgery, if there's still tumor left over in the tumor specimen that's been completely removed at surgery, then receiving immunotherapy, nivolumab, for a year after surgery has been shown to increase the cure rate, so that is standard. For patients who have stage 4 disease, it's about half or more of patients, and it means that the tumor has spread to an anatomic location that's far away from the original tumor like the liver, lungs. So in this situation, treatment depends on the so-called molecular status of the tumor. If it's dMMR, then immunotherapy with or without chemo standard. If it's so-called HER2 positive, it's another HER2 protein, it's another tumor protein, then pembro plus chemo is standard. If the tumor is HER2 negative, a Pdl-1 high, then immunotherapy plus chemo is standard. If the tumor is HER2 negative, but Pdl-1 low, then chemotherapy by itself without immunotherapy I would consider standard. though there's some controversy about that. So I think it's essential to know what the standard of care is, but I would highly recommend enrolling in a clinical trial if it's feasible, and that's because the outcomes using standard of care, even when using immunotherapy in a conventional way, need to improve, and we saw that in the survival curves. These clinical trials have been vetted and scrutinized at multiple levels, and in my opinion, they represent the best possible therapy against the cancer for patients who are eligible for that particular trial. So as with any treatment, there are side effects, and even though immunotherapy is typically very well tolerated, about 15% of people have a serious side effect, enough to put them in the hospital. So just as immunotherapy can boost the immune system to fight cancer, it can also boost the immune system's ability to fight against our own normal body cells, and it can affect just about any organ. And these are the most common that are effective. I've highlighted heart and lung because immunotherapy affecting the heart and lung can be fatal within a few days if it's not detected quickly, whereas the side effects can be reversed if they're detected early. So for lung toxicity, it can present as a cough. For the heart, it can present as just about anything from tiredness to arrhythmia. And oncologists are becoming more familiar with the vast array of side effects that can occur. But non-oncologists, doctors, nurses in the emergency room, cardiologists, we as a community of physicians are still learning about these side effects. In my opinion, if there's anybody on immunotherapy and they're doing fine, and then suddenly require ICU level care for reasons that are not immediately clear, I would consider that the immunotherapy is responsible until proven otherwise. Now, having said that, I want to emphasize that most patients on immunotherapy tolerate it well. Most of my patients who have been on both immunotherapy and regular chemotherapy, they much prefer the immunotherapy part of it if they had a choice. So I'd like to end on a patient story that I think really shows how much we're in an uncharted area when it comes to immunotherapy, but it also shows the promise of immunotherapy in this disease, and it illustrates the importance of both patient and provider education. And I share this story in the hopes that it may equip you and the many providers that you may come across in your cancer journey. So this patient of mine, 55-year-old man, metastatic stage 4 gastric cancer, and his tumor happened to fall in that 10% that was dMMR. He was started by a local oncologist on regular chemotherapy. Then he came to me and his tumor was growing, so I placed him on immunotherapy. And at that point, the tumor had already spread to his liver. This is his CAT scan. It's a cross-section of his belly. He's lying down, face up. Imagine we're standing at his feet. Top is his front, bottom is his back. Right, left. Each yellow arrow is a liver metastasis, that little shadow that the yellow arrow is pointing at. So he received about 3 doses of pembrolizumab once every 3 weeks. He did fine, felt fine. Then suddenly, while he was at home, he developed bloody vomiting and bloody diarrhea. He went immediately to the local emergency room, then to the ICU. New CAT scan was done, and the physicians informed him that the cancer in his liver had grown dramatically, and each of these new spots was a new cancer metastasis. They knew the patient was already stage 4, so in light of the widespread tumor progression, they encouraged comfort care and hospice, because these patients generally live about 2 to 4 weeks at this point. But the patient remembered some advice that immunotherapy could lead to something called a pseudoprogression or fake progression. Pseudoprogression just means that the tumor can seem to grow, but that's not because the cancer cells are multiplying, but rather because the immune system is converging on the tumor like an army, and the scans can't tell this apart. In fact, there's very little besides a biopsy that can distinguish pseudoprogression from true cancer progression. Pseudoprogression is generally rare, but I think it should be ruled out in a patient with dMMR, meaning aggressive support should be provided until the dust settles. So he insisted on being full code, and the ICU team agreed. And then sure enough, the patient did develop more bloody vomiting and diarrhea, and again, his blood pressures dropped. So they did a special procedure called a splenic artery embolization, and the procedure first confirmed that the bleeding was in fact due to the stomach tumor, which had grown and was eroding directly into the splenic artery, and this erosion was causing the bleeding. Second, they embolized the splenic artery, which is a temporizing measure, it temporarily clots off the blood supply to a part of the stomach, and it can temporarily stop bleeding without hurting the stomach. So they did that. The patient didn't bleed, and he was discharged from the hospital. And the hospital team fully expected that the patient would soon need to enroll in hospice and would not be able to go to another outpatient oncology visit. But that's not what happened. The patient continued to do okay. He remained strong enough to leave his home, go back to the oncologist's office. And the local oncologist was surprised by his healthy condition, so she thought she should obtain another scan just to see what's going on. And she was surprised to find that the so-called liver metastases had shrunk and some had disappeared. In other words, this was a clear case of pseudoprogression. Those new liver spots here were actually islands of cancer cells that had been there all along back here, but they couldn't be detected on the baseline scan because they were too small. But with Pembro, the killer T cells had converged on these little islands of invisible cancer cells, and that combined mass of the killer T cells plus the existing cancer cells became large enough that you could finally see them, that they became visible on the scans. So in fact, his bleeding was not a growth of cancer cells in his stomach, but rather because the immune response was so strong that the mass of T cells had grown large enough to erode into his splenic artery. So what was happening here was not that the cancer was worsening, but it was the opposite. His body was in a life and death fight against this cancer, and his body just needed time and support to get through it. Give his immune response a chance to beat back the tumor and then for itself to calm down. So that's what the local team provided, support, after the patient insisted on being full code. So after seeing the pseudoprogression, the local oncologist restarted pembrolizumab. And now it's more than a year later. He's been on Pembro the whole time, once every 3 weeks. Tumor has shrunk and is barely detectable, tolerating therapy well, living life. So I think this patient's story is kind of two-sided. It can really, on the one hand, it could really give hope for a future where maybe immunotherapy treatments can help a person give his or her life back in a way. But it's also unsettling because it just shows how much we as a medical community still have to learn about this powerful new therapy. So I think education, not just of patients, but also providers, is really important, especially now. So immunotherapy are drugs that boost the body's natural immune system to kill cancer cells. In its conventional use, very effective in 10% of patients, a little effective in half and not effective in the other half. And what immunotherapy is available to us depends on your cancer stage. This is just our gastric cancer medical oncology team at Mayo Clinic, both on the clinical side and the research side. Thank you very much for your attention.
Thank you, Dr. Yoon, for that great discussion. I'm sure many of our patients will be going back and watching this over and over and over again as they all give themselves the immunotherapy education class. Our next speaker, we're very honored to have his presence. It's Dr. Chris Hollemeyer. He is an expert in proton therapy and radiation therapy and actually led the esophageal cancer proton therapy trial here at Mayo Clinic. He's a consultant physician in the Department of Radiation Oncology at Mayo Clinic here in Rochester, Minnesota. He's an associate professor in the College of Medicine. His interests include radiotherapy for treatment of gastrointestinal cancers. He studies the impact of radiotherapy on outcomes for patients with GI malignancies, including cancers of the esophagus, stomach, liver, bile ducts, pancreas, intestines, rectum, and anus. He studied the integration of radiotherapy with surgery and systemic therapy to identify optimal and individualized multimodality treatment approaches. A primary focus of his research involves proton beam radiotherapy for gastrointestinal malignancies. He always joins us every Thursday morning for our GI tumor board, and we greatly appreciate him coming today and taking some time out of his Saturday away from his family. Thank you.
Thanks, Dr. Blackman, for the kind words, and thanks to you and Dr. Grotz for the invitation to speak today. I'm going to talk about radiation therapy in general, and then also spend a lot of time talking about proton beam therapy specifically, which I think has significant promise for esophageal cancer. So we'll discuss the role of radiotherapy for gastroesophageal cancer just from a more broad perspective. We'll talk about some of the side effects that patients experience while they're getting radiotherapy for gastroesophageal cancer. And then we'll talk about some of the advances in radiotherapy techniques, specifically proton beam therapy. So just going to start with a case. This is a patient that I saw a couple years ago, a 78-year-old woman who had presented with new epigastric pain and anemia or decreased hemoglobin. She underwent an evaluation and was found to have a mass in the lower esophagus. This is the endoscopic picture, and this is a tumor right here. This is the normal esophagus over on this side. This was biopsied and found to be an adenocarcinoma, which is the most common type of cancer that arises in the lower esophagus. She underwent a staging evaluation, and it was found that the tumor invaded a fair distance into the wall of the esophagus. These are scans. This is a whole body PET scan, and the tumor is shown here in the distal esophagus, and you can also see in this view here. This was felt to be a stage 2 esophageal cancer, meaning it grew deep into the wall of the esophagus, but there was no evidence of spread to any surrounding organs. Given her age, and she did have some underlying comorbidities, it wasn't clear whether she'd be a candidate for an esophagectomy, and quite frankly, she was hesitant to consider an esophagectomy. So we treated her with combined chemotherapy and radiation, and then a plan to reassess and decide whether to proceed with an esophagectomy. So she was treated with proton beam radiotherapy, which was given in 25 treatments, once daily over 5 weeks. She received weekly chemotherapy with carboplatin paclitaxel. This is the radiation treatment plan. This is a few different angles. This is showing a cross-section, as Dr. Yoon nicely described, with the front of the patient here, the right here, the left there. And with the proton beam therapy, we have 2 beams that come from the back through the table and deposit the radiation dose. The red is the highest dose of radiation, and then yellow, green, and blue are lower doses of radiation. So you can see we targeted the tumor and then the surrounding lymph node areas. She tolerated treatment reasonably well, developed some fatigue during the course of treatment, had some loss of appetite, some pain with swallowing, and lost about 10 pounds of weight, but we're able to support her with dietitian support, modification of her diet, fluids, and she got through treatment and then recovered. She came back about 2 months after treatment, and the tumor in the esophagus had significantly shrunk in size. There's just some residual mucosal changes here, and on the imaging, the tumor has substantially shrunk. Given, again, her age and comorbidities, she elected to carefully watch things as opposed to go forward with an esophagectomy, and she's now over 2 years out and is disease-free and has good swallowing function, but is in a close surveillance program. So how does radiation therapy work? As we mentioned in the case example, the patient came in for daily radiation treatments over a 5-week period. The patient lays on a table, and the radiation machine rotates around from several different angles, targeting the tumor and the surrounding tissues that are felt to be at risk. It doesn't hurt to get a radiation treatment. The patient basically lays there, and it's kind of like getting an X-ray. Radiation causes damage to the DNA of the tumor cells. The DNA is responsible for having cells replicate. It's sort of the master plan, the blueprint for the cell. And so if a cell wants to divide or duplicate itself, it has to replicate the DNA. So radiation causes damage to the DNA of cancer cells, such that when it tries to replicate itself, it's not able to do so, and the cell dies off. And then as the cancer cells die off, that can result in the tumor itself shrinking. The DNA injury is done immediately or nearly immediately when a patient gets a radiation treatment, but this process of the cancer cells dying off and then ultimately a tumor shrinking on scans, that process can actually take days, weeks, or months. So typically if we treat a tumor with radiation, we would need to monitor it for several weeks or months afterwards, and it's over that time that we would expect to see shrinkage of the tumor. Radiation is not a new treatment for esophageal cancer. It's actually been used for over 100 years. This is a publication from Mayo Clinic in 1920 from Dr. Vinson. And he describes a technique for doing radium treatment for esophageal cancer. This is a schematic drawing, but essentially they use a whalebone staff to advance this apparatus here that's on fishing line. So they use it to push it down to the level of the stricture of the tumor, and then it sits there for a period of time and gives radiation treatment to the stricture, and then they pull the fishing line back out. So as early as 1920, here at Mayo Clinic, they described successful treatment of some patients with esophageal cancer or palliation of swallowing problems with radium treatments. Of course, we've come a long way in the past 100 years, and a lot of research has been done, and this is the current status of how radiation is used for esophageal cancer. For patients that have localized or locally advanced but non-metastatic tumors, if they're a candidate for an esophagectomy, the standard treatment approach is to give chemotherapy and radiation first to shrink the tumor and then do an esophagectomy. If patients are not good candidates for an esophagectomy, then we would consider doing chemo and radiation as the sole treatment and then observe them afterwards. And for patients that have metastatic cancer, the cancer is spread to other parts of the body, radiation can still be a useful treatment for dysphagia or difficulty swallowing caused by the tumor. Even if it's not able to cure the cancer, it can cause the tumor to shrink and help open up the esophagus to allow patients to be able to continue eating. I'm just going to review from a high level a couple of the key studies that have established the role of radiotherapy in these different contexts. This is a very important trial that was done about 10 years ago in the Netherlands. It's called the Cross trial. And it really established the role of doing chemotherapy and radiation before surgery for patients that have localized or locally advanced tumors. So in this study, they took almost 400 patients who had a localized and operable esophagus or gastroesophageal junction tumor. And it was the flip of a coin. If they got heads, they went straight to having a surgery or an esophagectomy. If they had tails, then they got a regimen of chemotherapy and radiation over 5 weeks, and then approximately a 6-week rest period, and then surgery. So this was surgery alone versus multimodality or trimodality because of using 3 different treatment methods, so chemotherapy, radiation, and surgery. So this trial compared these 2 approaches to the treatment of esophagus and GE junction cancer. What they found is that the patients who had the concurrent chemotherapy and radiation did have side effects from the treatment. The most common ones were tiredness, a drop in blood counts, nausea, and weight loss. Most patients had these to some degree, and about 10% or so had fairly significant or symptoms that required hospitalization. What they found is that the patients who had the trimodality therapy or had the chemo and radiation before the surgery were much more likely to have a margin negative or what's considered a curative resection. The patients who went straight to surgery, about 70% of the time they had a margin negative resection, or conversely 30% of the time when the surgeon removed the cancer, there were cancer cells at the edges of what they removed. Whereas the patients who had chemotherapy and radiation beforehand, about 92% of those had clear margins, meaning less than 10% of the time there was cancer at the edges of what the surgeon had taken out. And that's because the radiation and the chemotherapy given before the surgery killed off a lot of the cancer, such that there wasn't as much left behind when the surgeon went in and removed it. And again, it was less likely that there would be cancer left behind. Similarly, giving the radiation and the chemotherapy beforehand killed off some of the cancer that had spread to the surrounding lymph nodes versus those that didn't have it beforehand. And in fact, about 30% of the patients who had gotten the chemotherapy and the radiation, when they had the surgery and the pathologist diced up the tumor and looked at it, they couldn't find any residual cancer cells left behind. So about 30% had an excellent response to the chemotherapy and radiation. And it was reassuring that giving the radiation and chemotherapy before the surgery did not have an adverse impact on the ability to do the esophagectomy, meaning The toxicities or potential side effects from the radiation did not increase the likelihood of having severe complications or dying from the surgery itself, so that was reassuring. This is a diagram that looks at how likely the cancer was to come back in the two approaches. For the patients that had, for the patients that had surgery alone, over time, about 32%, so this is the white area, had no recurrence. About 28% had recurrence in distant organs. 22% had a combination of distant and local. And 18% had recurrence in the immediate surrounding tissues around the surgical site. Whereas the patients who had the chemotherapy and radiation beforehand had a greater chance that the cancer never came back. So 52% of those patients, the cancer never came back versus 32%. The chances of having it come back in other organs was about the same, but then the likelihood of having it come back in the surrounding tissues around the esophagus was significantly lower. And then Dr. Yoon did a nice job sort of walking us through survival curves, which are what oncologists often look at in terms of evaluating the success of a treatment. And again, it looks at from the time of the intervention, walking out to the right, the amount of time that passes, and the percentage of patients that are still alive. And so in this trial of the patients who had the surgery alone, about 33% were alive at 5 years after the start of treatment, whereas the patients who had the chemotherapy and the radiation before the surgery, followed by the surgery, about 47% were alive. So it increased the proportion of patients that were still alive at 5 years after treatment. And then looking even out at 10 years, again, we see of the patients who had the surgery alone, 25% were still alive. In the patients who had the trimodality treatment or the chemoradiation and surgery, 38% were alive. So we see a meaningful improvement in the cure rate with long-term follow-up in the patients who had the trimodality therapy. So again, this really established trimodality therapy as a standard treatment paradigm for these patients. So again, in summary, this trial showed that for patients with operable esophagus or GE junction cancer, giving the chemo and radiation beforehand increases the likelihood of a complete resection. It doesn't negatively impact the surgery. It reduces the recurrence risk and increases the survival. What about patients who are not candidates for a surgery due to age or other comorbidities? There's a trial that was done that looked at either using radiation by itself or radiation combined with chemotherapy, so a 5-week course of radiation alone or combined with chemotherapy. This trial showed that the combined treatment causes much more side effects than radiation alone. So the chemotherapy enhances some of the side effects of the radiation treatment. So both severe and life-threatening side effects are greater if you give chemotherapy and radiation together versus radiation alone. However, the combination significantly reduces the likelihood of the cancer coming back, either in the esophagus itself or in other organs. And the combination treatment significantly increases the duration of survival and likelihood of longer-term survival versus using single modality, in this case, radiation treatment alone. So to summarize, for patients that have localized disease but are not candidates for resection, combined chemotherapy and radiation is superior to radiation by itself. It does cause more toxicity, but it reduces recurrence and improves survival, and is considered standard of care for these patients. I showed you some data from an older trial, more contemporary outcomes for patients who have esophagus cancer and are not candidates from surgery and are treated with combined chemotherapy and radiation. On average, patients live about 2 to 3 years, and about 30% of patients are alive at 5 years after treatment. So certainly we have a long ways to go in terms of increasing our outcomes or improving our outcomes, but there is a proportion of patients who can be cured with chemotherapy and radiation. Just to touch on the role of palliative radiation. So as we mentioned, patients that have metastatic disease or the cancer has spread, radiation is a useful treatment for shrinking the tumor in the esophagus and improving swallowing function. When we're doing it in this context, we will typically give a shorter course of treatment. So instead of a 5-week course of treatment that we would do for patients that have more localized disease where the goal is to try to cure the tumor, in this context, we'll do a 1 or 2 or 3-week course of treatment, and this can be given either alone or combined with chemotherapy. And a majority of patients will have some improvement in their swallowing with the use of even more abbreviated courses of radiation treatment. Depending on the study that you look at, many of the studies show that 3/4 to sometimes even higher patients will report improvement in their swallowing function for several weeks to several months after the treatment. Moving to gastric cancer, we'll spend a little bit less time on this. The role of radiation therapy for tumors located solely within the stomach, so not involving the esophagus, but solely within the stomach. Radiation is not used as frequently in that context for a number of reasons. So for patients that have localized and resectable tumors that are confined to the stomach, typically the treatment paradigm is perioperative chemotherapy and then a surgery, and it's only select circumstances where we would consider adding radiation treatment. If a patient has a localized tumor but they're not a candidate for resection for one reason or the other, or the tumor is growing into other organs such that it would be challenging to remove the tumor, in those circumstances, radiation is more commonly used. Oftentimes, after an initial course of treatment with chemotherapy, the radiation can be used to try to downsize the tumor to make it potentially resectable. Or again, if a patient is not a candidate for a surgery, chemotherapy and radiation could shrink the tumor and help relieve the symptoms for a period of time. And then for patients that have metastatic stomach cancer, short courses of palliative radiation can be helpful to address symptoms such as bleeding from the tumor, pain, or obstructive symptoms from the tumor. Just wanted to touch on one study that was done a while ago now, about 20 years ago, that looked at the role of radiation for patients with stomach cancer. This was a trial done across the United States, and it took patients who had initial surgery for their stomach cancer. So as I think was mentioned previously, we more commonly will do chemotherapy first before considering surgery, but at this point in time, 25 years ago, it was more common that patients would go to surgery first, and then we would consider treatments afterwards. So these patients had surgery as their first treatment, and then they either were observed, meaning they didn't get any further treatment, or they got a course of radiation and chemotherapy after the surgery. So this is a 5-week course of radiation as well as some chemotherapy. And in this study, giving radiation and chemotherapy after surgery did improve outcomes. The median time that patients lived was longer, and the percentage of patients that were alive at 5 and 10 years after treatment was higher in the patients who had chemo and radiation after the surgery. Now, as we mentioned, the application of this trial to the current era is a little bit challenging because a lot of things have changed. Surgery has gotten a lot better for stomach cancer in 2021, and we now commonly will give chemotherapy prior to considering surgery. So in light of these advances, as mentioned, radiation is not as commonly used for stomach cancer. However, there are certain circumstances, like we mentioned, where radiation still can play a role. Again, it's more commonly patients that may not be great candidates for surgery, or if the tumor is very advanced and there's concern about the removability of the tumor. In those circumstances, there can be a benefit in adding radiation treatment to the preoperative approach. Just to talk a little bit more about how radiation is given and sort of the patient's perspective of things. For tumors that are in the upper esophagus, for the treatment, we'll make a mask that goes over their head and shoulders that kind of keep them in the same position every day for treatment, and so they lay down on a table in this position. For tumors that are down in the lower esophagus and stomach, we want their arms up out of the way so that the radiation beams aren't going to come through their arms. So we'll make a mold that supports their head and their shoulders to keep them comfortable. We ask patients to come with an empty stomach for treatment. If a patient has a large meal before they get a scan or come in for treatment, their stomach can fill up and distend, and so it can move around the area that we're wanting to treat with the radiation. And so ideally, we want the stomach in the same position every day, the same distension every day. So typically the best way to achieve that is to have patients minimize their oral intake for about 3 hours beforehand. The two main types of treatments that are used for esophageal cancer are photon treatment. This is the most common type of treatment that's used, delivered by something called a linear accelerator. So the patient lays on the table and this machine rotates around. A newer type of treatment is called proton beam radiotherapy. This is a picture of the treatment room here in Rochester, and it's a much larger piece of machinery. If we could peel away the walls, you'd see that this is actually a 3-story apparatus to swing this around the patient. So this is a much more expensive type of treatment, much more expensive equipment to build in a facility to be able to deliver. So currently, there are about 30 or 35 centers in the United States that have this technology. Pretty much every other center in the United States has photon-based treatment. The side effects that we can see as a person's going through a course of radiation treatment, the esophagus can get inflamed and sore and swollen from the radiation treatment. That typically builds during the course of the treatment. So usually, first couple of weeks, patients won't notice much. But then once they hit week 3 or 4, the esophagus really starts to get inflamed, and it makes it difficult for patients to swallow. They have a lot of pain. We work closely with them to help them out and support them through the treatment. Oftentimes they need to modify their diet to softer or pureed foods. We can give IV fluids as needed. We work closely with our dietitians to help try to optimize their nutrition. We have sort of a pathway of pain medications that we use. We typically will start with Tylenol, and then if that's not controlling it, go to viscous lidocaine. That's a numbing medication that they can drink that goes down and sort of numbs up the esophagus. And then if that's not cutting it, then many patients will need to use narcotic analgesics, things like oxycodone or morphine, for a limited period of time until they get through the treatment and start to improve. In spite of that, about 5 to 10% of patients will need a feeding tube to bypass the area of soreness and discomfort. So if a patient's really losing a lot of weight and getting dehydrated, then we would need to consider going that route. And again, it's about 5 to 10% of patients. They can lose their appetite related to the chemotherapy and the radiation. They can get nausea and vomiting. They can feel tired. The skin on the chest or back can get sore. The acute side effects, again, reach their peak around the end of the 5 weeks of treatment and kind of stay at their peak for a couple weeks afterwards, and then they slowly start to get better over the next several weeks. We can see some late effects related to radiation treatment if the patient does not undergo an esophagectomy, or meaning they have definitive treatment. Some patients will develop scar tissue or stricturing in the esophagus, which can make it difficult for food to pass through. And they may need to undergo an endoscopic or EGD procedure where they go in and they gently stretch out the esophagus, and that may need to be repeated depending on the circumstance. There's a small risk of injury to the surrounding organs, such as the heart and lungs, related to the radiation treatment, which may not become apparent for several years after treatment. There's been improvements in both hardware and software in delivery of radiation treatment. This is how radiation was delivered in the 70s and 80s. They would take an x-ray of the chest and then draw a big square, and a beam would fire from the front and hit everything all the way through, and a beam would fire from the back and hit everything all the way through, and would give a lot of radiation exposure to the heart and the lungs. As we moved into the 1990s and 2000s and 2010s, there's been improvement in the hardware that can sort of sculpt the radiation beams and treat from lots of different angles, and then computer planning to help optimally design a radiation plan in different angles and modifications of the beam to try to put the highest dose of radiation in the tumor and reduce some of the radiation going to the surrounding organs like the heart and the lungs. As we mentioned, the most recent advance is proton beam radiation therapy. Again, this is sort of we call a color wash, showing the intensity of the radiation treatment, the red being the highest intensity, and then moving down green and blue, lower intensity. And so ideally, we put all the radiation into the esophagus and surrounding tissue and none of the radiation in the surrounding organs. And with IMRT, which is the most sophisticated photon or X-ray type of treatment, we can put the highest dose there, but we do get a spray of radiation going through the heart and lungs. And so the appeal of proton treatment is you can use two beams that come from the back and they drop the radiation right on the esophagus and can minimize the amount of radiation going to the heart and the lungs. Really, the esophagus sits in a tough spot. It's right in the middle of the body, it's right behind the heart, it's right between the lungs, and it's right in front of the spinal cord. So proton radiation does a better job in most instances than the photon treatment in getting the radiation to the esophagus and minimizing spillover into the surrounding organs. This is another view a little bit further down into the abdomen. Again, we can see the more conventional radiation gives a spray of radiation to the liver and the intestines and the stomach, whereas the proton radiation is a little bit more focused. This is another view of this, again, sort of looking head on. You can see there's better sparing of the lungs and the intestines. And then this is looking from the side. Again, the proton radiation, because the beams stop, you get sparing of the heart and the anterior structures. As I mentioned, proton therapy is only available at about 30 centers in the US, and many of those are fairly new centers. So there's fairly limited data looking at outcomes with the proton treatment versus IMRT, but the early outcomes, including data we've generated as well as MD Anderson, were the two centers that have the most experience with proton therapy for esophageal cancer. There is suggestion in the early data of better quality of life, lower heart and lung complications, and then interestingly, lower immune suppression with the proton treatment. MD Anderson tried to do a study where they directly compared proton therapy and IMRT. So patients enrolled and they had to be willing to, based on the flip of a coin, have their treatment decided for them. So they tried to directly compare to be able to better quantify the differences between the treatment. Their hypothesis was that the proton treatment would reduce toxicity. They showed that the proton treatment, in fact, did reduce radiation dose to the heart and lungs. It did reduce lymphopenia, which is depressed blood counts, and it did lower the toxicity burden compared to the IMRT. This is a fairly small study. There were only about 100 patients that were enrolled in it, and looking at survival, there weren't any dramatic differences between the two treatment approaches, but that really wouldn't be expected given the number of patients that were in the trial. There's now an ongoing larger national trial that's trying to directly compare proton radiation versus IMRT. This is being run through the NCI. So this is an NCI-funded national trial. And the goal is to enroll 300 patients, and they'll get either IMRT or proton. It's a randomized trial. Patients don't get to pick which treatment they get. Providers or physicians don't get to pick which treatment they get. These trials are hard for patients to consider enrolling in. A lot of patients will want to make a choice on what type of treatment they want. So this trial has enrolled about 50 patients and has been open for 3 years. The hypothesis is that the proton treatment will either reduce major cardiac and pulmonary side effects and or improve survival. So in summary, radiation therapy is an important treatment modality for patients with esophageal gastric cancer. For tumors in the esophagus and GE junction, it can be used as a preoperative treatment prior to surgery, as definitive treatment for patients who are not good surgical candidates, or as palliative treatment to relieve dysphagia from the primary tumor. For stomach cancer, it's used more selectively and less commonly for localized patients, and again can be used as a palliative treatment for symptoms related to the primary tumor. It's typically given over 5 to 6 weeks with chemotherapy if it's localized disease versus oftentimes we use a shorter course of treatment in a metastatic or palliative setting. The acute and late side effects are predominantly due to irritation of the esophagus and stomach, and then longer-term scar tissue in those organs. And newer and advanced radiation techniques such as proton therapy and IMRT can reduce radiation dose to the heart and lungs and could reduce the likelihood of having injury related to those organs. Thank you.
So our next speaker will be talking about demystifying the peritoneum and the HIPEC. Thank you again, Dr. Hallemeyer, for your discussion and presentation. It's always educational to get to hear you talk and to hear you talk about something that you have so much of a fund of knowledge of. Dr. Grotz, as everyone knows, is a surgical oncologist in the Division of Hepatobiliary and Pancreatic Surgery here at Mayo Clinic in Rochester, Minnesota. He's assistant professor in the College of Medicine. His clinical interest and expertise focuses on gastric cancer, ranging from minimally invasive robotic resections and gastrectomies to complex multivisceral resection and the treatment of peritoneal metastasis. His research focuses on early identification and improved treatment of peritoneal metastasis, and he'll be again talking about demystifying the peritoneum, which is the lining of all the organs in the abdomen and the lining of the abdomen, and HIPEC, which is heated intraperitoneal chemotherapy. Thank you, Dr. Grotz.
Thank you very much, Dr. Blackman. Thanks. So I have no financial disclosures. However, technically, HIPEC is an off-label route of use of FDA-approved medications. So what that means is FDA approves chemotherapy in a specific route and a specific indication and a dose. And so we as physicians do have the ability to use medications a little bit off label is what we call it, and that's what HIPEC is. So we're using drugs that are approved for treatment of gastric cancer, but the route that they've been approved by the FDA is through the vein into your port, and we're using it in a different route, which I'll explain later. So similar to Dr. Yoon, I asked my wife too, how do I approach this? Because I know it's a very complex subject, and I struggle to try to explain it to patients. And so similar to Dr. Yoon's wife, she told me I had to define what the peritoneum is first of all, because it's not a common used word. Talk about what are the risk factors and how do you get this peritoneal spread. Then talk about how do we identify it. And then lastly, talk about and explore some treatment options, such as including HIPEC, for patients that have peritoneal spread from stomach cancer. So to define peritoneum, so it's the peritoneum. It's basically, as Dr. Blackman said, a thin lining of the abdomen and pelvis that covers the surface of the organs. So this is a side picture of the human body, and you can see here's the organs. So here's the intestine, here's the stomach, this is the large intestine, here's small intestine, here's your pelvic organs, so this is a female, so it's a uterus and a bladder. And so you can see this blue line I drew on here is the lining of the, over the organs and also over the abdominal wall. And so it holds its function is to kind of hold all the organs in place, if you will, and try to cover all the organs and support them. So here's a really bad drawing that I did. And one of the ways to think about it, I think, is to take your fist and look and think about a balloon. And so your fist is the organ. And it's like you're punching through a balloon. The balloon wraps around. And so there's two layers of the balloon, right? There's the layer of balloon that's right on the fist, which is the organ. There's also the outer layer, which would be the abdominal wall. The only difference is in humans is that balloon is deflated. We don't normally have air in our abdomens, and so normally you have a deflated balloon essentially over the surface of your fist, over your organs. And so it's kind of what we do with laparoscopy and robotic surgery. We actually get into that balloon and we inflate the balloon, and that gives us all that working room to do an operation or a procedure. And that's also when people have ascites or fluid in their abdomen. Again, it blows up that balloon with all that fluid, and so that's why their belly gets distended. It's in that space. So it's a potential space, but it's not, normally we don't have fluid in that space. And so I think to begin, stomach cancer, as we've talked to, some of the other speakers have talked, can really spread three major primary routes. And they get there in different ways and they mean different things. And so we've talked a little bit before about how it spreads to the lymph nodes. And so I think the lymph nodes is kind of like a chain of lakes. So each lymph node is the lake, and then there's a river, which is the channel that goes from the one lake or the lymph node to the next lake. And so the cancer grows in the stomach, and then it gets into that river, and it kind of contaminates the water, if you will, and it gets carried up to the next lake. And then the pathologist can see it. Dr. Chen showed us the pictures where he could see it in the lymph node. So that's called lymph node spread. The other way is those lymph nodes are along the blood vessels. And as Dr. Chen showed us earlier, the tumor can get into the blood vessels, and that's how it gets into your body. And you can get cancer cells floating around in the bloodstream. And that's how they can get lodged inside of an organ, such as the liver or the lungs. That's how they get there. The peritoneum is a different area. And so what happens there is we think the cancer grows through the lining of the stomach. So the stomach cancer starts in the inside of the stomach, can grow through, and then it can become on the outside. And it can basically exfoliate, kind of shed cancer cells into the abdomen. So again, it's basically, remember that deflated balloon, it sheds cells into the inside of that balloon, and they can float around in there and land on the inside of that balloon. And so it's a different kind of route of spread. And so peritoneal spread, fortunately, is common in stomach cancer, and there's some risk factors that we know of. Some are not modifiable, or most of them are not modifiable. And unfortunately, our young patients actually are at higher risk for this type of spread in particular. There's some ethnicities, such as Hispanic and African Americans, who are also at higher risk for some reason of peritoneal spread. Again, the thickness matters, and that's because we believe the primary way it happens is, again, that the cancer cells get on the outside of the stomach and they exfoliate cells. So thicker tumors that involve the full thickness of the stomach have a higher risk of shedding these cells. And then the other factors here are some of the factors on the path report that Dr. Chen showed us that we look for. So when he uses the words, or he or she uses the words of signet ring cell, that's a special type of cell that's lost its cohesiveness, and so it's less sticky, and so it can spread quicker. Or if it is called a diffuse type, when he looks at it, it looks like a diffuse type stomach cancer. That's again another high risk feature. Also, tumors involve the whole stomach, and it kind of makes sense that the more involvement of the stomach, the more likely the cancer is going to be able to get outside of the stomach. And again, that differentiation, which Dr. Chen showed us too, so long ago was first started, actually is one of the important predictors of people who have a cancer that's more likely to spread through the peritoneal route. And so we can actually calculate somewhat of a risk score based on these factors. And so unfortunately, as I mentioned, peritoneal spread is very common in stomach cancer. And so when you take a patient, a person who's newly diagnosed with stomach cancer, and they get their endoscopy, and they get their CT scans, and they get their PET scans, unfortunately, 1 in 6 of those patients, based already on just the imaging, is going to be found to have peritoneal disease. And that's defined by the screen part of the chart here. So here's a picture of a CT scan. I know a lot of us don't look at these regularly, so I think it's always helpful to have a normal CT scan. So this is just one slice of a CT scan. And so we have labeled the organs here, the liver, the stomach, and the spleen. And this is this normal black fat in that side of that balloon of the organs. And this is normal. And you can see things can be pretty subtle if you're not used to looking for peritoneal disease. And so this is not black, it's gray. And then you see this over here is a lot, I call it busy. There's a lot of gray kind of nodularity of subtle changes there. This is all cancer that's spread outside of this stomach and now is inside that inside of that balloon. And we see that on the scan. So let's say you're, again, diagnosed with stomach cancer. You have your CT scan, you have your PET scan. You're not the 1 in 6, so everything looks good. So then your surgeon tells you that you need a laparoscopy. And so they go in, they put you to sleep. They go in with small incisions. Again, they inflate that balloon around the organs, and they take a look around with their eyes, and they do some washings. And unfortunately, now 1 in 3 of those patients undergo that procedure are going to be found to have peritoneal spread in their abdomen. And so that's reflected by these 2 blue and purple charts. The blue is the people that have visible, so you can actually see it with your eye on laparoscopy. And this purple is the patients that have only microscopic. So when Dr. Chen and pathologists look at the fluid that we sample, they actually can see cancer cells in the fluid. So here's a picture of what I see as a surgeon. So I've blown up that balloon around the fist. And so here's the liver, here's the stomach. You can kind of see this big crater in the stomach cancer. So I can see on the outside now of the stomach. So this cancer had grown through here. But fortunately, I don't see any white cancer anywhere else on the organs. The diaphragm is a smooth muscle, looks very good. On this situation, same thing. Here's the stomach. I got a little bit less of the liver, you can see. But now you see these very faint little white plaques. And so you can kind of see why they're so small, why we can't see them sometimes on CT scan. Because they're so small, they're so flat, you only can see it with your eye. So we have to biopsy that similar to Dr. Wang, how he did the biopsy. We take a little bite with some graspers, and we send that to the pathologist. So this is really important to understand the stage. Again, as we mentioned, all the treatment hinges on the stage of the cancer. And so unfortunately, we as a nation are really bad at completing this part of the staging and really recognizing how important it is to identify peritoneal disease. And so this is just a chart kind of looking at insurance data, the kind of Medicare data over time. It's going to be an old chart now, so hopefully things are much better. But on the x-axis, the bottom part, that's years. And then there we go. And then on the y part is percentage of people who should have got the procedure who actually got it. And so the blue line is all patients. You see, back in 2004, we didn't really recognize this as a problem, and so very few people ever even got the procedure. And even as early as 2013, we still don't really recognize it because less than a quarter of patients who should be getting these laparoscopies are getting them. And then again, so let's say you go through your staging imaging, you don't have any cancer, you get your laparoscopy, it looks good, so you're doing well. You get your treatment, you get your chemotherapy, you get your surgery. Then you're being followed in surveillance. And so not everybody recur, and we showed those, Dr. Yoon showed those nice curves. There are definitely patients who do well. But of the patients who have recurrence, 1 in 3 of those recurrences will be isolated to just the peritoneum alone. So again, it's just a very common site of failure or of spread of stomach cancer. This is important because as we've talked before, and Dr. Yoon really elucidated very nicely, this does mean this is stage 4 cancer. This means it's cancer spread outside of the stomach. It's gone elsewhere. And traditionally, the survival is not well. And we've seen a couple of these curves, a bar chart, kind of a similar way to look at it compared to those graphs. Obviously, patients early cancer do well. And again, the proportions, not everybody, and you've seen some long-term survivors are here, that there are patients. But again, the proportion of people that do well is less, much less, in patients with stage 4 cancer. So we need better treatments. So what are we doing here at Mayo Clinic to try to diagnose these peritoneal metastases? So first of all, again, doing the laparoscopy is super important. Just the more information we know, the better. And so doing those on everybody who needs those. But more importantly, laparoscopy, there are limitations to that. It's how thorough we look at everything. Could we miss the cancer? Even the fluid sampling, even the pathologist, when he looks at the fluid, he or she looks at it, they still can miss a cancer cell. And so there's definitely people who, again, as I mentioned, 1 in 3 people that have recurrence, even though everything was negative, they'll be in the peritoneum. So it's not a perfect test, as Dr. Yoon mentioned earlier, that we have to kind of add all these tests together to make things better. And so one thing we're looking at is trying to look at signatures for cancer. And so I know Dr. Kasi is going to talk about later what cell-free DNA means and liquid biopsies. And so I'll let him expand on that more. But essentially that's what we're doing here is we're looking at DNA. So all cancer cells and human cells, regular cells, have DNA that makes up how they function. And they actually can release that DNA. And so if you check your blood, you can find, or fluid in your peritoneum, you can find normal DNA. You can also find tumor DNA. And how we know it's tumor DNA is because we know that there are the mutations that we know that are in cancer. And so people normally have healthy DNA, and there's not a lot of mutations. And then there's certain mutations that we know we can look for in cancer DNA. And so now the technology has gotten so good, we can measure these DNA down to the tiniest amount. And so this really can be the next step of being the most sensitive way, because we can measure cancer cells way before they become visible to the eye or even by imaging. And so that's something that we're actively studying here in the peritoneum. And so what can be done about peritoneal spread? Well, traditional intravenous chemotherapy, as Dr. Yoon presented, is very effective. It gets into your bloodstream and it treats your whole body. But one place that we think it doesn't get to as well is the peritoneum. And so I said less effective. It definitely can still be effective, but it just has a tough time penetrating. There's this barrier. So remember, again, that balloon around the organs, this has a tough time getting through the wall of the balloon. And so if we give people chemotherapy through their port, and then we try to measure the chemotherapy levels in the peritoneum, it's really much less concentrations or amount in the peritoneum. And so one route or one way to kind of change up or take advantage of this is by giving intraperitoneal chemotherapy. So again, what we do is we blow up that balloon now, but we put chemo in that balloon. And that barrier actually helps us now, because now we can put high concentrations of toxic chemotherapy into the balloon, and it doesn't get into the blood vessels, and you don't get as many of the systemic side effects that you can get with intravenous chemo. And that's essentially what HIPEC is. So HIPEC is hyperthermic, which means it's heated. It's intraperitoneal, which means it's inside your abdomen, inside that balloon, and it's chemotherapy. And so we do heat it, and it is pretty hot. So it's 108 degrees, and those of you that may have a hot tub know about hot tubs about 104. So 108 is a pretty hot tub. It's not meant to burn or scald anybody, and if you look at the organs afterwards, they all look fine. They didn't get burnt or anything. But that heat seems to help the chemotherapy penetrate deeper into the cancer cells. And it also seems to help synergize with most chemotherapy drugs, not all of them, but help to make the cancer or chemo be more cytotoxic. And so again, this route allows us to then get less side effects and higher doses of chemo right to the area. And so HIPEC's been studied actually for a lot of different tumors for quite some decades. Really in the 80s is when it first started into clinical practice. But really, gastric cancer really hasn't been investigated until really recently. And that's largely because we didn't have effective systemic chemo, as like Dr. Yoon had shown you, until just recently. And so as all the treatments get better, that's why it's so important that all of us collaborate together, because as they get better with the chemo and radiation and stuff, it allows us to do more for surgery. And so now we're looking at HIPEC in two different ways. One is to try to decrease that recurrence of patients who don't have disease, but try to prevent cancer from coming back in the peritoneum. And a lot of Eastern European countries are looking at that. Primarily what we're doing here is taking patients who already have peritoneal spread and seeing if we can treat them and help them with intraperitoneal chemo. And so one way we do that is this laparoscopic chemo, or HIPEC. And so this is a picture of a patient. So I put a little picture of this. The head's going to be up here, feet are down here. This is the belly button. And so he has a feeding tube. And we go in laparoscopically through small incisions. We take a look around. We see if there's any peritoneal disease. We take some biopsies. We do a washing, see how much cancer cells are in the abdomen. And then we put these catheters in just through the incision. And they put 2 of them in there. And then this one flows the chemo through there, and the chemo circulates around, and then it comes out through the outflow and goes back to the machine where it gets heated, and then it flows it back in. And so every couple minutes, actually, all the fluid in the abdomen, chemo, is being changed out and heated again and put back in. So it's kind of, some people think it was a whirlpool or like a washing machine. We're kind of trying to, get that chemo washed around so it gets everywhere. And so we can do this as a minimally invasive procedure. People can go home, usually stay overnight. Generally, it's pretty well tolerated. It is general anesthesia, and it is a surgical procedure. And we do push on the belly, so there can be some soreness. So there are some, but in general, people do pretty well. And so really the goal of this is, again, we're not doing any surgery, we're just doing chemotherapy. So I try to explain to patients that this is the pathway that we want everybody to be on. They get diagnosed hopefully early, there's no metastatic disease, they're healthy, and they're a good candidate for surgery. They get their treatment, and they go on to curative intent gastrectomy, and they do well. And so that's what we're hoping for. But as I said, there's just a lot of people who unfortunately fall off here because we find that peritoneal disease. And so we can't keep going down this route when you have peritoneal disease, because if you don't treat the peritoneal disease, it comes right back. And so we don't have the good outcomes that we do when we don't have the peritoneal disease. And so I think of laparoscopic HIPEC as we're trying to salvage and to get people back on the pathway. So they find out they have fluid that's positive, very, very small amounts of peritoneal disease, and through a combination of the IV chemo that Dr. Yoon or his colleagues give, and then the laparoscopic HIPEC, can we convert some of these patients to go to negative, where there's no more peritoneal cancer in the peritoneum inside that balloon, and can then we get them to curative intent gastrectomy and get the same outcome that everyone else has. And so that's been a goal here, and we've been doing that for the last several years. So here's an example of how effective this can be. So this is a patient who is newly diagnosed, and so this is on laparoscopy, so I inflated that balloon around the organs, and then I'm lifting up the stomach. So this is the stomach, and so I'm getting underneath it, and then below is the pancreas, and here's the colon. This white stuff is the cancer that's spread outside of his stomach, and so this is peritoneal metastasis. So then we gave a combination of IV chemo, and we did HIPEC, and we came back, and we take a look, and now his stomach looks almost completely normal, and there's no more of that white stuff. It's just scar. When I biopsy this, Dr. Chen tells me this is all scar, and there's no more tumor in here. And so this is a patient who we think we've converted from a very bad situation to hopefully a potentially curative situation. Unfortunately, we can't convert everybody, and so so as we work to try to improve the HIPEC, the chemo, and get things to convert, there still are some people who still have some peritoneal disease. They don't have that complete response. There's still some stuff in the peritoneum. And so, again, we're trying to get them back on this curve. But they need an additional surgery now. They need another step to get them hopefully to that good outcome. And that's a pretty aggressive surgery to remove not only the stomach tumor, but all that peritoneal nodule, all that tumor that's inside of that balloon, in addition to the HIPEC. So this, and I apologize for showing surgical pictures right before lunch, so hopefully nobody gets too queasy. But essentially, we call that cytoreduction. And so what cytoreduction is it's really two steps. One, the first step is you have to systematically observe and examine every nook and cranny. So again, going back to that fist in the balloon picture, you have to look in every crevice of the knuckles and everywhere along that organ to find cancer, because it can tend to hide and be in spots. So one part why it's such a long operation is just being so thorough and looking everywhere. And then when you do find it on that lining, we basically try to peel that lining of the balloon off the organ if we can and preserve the organ. We try to be as organ preserving as we can if possible. So here's an example of, it's hard to probably appreciate, but there's a lot of tumor, this kind of red stuff with the white, the white is the tumor, the red is probably the normal muscle. And so there's tumor all along this diaphragm. And so what we can do is we can actually peel, that's that line, I'm peeling the balloon layer off of the diaphragm. And then you get this nice healthy diaphragm. So this is what is underneath this. Underneath this is this muscle. That's the diaphragm that helps you breathe. And you see there's no tumor on the actual muscle of the diaphragm, but that whole lining, that lining of the balloon's been peeled off. And so we're able to remove that. And then we do HIPEC at the same time now. So now, after we've gotten all the cancer out, because there could be something that I can't see with my eyes or that is still floating around, we do the similar HIPEC, where we again put the catheters in the incision, but now we have a bigger incision. And then we hook it up to this machine. It's a pretty simple machine. There's a heater down here that heats it. We can measure it within 1/10 of a degree. And then here's just the roller pump, so it's pretty small, and just pumps the fluid through. And then here's kind of our control panel. We have a filter, and basically it just kind of keeps circulating. Like I said, every couple minutes we turn out all the fluid in the abdomen. And we do that for about an hour to hour and a half, depending on which regimen we do. Then we drain it all out, and then we close people up. And so that can be a very intense surgery and a very intense recovery. But again, the goal is to hopefully get patients back onto that trajectory of good outcomes. And so that's, again, another thing that we're doing here for patients with this particular type of spread of cancer. So then I want to transition to a different type of intraperitoneal chemo, and that is what we call PIPEC. And so HIPEC, all these acronyms, but HIPEC, again, remember, is fluid. So it's all fluid. It's a chemo bath. So we're using fluid dynamics. PIPEC is just basically using pressure dynamics, air dynamics. So that's what PIPEC stands for, pressurized intraperitoneal chemo. So in this case, if you ever work on an air compressor or inflate your tires, you kind of know that's what we're trying to do is we can increase the air pressure to a safe level, but it's a level that can actually kind of push a little bit the chemo into the cells. And so PIPEC can be done minimally invasively, just like I had that picture. You can put small little, these are really small. They're usually about 5 to 10 millimeter ports here. And we take the chemo and we inject it and we put some CO2, and so we blow that into the abdomen. Remember, that's again the balloon around the organs. We get into that balloon and we blow up the balloon, and so now all the air in the balloon, instead of a water balloon, we have an air balloon, and then there's a lot of tight pressure in that air with chemo. And that seems to be another way to deliver chemo, again, directly to the peritoneum. And so this has really only been studied in Europe. It's starting to come here to the US. And in fact, one of our colorectal surgeons here, Dr. Murcia, was the first surgeon to do PIPEC in the US. And so he did it in 2019. And so he and his team there, pictured here, are offering that primarily for colon cancer patients. But we are now adapting it to patients with stomach cancer. And so he has a clinical trial right now. It's open in our Mayo Clinic in Jacksonville site. And this is not a picture from his trial, but this is from one of the European trials, just showing CT scans of some of the responses that they've seen. So here's a patient with fluid. So this asterisk is fluid around the stomach here, and a very thick lining of the peritoneum. So that's a thick lining of that balloon. And then with successive treatments, you can see that fluid goes away, and that lining gets very, very thin. And so same thing here, all this fluid. And fluid is usually a product of cancer. So that usually is the cancer makes the fluid, and that's why people get fluid in their abdomen or ascites. So you can see here the fluid, and then again the fluid just goes away with the treatment. So this is some of the responses that we've been seeing with PIPEC chemo. And so we're hoping to get this trial open here in the very near future. So in summary, peritoneal spread is unfortunately very common in stomach cancer. It can be routinely diagnosed with staging laparoscopy and peritoneal cytology. There are some newer testing that's coming hopefully soon that we're investigating, looking at the cell-free DNA or liquid biopsy to try to improve not only diagnosis and catching it early, but potentially also monitoring responses to therapy, and so we can adjust and know if people are really responding to therapy or not. I think intraperitoneal therapy, again, it's just a different route of giving chemotherapy. It's going to have an increasing role in the treatment of patients with stomach cancer and peritoneal metastasis, and in a variety of different ways, either through the pressurized way I explained before or through a fluid technique. But clearly there's future research is needed because this is a very toxic pathway for patients. And so we need to significantly improve how make it simpler, make it more safer for patients, less toxic, and again, more effective. And so hopefully we'll continue to work on that. All right, any questions? All right, thank you very much.
So I think now we'll have a lunch break. Feel free to roam around and explore the lobby and atrium area, and you can take your masks off to eat lunch. And we'll come back at 12:45, is that right?
12:45.
Yeah, 12:45 we'll meet back in the auditorium for our next series of lectures and a panel of more survivors from esophageal and gastric cancer to also visit with you. Thank you. Is that the countdown? No, it's going down, so. Yeah, I didn't want Dr. Kendrick to panic when he saw that he only had 28 minutes to talk instead of exactly 30. Okay. I'm going to give a couple more minutes for people to walk in, or do you want to go ahead and start? So we stay on time. Yep. Okay. Okay. So as people are starting to come back in after the lunch hour, I just wanted to take a minute to thank everyone at Mayo Clinic who worked so hard to build this symposium. Shannon and Dorinda worked so hard to organize everything, constantly meeting with us, the Debbie's Dream Foundation team that's come here, all of our patients who are willing to share their stories, and even the people that don't get recognized at events like this, but really do a whole lot of work behind the scenes. We have two of our researchers here that work in the research department. Can you wave? Yep. So these people are the people that frequently work behind the scenes that make all the wonderful things that happen at Mayo Clinic magical by consenting patients for clinical trials, offering them novel therapy, and getting them plugged in when they need resources. So I'd like to introduce Dr. Michael Kendrick. He's a consultant surgeon at the Department of Surgery at Mayo Clinic in Rochester, Minnesota. He's a professor of surgery within the Mayo Clinic College of Medicine and Science and is the chair of the Department of Surgery and chair of the Surgical and Procedural Committee at Mayo Clinic in Rochester. His clinical interests include minimally invasive treatments of gastric, pancreatic, and hepatobiliary diseases. Dr. Kendrick received his MD degree from George Washington University in Washington, D.C. He completed his general surgery residency at the Mayo Clinic College of Medicine in Rochester, Minnesota. After his residency, he received additional training as a Mayo Foundation Scholar in hepatobiliary surgery at Mayo Clinic, Rochester, and in Paris, France, and in minimally invasive surgery in Mount Sinai in New York. His clinical interests include innovative and advanced minimally invasive approaches to the treatment for premalignant and malignant gastric and pancreatic hepatobiliary diseases. Inherited conditions predisposing to malignancy, such as CDH1 gene mutation, is a specific area of interest of his, as you met some of our earlier patients who were patients of his. Dr. Kendrick has published 20 book chapters and over 189 peer-reviewed articles. He's been recognized by his trainees and has received Teacher of the Year in Surgery multiple times, not surprisingly. Thank you, Dr. Kendrick. We look forward to your talk.
Thank you. It's a pleasure to be here today, and I appreciate the opportunity to present to you. I'm going to talk about minimally invasive surgery, and I wanted to thank Dr. Grotz and Dr. Blackman and all of those who have put together this course. I'm a participant and deserve none of that credit. I have nothing to disclose. Dr. Blackman outlined my interests. I think I've spent most of my career working on the innovative and advancement of the minimally invasive approaches for the diseases and conditions she outlined. What I'd like to do in the next 25 minutes or so is, first of all, just review the definition of minimally invasive surgery. I think that's very basic, but it's important that we make sure we're all speaking the same language. And then describe some of the potential benefits of minimally invasive approaches, and then we'll briefly explore some of the reported outcomes comparing minimally invasive and open approaches that justifies why we're talking about this today. This is a very simple definition, but really any surgical approach performed through smaller incision or incisions instead of a larger opening would fit this. And so whether that's single port surgery or multiple small ports, this is really an advance from the larger incisions with many physiologic and musculoskeletal consequences of that. Some of the terms you'll hear are open or laparotomy. That describes the larger incision. We're talking about gastrectomy today, so this is typically done through a long, what we call midline incision, as you see in this figure. If it was a very locally advanced gastric cancer involving other organs, sometimes it would be up underneath the ribs, transversely, cutting through the muscles for an open approach. For minimally invasive approaches, as we mentioned, this is going to be smaller incisions and potentially several of those. Typically for a gastrectomy, there's 4 or 5 incisions, and near the umbilicus is a little bit larger incision just to remove the specimen. Within the realm of minimally invasive surgery is laparoscopic and robotic, which are both considered minimally invasive. What I want to point out is the procedure is and should be the same. Just because it's done minimally invasive, we should not change the oncologic procedure or any of the benefits that we've worked on for hundreds of years with surgeons in the past. So the operation is really not dependent on the approach. Sometimes the minimally invasive approach may alter the steps a bit, but the actual procedure, which you can see here without a lot of detail, this is a total gastrectomy. The reconstruction should be the same, and while you're not seeing all the blood vessels and lymph nodes and tissue around where the tumor might be, those approaches should be the same regardless of which approach is used. I'm going to show just a few videos. This is one that benefits from laparoscopy. This is just a diagnostic laparoscopy in a gentleman with a advanced tumor. You can see the little bulging right there in the end of the stomach. Fortunately, his tumor wasn't growing through the stomach into adjacent organs, but was a fairly advanced tumor, so we did this diagnostic laparoscopy with peritoneal washings for cytology. So you can see here we just explore, we look around the liver, the lining of the abdomen, up along the diaphragms, and we're just looking for anything that might suggest that we should biopsy that to make sure it's not cancer that had spread. Once we look around, we then put in fluid. You'll see saline infusing, and that is just to wash the peritoneal linings and the organs, and then we aspirate this fluid and send it to the lab for evaluation of sometimes tumor markers, certainly cells for cytology, to see if there's any evidence of tumor spread, which can be fairly common in gastric cancer. As long as these are all negative, the patient would undergo the standard neoadjuvant chemotherapy, and then we would bring him back for the resection. This patient, as you could see on that exploration, had a very distal cancer. So depending on where the cancer is located in the stomach, it alters what we need to do. So this is a patient with a very distal cancer, so we didn't have to remove the entire stomach, but we did what's called a distal gastrectomy. So the distal, maybe 60 or 65% of the stomach was removed. That's to assure negative margins, both distally. This is what we call the duodenum coming out of the stomach that's been transected. And then we would transect proximally up in the body of the stomach or into the fundus to assure we get enough margin around the actual tumor. Here you can see let me just back that up just a little bit, if I can. Here you can see the blood vessels that have been skeletonized, so we get all of the lymphatic tissue. Since this was a distal cancer, we were able to preserve one of the branches to the upper part of the stomach. You can see that here. And so now we have about 35% of the stomach remaining, maybe 40%. And then for this situation, we would bring up a loop of intestine and hook to it. So that was a stapler that made a connection between the stomach and the intestine. And then we just sew up that little hole where the stapler went, and you can see the loop of intestine here hooking back to the stomach. Occasionally, though, either due to extensive tumor throughout the stomach or those located in the upper portion of the stomach, a total gastrectomy is required. And so you can see here, this patient had a tumor that required that we come across the esophagus. You can see the stapler here across the esophagus as it goes up into the the hiatus up into the chest cavity. So here we've mobilized the esophagus, cleared all of the lymph nodes around the area, and then now we're taking the stapler across the esophagus to disconnect it there. We'll have disconnected at the duodenum like you saw in that other patient, so that the entire stomach, all gastric tissue, is gone. This is important not just for those with cancer, but especially for those with something like CDH1, where we're trying to remove all of the gastric cells to eliminate the risk of gastric cancer. So that's the spleen in the background, and then we'll continue to remove lymph nodes along all the blood vessels, what we call a D2 resection for this. This, because there's no stomach left, we don't bring a loop of intestine up, because that would create reflux up into the esophagus. We bring what's called a roux limb up, so we make the end of the intestine come up and meet with the end of the esophagus. There's many ways to do these anastomoses. I prefer to hand sew these, as you see in this video, but many will use staplers, either linear or circular staplers, which is also very acceptable. It's really predominantly surgeon preference. So this is just, we've made a hole between the esophagus and the jejunum here, this roux limb, and we're just sewing this together. We have a tube that we put down the mouth and down through the esophagus as we sew some of the outer layers of this to make sure the opening is appropriate. So as I mentioned, just because of the approach, the operation itself shouldn't change in terms of how much stomach we remove, what lymph nodes we remove. All of that should be very consistent with what we know are good oncologic practices for gastric cancer. I would also say that the technical equipment that we use is also the same. So for instance, for resection, in open surgery and minimally invasive surgery, we use these staplers very commonly to divide the esophagus, stomach, or small intestine. And we use clips, sutures, or energy devices to control the vasculature, whether it's open or laparoscopic. For the reconstruction, again, same options in open or laparoscopic with staplers, either a linear stapler or a circular stapler, and hand-sewn techniques. These are surgeon preference predominantly. So if I'm telling you it's the same operation and we use the same type of equipment, why would we use a minimally invasive approach? I think those that have had this or know someone, they probably have many of these potential benefits in mind, and we'll talk just a little bit about these. But I would tell you in the operating room, so these are all benefits ultimately to the patient, but certainly to the surgeon to be able to do the best job they can do. You have a magnified view of what's going on with high definition video. And then I think what is important as well is because we're doing it minimally invasive, we have a camera looking at what's going on in the abdomen that's then projected up on monitors so that every member of the team in the operating room is able to see exactly what the surgeon sees. And that is not the case in open surgery, where you probably have seen pictures with residents or people trying to look over the shoulder of a surgeon and see anything they possibly can. I think this helps with efficiency of the operation, but it also helps to have more eyes to make sure we're seeing everything and doing everything appropriately. Another advantage with a minimally invasive approach, there's really no open abdomen during the case, essentially. And what happens when there's a laparotomy incision is the moisture from within the abdomen on the organs and the lining is some of that evaporates and is lost. So there's fluid losses, and this can result in different physiologic states or need for additional fluid. Minimally invasive, that does not occur. And so as a result, most patients will get less fluid than if we do it with a big open incision. Also, there's a decreased blood loss, and there's lots of reasons why this may be the case. It may be the fine instruments we use, the magnified view, but certainly the pressure created by the CO2 that we insufflate into the abdomen creates a bit of pressure on small veins, and that is thought to help contribute to the decreased blood loss seen with most studies evaluating minimally invasive approaches. Well, what does that mean for the patient? Well, post-operatively, Smaller incisions, we don't cut through the muscles of the abdominal wall, so there's less pain. And there's also decreased wound complication rates. And this all results in a quicker recovery. So who is a candidate? And there's conferences that go on all the time going through exhaustive lists, and people agree or disagree, but I would say that essentially all patients are appropriate for at least consideration. Just because we can do it that way, though, may not be the appropriate reason to offer minimally invasive, because there are situations where we need to consider that. In terms of absolute contraindications, I don't think there are any, because most of the contraindications are a judgment based on a lot of different things. So let's talk about a few of those. Number one, I think a lot of it is based on surgeon experience and the hospital resources. As a surgeon's experience grows, and we've seen that with every area of surgery, whether it's open or minimally invasive, whether we're talking about a gallbladder removal or other procedures, with more experience, the surgeon is able to take on more difficult operations. So early in a surgeon's experience, there's probably a longer list of relative contraindications than later in their experience. But certainly there are conditions that increase the technical difficulty of these operations minimally invasive. Obesity is one of those. Obesity creates a problem even for open surgery, but it can be very difficult in laparoscopy to be able to get, for instance, enough view if the abdomen doesn't stretch enough or there's too much adipose tissue to be able to see the vessels and the organs that we need to identify readily. Extent of disease. So again, with time, these can be done, but if the gastric tumor is infiltrating out of the stomach into the colon, the blood supply to the colon, to the pancreas, that certainly increases the difficulty in a large magnitude, and that is going to be dependent on the surgeon's experience with removing those other organs. Prior abdominal surgery is certainly a factor. If there's been extensive liver or gastric surgery in the upper abdomen, sometimes that can make it much more difficult. Or even just any operation or infection within the abdomen can create a lot of adhesions. And while it's still possible to lyse those, that does take a lot longer to do laparoscopic in many instances when there's hours of lysis to do, and that may not be in the best interest of the patient in order to preserve them the smaller incisions. So that may be a good reason not to do it as well. Very rarely, but occasionally, we'll see patients with significant medical comorbidities such as severe heart disease or lung disease that they might not do as well with the prolonged intra-abdominal pressure of the pneumoperitoneum, and so those are things to be considered as well. Well, let's talk a little bit about outcomes. So what do we want to assess? First, let's look at some short-term outcomes, and that would be about complications, would be blood loss, wound infections, things like that. The recovery, how well did the patient recover, both in the hospital and shortly after dismissal? And what was their quality of life like? Did they need chemotherapy after, and were they able to get to that chemotherapy as a result of the operation that was done? But obviously, very important as well is the adequacy of the cancer operation. And so how do we assess that? We wouldn't expect a recurrence to happen in the first week or 2 or 4, but we use surrogates for how well we do as far as a cancer operation. And those would be the number of lymph nodes that we remove and what lymph nodes we removed, and then the margin status. So those are at least give us an idea of how adequate the cancer operation was. Next would be the long-term outcomes, which is really what every patient wants to know. You did all those things. What does that mean for me down the road? And so we need to look at long-term outcomes, and that would be ultimately the survival and the recurrence of the disease. Obviously, even the best surgery is not necessarily going to prevent recurrence from showing up in the liver or the lungs, which would suggest those cells were there prior to the operation. There's a long list of studies that have been done over several decades, and I could have spent probably a good hour just on those. And I've chosen just to highlight a few of the more recent, better studies. But I just wanted to point out that there's been a lot has been done comparing laparoscopic or even robotic to open approaches over many years. Initially, some of those studies were not very good quality because of the limited experience. There's bias in that the surgeon, when they start doing these minimally invasive, they may select out patients that would be easier to do, maybe not as advanced tumors, maybe they're not obese or other factors. But the quality and the scientific validity of these studies has definitely improved as we get more experience as surgeons, but also as the volume of patients who have undergone minimally invasive procedures increases so that we can do statistical comparisons. The overwhelming majority of these studies suggest several advantages for minimally invasive approaches. This was not surprising. This has been shown in most areas of abdominal and even thoracic surgery where minimally invasive approaches offer several advantages. Here's one study I just want to bring your attention to. Gastric cancer is very common in certain parts of the world, in Asia specifically, and this is a group of Korean surgeons from many centers that did a randomized controlled trial. And I want to point out a couple things. This was just for locally advanced, so this wasn't early gastric cancer. They had 1,000 patients in just a little less than 4 years. I can tell you there is no center in the United States that does 1,000 gastrectomies for cancer in 3 or 4 years. This is a lot of volume, and so that's why I like some of these studies. They're not perfect either, but the volume is nice to be able to compare. They looked at how adequate was the lymph node removal, and so for these types of tumors in patients that were included in this study, a D2 resection, lymph node dissection, was appropriate. And they showed that in these groups, these two groups, laparoscopic and open, over 99% of the patients had D2 resections. The margin rates and number of lymph nodes retrieved were similar, suggesting that there was equivalent oncologic short-term outcomes for both laparoscopic and open. They did note that the operative time was longer in the laparoscopic group, but the blood loss less. You can imagine certainly earlier in the experience, and even sometimes now, some of the approaches do just take a little bit longer than open approaches. Certainly the robotic experience has shown that. Overall complications, pain, return of bowel function, and hospital stay were less for the laparoscopic group. Again, pointing to those expected potential benefits that we were hoping for. 90-day mortality was very low in this group of 1,000 patients, less than 1% in both groups, and was not statistically different. This was the group's efforts to look at the short-term outcomes. Subsequently, they looked at 3-year outcomes of the same group of patients. So this is this class 2 RCT, this randomized controlled trial. So the exact same patients just followed out further. And they looked at late complications and found that late complications were also less in the minimally invasive group, predominantly bowel obstruction. And we know that from other operations in the abdomen that minimally invasive approaches generate less scar tissue and adhesions that can ultimately lead to bowel obstruction. Importantly, though, the 3-year, what they called relapse-free survival rate was similar between the two groups, again suggesting not only that short-term outcomes, the surrogates of oncologic resection, were similar, but now we even have some data in terms of recurrence and survival. So in summary, minimally invasive surgery for gastric cancer is safe, feasible, and provides advantages over the open approach. Most patients are candidate based on surgeon experience and hospital resources. Favorable long and short-term outcomes are evident at experience centers, and I say that specifically because sometimes these centers that do 1,000 gastric operations will report something, and a small hospital in a community will try and do one and expect the same outcomes. That's not going to be the same. The oncologic outcomes are similar. There's really nothing that would even make sense to us that it wouldn't be as good as long as the surgeon follows all of the skills or all of the steps and the safeguards like we talked about on the first few slides of not changing the operation in terms of the oncologic muss for the procedure. Thank you very much. Happy to answer any questions. Any questions now? Or
questions at the end.
okay, yeah, in the panel. Great.
Thanks, Dr. Kendrick, for that great, insightful, minimally invasive talk. I particularly enjoyed the videos. I'm not sure if the other audience members did, but I think it's always nice, even for those that aren't allowed in the operating room, to sometimes see things through our eyes and how we see it. The next person that will be presenting is Dr. Pashtun Kasi. Dr. Kasi is a GI oncologist in the College of Medicine and Oncology and at the University of Iowa in Holden Comprehensive Cancer Center in Iowa City. He's an associate professor in the College of Medicine. He's board certified in oncology, hematology, and internal medicine. Additionally, he has a postdoc and master's in clinical and translational science from Mayo Clinic School of Graduate Medicine. His clinical and research interests include work on liquid biopsies, also known as circulating tumor DNA or cell-free DNA, and circulating tumor cells. His work and interest in this novel and exciting area of liquid biopsies is what he would be talking to us about today. I'd like to thank you. Yeah.
Again, thank you so much for the opportunity. As mentioned, I'll be talking about this novel area of field of research, liquid biopsies, often referred to as circulating tumor DNA or circulating tumor cells. We'll be broadly talking about, what does it mean and how do we use it. My email as well as my Twitter handle is listed. I would love to continue some of the discussion online later. These are my disclosures. I have been a part of consultancy and advisory board for some of the liquid biopsy companies, and we will be talking about some of the off-label use of ctDNA and CTC testing. So the main learning objective of the talk today, I wanted to introduce this broad area of clinical as well as research that's having a tremendous impact in many solid tumors, including stomach cancer and esophagus cancer, for which we're here today. But a lot of what we'll talk about today is very relevant to other GI malignancies and even other cancers like breast cancer or lung cancer. On Twitter, these are some of the hashtags to follow if you wanted to follow some of the topics on related to the area of research of liquid biopsies. Now, what do we mean by liquid biopsies? It is a misnomer because there is no biopsy being performed. It is just a blood draw. What's happening is a lot of the research in this and also a lot of the practical implications, they all originated from pregnancy and prenatal testing. Almost 20, 30 years ago, this technology is not new. For some of us who may know, you can get a blood draw if you're pregnant and get to know the sex of the unborn child as early as 8 to 10 weeks of pregnancy now. You could also know if there are genetic syndromes as early as first trimester. That's because as the fetus or the unborn child is growing in the mom's womb, it's shedding its DNA in the blood. And with technology that goes back to as early 2000, you can separate the fetal DNA from the mom's DNA and tell the differences or tell the sex of the unborn child or see if there are any syndromes or not. The same concept, the same technology, in fact, some of the same companies who have been doing liquid biopsies for pregnant individuals for the past 20 years is the same technology that is now being involved in tumor testing, because if you think about it, the tumor is also a foreign object or a foreign being in the person. It is also shedding its DNA as well as cells into the circulation. And with just a simple blood draw and techniques, we can separate out cancer cells and cancer DNA, which can then be tested in the same principle as you would test a real biopsy. Because you get information the same way as you would in a normal biopsy, the term liquid biopsy has commonly been used, but essentially it's just a blood draw. And that's what is very important from a patient standpoint, as well as a provider standpoint. It's a non-invasive, simple blood draw that can be repeated as many times, as opposed to a real biopsy, or for that matter, sometimes a biopsy is not enough and we need surgery for tissue or genomic testing. Now, within liquid biopsies, you'll see different terms, different acronyms, different abbreviations being used. And liquid biopsies not only provide us information about circulating tumor DNA, often referred to as ctDNA. The other term often used is circulating cell-free DNA or CCF DNA. And the reason why you see the term CF DNA, as I mentioned earlier, a lot of this technology was from prenatal diagnostic testing circulating cell-free DNA in normal individuals. That's why you see the other abbreviation. But in the context of tumor, the most appropriate acronym or abbreviation would be the ctDNA. The other thing that's very relevant for our patients with stomach cancer and esophagus cancer in an era of immunotherapy is you can now also find out something called the microsatellite instability or the mismatch repair, for which, as we know, up to 10% in some of the series of stomach cancer patients have what we call MSI high or the Lynch syndrome. And those are individuals who have tremendous responses to immunotherapy. And this information can now also be obtained from the blood draw. So the liquid biopsy these days is not only giving information about particular mutations or amplifications like HER2 that you might have heard multiple talks today about, but also other things like MSI high. Even within circulating tumor DNA, there are now different kinds of tests being ordered. Some are already approved, FDA, as well as Medicare for use in advanced or metastatic cancers, but some are also now in research, and there are a number of publications already reported later this year. And soon it will be something that would also be available for our patients with stomach and esophagus cancers. The broad category that I wanted to introduce our patients and advocates to is something called tumor-informed platforms versus something called tumor-agnostic platform. As the name suggests, tumor-informed platforms means that a piece of tissue has to be sent to the company, and they pretty much make like a barcode of what is unique to your own cancer's DNA. And then by doing a blood draw, they see if that same barcode of genetic mutations are present in the blood. It's used primarily to answer the question, let's say if somebody has a curative surgery or the question is, is all the cancer taken out? Am I cured or not? These tests are being used to answer the question of something called minimal residual disease, meaning that is there any leftover cancer after curative surgery? So its use is mainly primarily in early stage situations. However, a lot of the tumor agnostic platforms where no tissue is sent, this is relying on panel-based testing to report out what's present from a mutation standpoint and what's unique about this cancer, or is HER2 present or not, or am I a candidate for immunotherapy or not? So those kind of questions. It is having an impact at all phases of a journey of a patient with cancer, not just for advanced cancers at the time of treatment response or resistance, but also to answer this question of, like I said, minimal residual disease or leftover cancer after curative surgery. And a few weeks ago, even tests that are that may be used for diagnosis, just like a colonoscopy or mammogram for colorectal cancer or breast cancer, there are now blood draws, blood tests using similar technology that are being proposed to be used as screening tests to catch cancers potentially at an early stage, as opposed to later when it's already advanced or metastatic, and we know how outcomes become very dismal when you catch the cancer at a later stage. So not just for stomach or esophagus cancer, this is something that's truly is having an impact at an exponential pace for many solid tumors. Even though this is a more of a research publication, it is still a very good read, published in March 2018, that talks broadly about what liquid biopsies are, how it is to be used, what are the challenges. So just a reference which is online freely available in the Journal of Clinical Oncology from our oncology societies as well as pathology societies. It is a good read for our patients and patient advocates as well, who are trying to understand what this exciting field is. And while the conclusion from the March 2018 paper talked about that maybe some of this is not ready for prime time, there have been hundreds of presentations and publications and posters and abstracts at a lot of our conferences. Just to give you an idea, 2014, 2013, if you looked up the term ctDNA or liquid biopsies, there were only 10 or 12 publications for all cancers combined. Nowadays, there are at least 300 at each of our medical conferences. So I would question that the argument that if it's not ready for prime time for a lot of the institutions, it is something that's already being integrated for some of our cancer patients. And again, these are not my slides. These are slides from discussants, experts from other institutions that are GI oncologists, where they're also arguing that a lot of this technology is already ready for prime time. And there have been recent updates too. This is a paper focusing on colorectal cancer, but again, the main focus is ctDNA applications, and a lot of the challenges and outlines that are mentioned here are very relevant for our stomach and esophagus cancer patients too. And again, these are not my conclusions. For a lot of the issues that some oncologists or researchers may have voiced regarding the use of circulating tumor DNA testing, it's a lesser concern in metastatic disease where there's a lot of shedding, and I'll show you some data regarding that. So, the biggest utility, at least for our patients with stomach or esophagus cancer, is we know that the advances for our patients are coming in subsets, meaning that we have better drugs for the ones who are so-called HER2 positive, the ones who have something called MSI. Often you need to be able to test these things. For stomach and esophagus cancer, these are some things that are considered a minimum for every patient who has advanced metastatic cancer, to be able to offer them something beyond chemotherapy. And one new wave of approvals by FDA is on the right-hand side, shaded here in green, are some of these agnostic approvals, meaning that it doesn't matter what kind of cancer you have, as long as the lock is present in the cancer, the key, as in the medication, could be prescribed. This is true for immunotherapy for MSI high or mismatch repair deficient or Lynch syndrome patients. There is something called an NTRK fusion. It's a rare event, but when present, these drugs, pills, they work gangbusters. They have been approved for children or adult, whether you have a brain cancer or a stomach cancer or colon cancer, it doesn't matter. As long as you have a NTRK fusion, there are not just one, but two different pills by two different companies that are approved. And this is one of the first times that FDA approved a drug regardless of what type of cancer you have. Recently, another approval that came through is for something called TMB, or high tumor mutation burden. And if that's present, patients respond better to immunotherapy, and that's also something that's approved. All these things you need tissue for, but now you can also use liquid biopsy or just a blood draw to be able to answer this question. It is actually overestimated that how often we're able to get tissue and tissue enough to do genetic testing. The fact that we ordered a test doesn't mean that it actually got done or it got resulted. If you look at some of the real world series in patients with stomach or esophagus or colon or other GI cancers, at least a third of the time, the sample wasn't sufficient. Even if the sample was sufficient, sometimes there could be weeks worth of delays. And once you start treatment, in a good way, the cancer starts melting away. So then if you do another biopsy, then you can't really get that information out. By using a blood draw within 7 to 10 day turnaround, you can get that information in a very swift fashion. So this goes without saying that, stomach and esophagus cancer advances are coming in subsets. These are not just one cancers, but are a group of different diseases driven by different mechanisms, and all may have certain markers that can be detected in blood, such as the ERBB2 or HER2, which is almost 30% of the stomach or esophagus cancers. This is something that can be detected in blood, and there are many drugs now approved in that context. The other thing that's happening for our patients with stomach and esophagus cancer is advances are not coming just because of one wonder drug. It's just that we have multiple drugs. Shaded here in blue are the traditional chemotherapies. Then we have the targeted HER2 therapies. Then we have the PD-1 or the immunotherapies. Then you have other biologics that affects the blood vessel growth, like the ramucirumab. And then you have other chemotherapies, pills, antimetabolites, other HER2 drugs. So they all are pushing the needle forward, where the folks who unfortunately would have died within months are living in the order of years, mainly because, like I said, not just because of one wonder drug, but many drugs that can be used one after the other after the other. But then what is actually happening is, when you keep doing that, it would be a mistake to assume that in somebody who, for example, got diagnosed with stomach cancer, let's say 3 years ago, went through several chemotherapies, HER2 therapies, for them, if they come to you for, let's say, another opinion regarding what to do next, like I said, to rely on the biopsy from several years ago may or may not be appropriate. This is because it's not like our drugs don't work. Often our drugs do work, but at some point in time, the cancer starts evolving, just like Darwin's survival of the fittest. As you can see here in this cartoon, where you might have resistant clones to begin with. It's just like, twins from the same parent. Even if they live in the same household, grow up in the same family, they don't have to have the same personalities. Cancer cells too, in different parts of our body, exposed to different treatments over different periods of time, may evolve. So it's not just one blob of black and white cancer cells. These are cancers that may have different colors in different parts of the body, especially with exposure to targeted therapies. May or may not be the same case if it was just chemotherapies, but with many now different types of therapies, targeted therapies, immunotherapies, these cancers do evolve and change over time. So as shown here in this cartoon, at the time of progression, meaning when the cancer is worse, that cancer may or may not be the same as it was several years ago. Now, it is not safe, feasible, possible, or practical to be biopsying a person every time they have progression. If as a patient or as well, that's not something that is you can do something you can do repeatedly. But with a blood draw, that's non-invasive and you can repeat it as many times. So that's where doing a liquid biopsy is attractive. Just as in a case example, one of my first experiences of liquid biopsy was in a colorectal cancer patient who had targeted therapy. At the time of progression, I suggested, another tissue biopsy, and this patient, we are seeing a rise of cancers in young, which means that cancer patients are getting exposed to multiple therapies, living for multiple years. So at the time of progression, this time, I ordered a liquid biopsy because the patient outright refused getting one more procedure or one more biopsy, even though, in the big scheme of things, it's not a big procedure, but it's still, as a patient, it can be, daunting to be doing all this over and over again. So what I found in that liquid biopsy were all these different colors that the cancers, which represent mutations that had evolved on treatment. We were able to do some radiation. And what was very interesting was down the line when the cancer spread to the lungs, it kind of reset the clock where a lot of these colors that the cancer had acquired, it was able to shed off, and we were able to use the same drugs that stopped working again. Again, these principles are somewhat relevant for stomach and esophageal cancers too, because it's been shown by elegant work from MD Anderson that a lot of these acquired clones, they decay over time. So often we quote unquote recycle or reuse some of the old drugs. And that's because potentially the same mechanisms of resistance may have faded away over time. Again, this is shown here in this cartoon, taking an example of one target therapy. Again, it's not like our drugs don't work, it's just that at some point in time they stop working. So by doing something different, what's happening is we're blocking these highways that the cancer is taking to grow. The cancer starts taking detours around it. So by doing a holiday of whatever you were doing and doing a different kind of treatment, you can potentially reset the clock. So are we curing these patients? No, but are we giving them another option and treating the cancer in a smart way? I would argue yes. This is just another example of a patient where we had multiple attempts at a tissue biopsy and they were not successful, but at all these three different time points with a blood draw, you can clearly get the basic makeup of the patient's cancer, so as a replacement to tissue biopsy. In an era of immunotherapy, this term you'll come across often is something called mutation burden. Basically what it means is the more mutations you have, the more deformed or irregular or out of whack your cancer is to your immune system. So your immunotherapy then works really gangbusters. So you're able to predict that with just a blood draw. The other advantage of circulating tumor DNA, as opposed to some of these other tumor markers, is it fades away within the order of hours to maybe a few days, meaning that if somebody did a curative operation on the patient, a few weeks later, there should not be any circulating tumor DNA. If it is, it means that there is leftover cancer. Also, if you started an effective therapy as early as within a week or two of treatment, you can actually see 90% of the circulating tumor DNA fall. So it could also be a non-invasive marker of response. Right now, we rely on scans 2 to 3 months later. Potentially, you could use non-invasive blood draw, especially as the cost of these tests is coming down. It could be something that could be used, a couple of weeks into treatment, as opposed to waiting for months, knowing if my treatment is working or not, especially in the context of some of these treatments being very expensive and not necessarily free from toxicity. This is just another example of our work showing that using liquid biopsies, you can tell apart a person who would have unfortunately progression, meaning worsening of their cancer when these colors continue to not fade away, as opposed to somebody who's responding. You can see these circulating tumor DNA clones rapidly clear the blood. This is a patient of mine, stomach cancer, 1 dose of immunotherapy, 3 weeks later, circulating tumor DNA shown here as a percentage, meaning 16% of this person's blood, the number should be 0. There should not be any circulating tumor DNA in anybody's blood. So anything more than 0 is considered relevant. So 16 is a very high number. So as you can see, this is an MSI high stomach cancer patient where immunotherapy, when it does work, it works gangbusters to the point that some experts are using the word cure with some of these patients, like this patient of mine. 3 years out, this was 2018, we're into 2021. She's still free from cancer just after immunotherapy, no surgery, no radiation. And there is some findings on the scan, but having findings on the scan doesn't necessarily mean that you have leftover cancer. This patient's circulating tumor DNA clones pretty much disappeared a couple of months into treatment and have remained as such. So you could use it as a marker of response here as shown. This shaded here in green are the ones who cleared circulating tumor DNA, stomach cancer, esophagus cancer, colorectal cancer, pancreas cancer, as well as they cleared the MSI high, the other test that I was telling you guys about. So there are many ways in which different aspects of a patient's tumor shedding some of their products into the blood, that we can use different lenses to see if it's going away, or we can quantify it as well, or if it's present or absent, that can be used to tell us if somebody's responding to treatment or not. And again, this is an example. This is not just colorectal cancer, stomach cancer, esophagus cancer. This is relevant for many types of cancers as long as there is enough shedding to be detectable in blood, you can use the clearance of circulating tumor DNA versus rise of ctDNA as good or bad signs. So you can use what we call the kinetics, meaning changes in liquid biopsies in predicting response to immunotherapy or some of these other drugs. So again, going back to different things that the blood draw can tell you, MSI high is very relevant. Like I said, at least different series, 5 to 10% of stomach and esophagus cancer have this MSI high or Lynch syndrome related stomach or esophagus cancer. In these situations, immunotherapy is an option. Sometimes the tissue sample may not be sufficient, but the blood draw can be used as a surrogate. HER2, it goes without saying, it's very important for stomach and esophagus cancer, breast cancer, colorectal cancer. And again, there are different ways of knowing if somebody is HER2 positive under the microscope. But again, with blood draws as well, these are different trials showing that the blood draws were able to detect HER2 positivity. Like in this case, these were HER2 positive patients who got anti-HER2 therapy. The blood draw detected the HER2 in 46 out of the 47 samples. And you can track it over time as a marker as well, because the other thing that's weird about cancer is HER2, for example, can fade away. The cancer can camouflage the HER2, so the HER2 drugs may stop working. So again, in the ideal world, you would want to biopsy some of these patients again, but we could do that information with a blood draw. There was some work recently presented at our European conference that shed some light on this topic. The other kind of liquid biopsy that is relevant, and there is some research that we will present later this year as well, which would be one of the first look at using some of these tumor-informed liquid biopsies to see is somebody cured or not cured after resection. What medically the term you might see is something called minimal residual disease. What that means is, after somebody's surgery, like I mentioned, circulating tumor DNA should be undetectable, as shown here in the dotted line. But unfortunately, some of the patients may not be cured, and that's when their cancer comes back. But by the time it gets detected on a scan, it might be a year or so. Shaded here in yellow is where you could potentially do a blood draw to see if circulating tumor DNA is present. And maybe these are the ones where you may need to do something different besides just watching, whether it's immunotherapy now that's now approved for esophagus cancer patients after they've had chemotherapy, radiation, or surgery. Immunotherapy just got approved a few months ago. So you could use this as a guide potentially to see who's cured and who's not. And the reason why stomach cancer is potentially a good cancer for this particular question is it's not just about the test. Like I said, some of these testing companies have been around since the 1990s. You know, they were doing pregnancy, prenatal blood work. It's the same technology, same machines. But at the same time, you have to have enough shedding of the cancer DNA in the blood for the liquid biopsy to work. Just like they say, garbage in, garbage out. If there is no substrate of DNA being spilled over in blood, no matter how wonderful of a test you have, the result is going to be zero. However, in stomach cancer, as well as some of the GI cancers, we often call them high shedders, meaning they do shed a lot of cancer DNA in the blood. So for any of these tests, you know, if you have enough cancer, you may get some spillover where you can use some of these tests to answer the question who's cured, who's not. And many studies show that besides colorectal cancer, gastroesophageal cancers are high shedders. Not surprisingly, brain cancers are the lowest shedders, but I'm just pleasantly surprised to even know that even you can detect brain cancer DNA in the blood of a cancer patient. So while this technology may or may not be relevant for every single brain cancer patient, but a lot of the gastric or stomach or esophagus cancer patient, this is something that is very pertinent. I'll show you some papers from colorectal cancer. Very similar results would be unveiled regarding stomach and esophagus cancer, and you'll see a constant theme. If you have circulating tumor DNA positivity, meaning that there is liquid biopsy showing that you have cancer DNA in your blood, unfortunately, every single time, those patients have cancer back within 2 years. As opposed to if your circulating tumor DNA is negative, it's not 100%, but 90% plus time, you're hopefully cured almost 3 years out. So again, these results are pretty drastic. Again, they're not meant to replace our current clinical, acumen and our decision-making, the pathology report and all that stuff. However, some of the results that are coming out with some of these assays are truly remarkable. The other thing, like I said, it's just a blood draw, so you could repeat it to see if somebody is circulating tumor DNA positive today, can you mop them up with mop-up chemo or immunotherapy? So it's not a static variable, it's dynamic. So the folks whose circulating tumor DNA was positive but became negative on chemo, they were still cancer-free, versus if you were circulating tumor DNA positive and remained positive, or even transiently if you became negative but then turned positive again, it's an ominous sign. Every single patient, the cancer came back. This is a different paper, different tests, same results. You keep seeing this wide split of the two curves. Within 2 years, every single circulating tumor DNA positive patient, unfortunately, the cancer is back. Every single circulating tumor DNA negative patient, it's not 100%, but as you can see, 80, 90% of the time, these patients are cancer-free years out. Again, this paper is from 2008. Different tests, same results. Circulating tumor DNA positive, cancer comes back within 2 years. Negative, hopefully cured. And we use CEA 19-9, all these other different markers. Sometimes for our patients with stomach and esophagus cancer too, they're not great markers out there. Circulating tumor DNA is something that even for earlier stages is very relevant. So, can we use it reliably to predict recurrences? The answer is probably yes. How do we use it in terms of using what we call like a predictive marker, meaning can it be used to guide who gets chemo, who gets immunotherapy? I think this is right now a research question for trials. So, where is the research headed? What are the future directions? A lot of what we have in clinic is on circulating tumor DNA. But remember the first cartoon I showed you, it's not just circulating tumor DNA. You can actually capture cancer cells in blood. A lot of this technology is very new. In my lab, we are using 2 different platforms to be able to capture cancer cells. The advantage cancer cells have over circulating tumor DNA is you can stain them for different things. So this is a patient of mine with gastroesophageal malignancy who you can check for cancer cells because cancer cells are heavier and they are less compressible, meaning that just like if you strain your coffee or tea, these heavier cells can be strained and you can stain them using different platforms. You can stain them for things like Pdl-1, which is relevant in the context of immunotherapy. You can stain them for HER2 to see who's HER2 positive or not. And it's not just one way. This on the left is the staining technology, but on the right, there are also other methods to capture cancer cells and tell them apart from your normal white cells. So it is very exciting that not just circulating tumor DNA, you could actually capture single cells, and you can even do genetic testing on single cells, which is no longer something just something for the future, but something that can be done at present using different platforms. So, in the context of stomach and esophagus cancer, this year was all about many approvals. I think there were at least 5 new approvals in the context of adjuvant immunotherapy, meaning after curative surgery, first-line immunotherapy for HER2 positive, HER2 negative, other targets like FGFR2. In this trial, actually, they used circulating tumor DNA, FGFR positivity to be able to use this new drug called BEMA in addition to chemotherapy. And then this is something that was approved in Japan, but now is approved in the United States as well. Pretty long name, trastuzumab deruxtecan, TDXD for short. This is now approved for our patients with HER2 positive cancers who have previously had prior trastuzumab or HER2 therapy. Just a couple of weeks ago, there were new research presented from the same group who had led the research that led to the approval of this drug. Circulating tumor DNA positivity of HER2 could tell patients apart who truly would benefit from the drug versus people who may or may not benefit, because like I mentioned earlier, these cancers are smart. They start taking detours around, they start camouflaging their receptors, they lose HER2 positivity. Now you could find that information with repeated biopsies, but potentially you could get that information from a simple blood draw. These are the different approvals. Like I said, this has been a good year for our patients and our oncologists treating these cancers, where we've seen many approvals. But in addition to the approvals, it's also the technology, in this case, liquid biopsies that can be used in a non-invasive way to help improve the outcomes in our cancer patients. So with this, I'll stop here. And like I said, on Twitter, my Twitter handle is @Pashtun my email is listed on Facebook as well. Would love to continue some of the discussions online. Again, we look forward to the question and answer session on the panel as well. And again, thank Mayo Clinic, my alma mater, as well as the organizers for the opportunity. Thank you again.
Thank you, Dr. Kasai. That was a great talk. I know a very difficult topic because there's so much to cover and there's so much exciting stuff going on, but you clearly are leading the way, and so thank you for sharing that with us. So next we'll continue on. I have the esteemed pleasure of introducing my colleague, Dr. Shanda Blackman. She's a consultant in the Department of Surgery, a professor in the Division of Thoracic Surgery. She has her MPH in Behavioral Science and Health Education. Her clinical interests and research include esophageal cancer, minimally invasive surgery, remote patient monitoring and patient-reported outcomes, and digital technology platforms to enhance patient experience. She's a minimally invasive thoracic surgeon. She completed her training at the Baylor College of Medicine in Houston, Texas. She was awarded the clinical instructorship position in thoracic surgical oncology at MD Anderson. And then she was recruited and led the Division of Thoracic Surgery at Houston Methodist Hospital. Dr. Blackman was the chief of thoracic surgery at Houston Methodist Hospital for 8 years and served as the director of the Thoracic Tumor Board and director of the Cancer Screening Program as well. She has led esophageal support groups for the past 16 years. She joined Mayo Clinic. We were able to recruit her here in 2014, and she currently practices minimally invasive surgery in the Department of Thoracic Surgery. She holds a patent for novel esophageal anastomotic devices. She leads our Mayo Clinic Esophageal Tumor Board. She's developed an upper digestive disease app that allows patients to manage their symptoms on a virtual platform after complex esophageal reconstruction. And she's developed specialized team and tools for evaluating these complex esophageal reconstructions. She's a champion of the 3D and anatomic modeling for complex thoracic resections here. And she's just appointed as the medical director of Mayo Clinic Digital Properties Platform to advance her overall digital strategies and product roadmaps. She's currently serves on the following boards and councils: the TSF, the STS, the WTS, the AATS, and the STSA, all national societies of thoracic surgery. She's been extremely productive with over 100 peer-reviewed manuscripts and over 200 oral presentations, and she's internationally recognized. And so, Dr. Blackman, we look forward to hearing from you.
Thank you. If I'd known you were going to do that, I would have cut that in like a third. So I'll be talking to you about patient-reported outcomes. This is a topic that I'm very passionate about. Two of the people that work on my research team are here. This is something that started when I first went out into practice as a thoracic surgeon, completely overwhelmed by the burden of clinical practice and feeling like I wasn't able to give my patients the attention that they needed. I could do a complex minimally invasive esophagectomy and then follow my patients for surveillance, but I found that some of the symptoms that my patients were exhibiting required a lot more attention to detail. And they would frequently go back to their providers and find that the providers that were caring for them, either gastroenterologists or primary care doctors or medical oncologists, barely understood the surgery that we did, much less the symptoms that they were struggling with, much less how to identify if they were doing okay or if they were actually in trouble. And so we started doing a focus group and a symptom-focused support group. And over the 8-year period, my secretary sat in the room every time we had a meeting, and she wrote down the symptoms, the frequency, and the severity that every single patient complained of. And we tabulated all those, and we developed a questionnaire that completely and comprehensively assessed things on what patients care about, not necessarily what providers care about. And we're starting to learn that those two things are often very different. So I'll talk to you a little bit about patient-reported outcomes and how the evolution of our research project has led to what we're doing today. So I do have some clinical trial support, but none of it is relevant to this particular topic, and I don't have any relevant disclosures. I'd like to review the role, the scope, and the philosophy of patient-reported outcomes and remote patient monitoring. I'd like to explore a case to highlight PRO use for a patient after esophagectomy. Actually, several cases. So the first question is defining what are PROs. What is a PRO? It's a directly reported outcome from a patient without interpretation of the patient's response by a doctor or a clinician or anyone else pertaining to the patient's health, directly from the patient saying what they think their quality of life is or what they think their functional status is associated with their healthcare treatment. So what is remote patient monitoring? That's something that I'm keenly interested in. Remote patient monitoring is a method of healthcare delivery that uses the latest advances in information technology to gather patient data outside of traditional healthcare settings. Remote patient management is about moving more of the healthcare out of the traditional setting and into the home, where people live, interact with their family, and play every day. So how's that different from telehealth? Telehealth technology refers to the utilization of a telephone, a video conference, and interactive communication, much like this website that we're doing, or webinar that we're doing today, where a patient can communicate with a provider, or two providers could communicate with each other without the two of them being in the same location. Telehealth technology is about helping the patient get the care that they need without requiring them to come into the hospital. This is one of the things that we had to do during COVID. This is especially helpful during a pandemic. For example, patients might have limited mobility. They might be on quarantine at home, or they might not be able to leave work or take a whole day off from work or drive 7 hours to get to Mayo Clinic. So there are a lot of goals of our project, and sometimes when I put this slide up, everyone's eyes glaze over. But I just wanted to let you know that when we started this project, we had a lot of goals. We had a lot of things that we wanted to accomplish by enacting this patient remote monitoring project. We wanted to enhance survivorship. We wanted to expand our reach to patients, help patients identify what their problems were, give patients a common language from which they could use to speak with their providers and their caregivers. We wanted to help comparative effectiveness research. We didn't want to just have research projects that look at what the 90-day mortality is or whether or not a patient lives through a surgery. We wanted to actually see how do they come out from that surgery on the other side, and what kinds of surgeries put them in a better position compared to others with things besides whether they're alive or dead. So this is a little bit like eating an elephant. Does anyone in the room know how you eat an elephant? Bite by bite. So remote patient monitoring during the COVID pandemic became a very big part of how we provided care here at Mayo Clinic. Post-esophagectomy patients especially suffer They have a critical need for remote patient monitoring, given that these patients return to their home communities, typically at a distance far away from where they had their surgery. And to address this need, our team developed what's called the Upper Digestive Disease App. I'll call it the UDD app for the rest of this talk. It's a mobile device electronic patient-reported outcome tool that virtually connects patients and providers. Esophagectomy patients have one of the highest morbidities, mortalities, suicide rates, unemployment rates, disability rates, and impaired quality of life scores compared to the general population and even compared to other cancer patients. Advanced esophageal disease patients often require esophagectomy, which is performed in the United States at least about 5,000 times a year. In 2020, there were more than 18,000 United States esophageal cancer cases, with more than 16,000 deaths from the disease. For those of you that don't know a lot about epidemiology, if the number of people diagnosed in a year equals the number of people dying, that's a deadly cancer. Inadequate post-cancer surgery symptom control, including pain, is reported to be as high as 90% and is especially stark among minority populations, elderly patients who might have a hard time coming into the clinic, and rurally situated patients like in the Midwest. So this is our overall strategy. And like looking at that elephant, this might seem like a daunting task, but we've gently chipped away bit by bit at each of these projects and accomplished almost all of these as we've gone through the past 8 years since I've arrived at Mayo Clinic. We started with a focus group. We've gone on to creating domains and scoring those domains, setting the standard by which we color code the domains, setting normative standards by testing it on a big population of patients, looking at how the patients score versus how a provider might score that patient, and then developing an app to actually do it digitally. And now we've pitched a randomized trial. We'll talk about getting it on the App Store in a patient case. So this is how we started. And for those of you that want more information, you can merely scan the QR code that will give you more information and a link to the publication. We looked at Symptom Management Esophageal Support Group that ran over 8 years, located in Houston, Texas. We collected qualitative and quantitative data informing the content of the tool. We recorded the frequency and severity of those symptoms patients experienced after their esophagus was reconstructed. And we used this qualitative methodology led by a moderator, which was me. And this is actually a picture I got released from all of the patients that attended this support group, where we actually took a field trip and went to a restaurant and had a chef teach us how to cook food that might be tasty for an esophagectomy patient, because we had a lot of patients at that time that were suffering from weight loss. And the chef actually made a mashed potato thing and put a little truffle oil in there, and everybody became addicted to truffle oil after that. But lots of great memories working with this patient group. All of these people really opened up their lives and their hearts and their minds and shared a lot of information to help me to build this tool, and I'll forever be grateful for that. I think I learned a lot more than they did during those 8 years. Then we set about establishing domains. A domain is nothing more than a variable that helps you to track where a patient is. There are 2 domains that are very important that big research groups have already worked on establishing. One is called the PROMIS Group Physical Health, and one is called the PROMIS Group Mental Health. We didn't try to reinvent the wheel. We basically used those and incorporated them into our tool. We also used standardized ways of setting about descriptions of pain, and then we developed a tool with a bunch of different questions that led us to how we might score a patient on dysphagia, which is trouble swallowing. We heard a lot of the providers and patients today talking about dumping. We discovered that there are 2 different types of dumping. Dumping gastrointestinal, which is where you eat something really sweet and you suddenly have to run to the bathroom and have diarrhea, versus dumping hypoglycemia, which is where you might eat a sweet meal and then you feel like you're going to pass out and your blood sugar might drop down to 30. We also described something called reflux, which has already been well described within Mayo Clinic, and we readopted the Mayo Clinic reflux or GERD score and incorporated that also into our tool, trying not to reinvent the wheel. And this manuscript has a QR code that leads you also to the publication that describes how we set about defining all the science behind creating those domains. After we had the domains, we needed to score the domains. We needed to be able to say, For dysphagia, are you doing great, which means you're green like a stoplight? If you're not doing so great, maybe you're trying to eat things like a steak 5 days after gastrectomy. Probably that's not appropriate and you need a little education. That group we call the yellow group. They might be doing the wrong thing, but they might be having a perfectly normal recovery. However, there might be people who are in the red zone, which means you need to see a provider, you're in trouble, your outcomes are not what we would expect, and you're having a severe problem. Before we started this project, one of the biggest things that used to get me was seeing a patient who'd struggled with severe problems for years, and they would go back to their provider, and their provider would say, "You're so lucky that you survived the surgery, you just need to deal with the outcome." And to me, that was not acceptable because there are tons of patients who continue to suffer after esophagectomy or gastrectomy or complex foregut surgery, and they have severe problems and they just get ignored because nobody knows how to recognize it, nobody knows how to diagnose it or work it up, and much less nobody really knows how to treat it. So the first problem is to be able to identify it. So we had a group of providers that got together, and this QR code leads you to the paper that we published that talks about how we scored those patients, looking at scenarios and benchmarks of when we thought a patient might be good, moderate, or poor in their outcome. Now, this is not meant to convey an obvious roadmap for you to understand. It's just to show you that a lot of thought went into how we manage these patients. Basically, if you start up at the top, the patient gets an esophagectomy. They recover for about a month before they really start eating. Once they start eating, we get data on how they're doing. We give them the questionnaire. Once they take the questionnaire, they get a scorecard. Each of the domains gets color-coded. If they're doing great, they get green all the way across the board. If they're having some problems and they need some education or tweaking, they go in the yellow zone. And if they have severe problems, they go in the red zone. If they're in the green zone, they just flip right back to routine surveillance and get followed to make sure their cancer doesn't come back, and they get reassurance. If they're in the yellow zone, we send them targeted information to help coach them to get better. Stop eating the steak. It's not going to help you. Don't eat rice, and then immediately follow with water. These are ways that you can start to eat that'll help you to do better. But it helps us to not send them an entire notebook full of information, just information that they need where they particularly need to be where they particularly are struggling. And then if they're in the poor group, it initiates a message to the provider to let the provider know, hey, your patient's having a problem, maybe you should reach out. So now we've developed educational content. Thanks to the extensive patient library at Mayo Clinic, we've been able to create customized education for all of the problems that we've identified that these patients suffer from, and we send it out when they're in the yellow zone. So this is just a quick video that shows you an example of how the app works on a mobile phone. It can also work on the internet, on Chrome or Internet Explorer, or on a tablet, or on a cell phone. So you basically click the buttons, answer 67 questions, and then click Submit. Once you click the Submit button, you see these scores. These scores are easy to read, and you see where they are, and they point to what their color-coded score is. And this is essentially what it looks like when you look at it on your mobile device. Now we have clinical reporting tools that help clinicians to look at these dashboards and see how a patient does over time, see if a patient's getting better, getting worse, or staying the same in spite of sending them education. This helps us to longitudinally track patients. And this part helps us to drill into where they might have problems. For example, if they're having a problem with reflux, we can drill into all the questions that they answered on reflux and help coach them in an appropriate way. This is a collaborative project with Wellpepper and Mayo Clinic working together. So this is again how the app works. All we do is we send out a targeted email to you. You click on the hyperlink, which is listed in the email, and when you click on the hyperlink, it loads the app onto your phone, tablet, or device. Once it goes onto your device, you follow the instructions as the video showed you. This is a sample education tool that we send you that teaches you what does it mean when you score in the different colors so that you know how to read your own report. So we've just completed writing a manuscript that talks about evaluating how this tool impacted the lives of patients for the first 50 patients that we launched it in. We called 32 of the 50 patients and asked them about what their thoughts were. We looked at their digital literacy, their computer literacy, and how they work with a tablet or a smartphone or a device. And we looked at some things that we found really surprising, like one of the patients was colorblind, so the 3 colors meant nothing to them. And so we found that we need to find novel ways to share with patients who might have novel impairment. We also found these themes, these 7 themes that I have listed. Patients expressed a value of identifying the problem. Again, if you can identify the problem, that's the first step to tackling it. We also learned from patients that they felt like it helped enhance their communication with their providers and enhance their communication with their caregivers. If they could identify the problem, then they could start to tackle it with all the people on their team. They also had a sense that they weren't forgotten. You know, there's a lot of excitement when you come in and you first get diagnosed and you go through the neoadjuvant treatment and then you go through the surgery. And then after the surgery, there's, I call it the wasteland, where no one really champions your care after that. The medical oncologist or different people might offer to follow you for surveillance, but this is the real part where people start to feel alone. And I noticed from the support group that if people don't feel forgotten and they feel plugged in and they feel like we're still monitoring them, they're very grateful and they tend to continue to get better. We also noted that people felt like they were being monitored without having to come all the way back. It saved them time from taking off from work, travel, expense, cost, childcare, all kinds of problems were solved with this. It enhanced convenience. Patients did express some concerns over privacy. With the movie launching The Social Dilemma, a lot of people were wondering, what are we doing with all of that data? And hopefully you trust Mayo Clinic and know that the data that we're collecting is HIPAA protected and carefully provided only at the access of our research group with the IRB consent. Patients also had a desire for more personalized digital engagement tools. People liked it so much they wanted more, and so now the Department of Surgery is launching more remote patient monitoring projects. So there was a very high compliance, and we established feasibility and accessibility through this project. Another really interesting finding is we looked at how providers score patients versus how patients score themselves. Mike Trainer, who's one of our general surgery residents, partnered with me to look at these scores, and we found that providers are really good at saying if a patient can't swallow, probably because the patient comes into the clinic and says, I can't swallow. And we have a study where they do a swallow test and we see that they have a stricture and we dilate them. We also found that patients are really good at saying, I have stuff refluxing back up. But some of the areas where patients were not really good at conveying to physicians, or physicians were not really good at picking up on patient problems, were in the areas of dumping hypoglycemia, dumping gastrointestinal, and pain. Providers frequently underestimated the amount of pain that patients were in when they came back to the clinic. We've launched a proposition to NIH to fund a randomized trial. We were favorably reviewed and we're waiting to see if we got funded. And this is basically where we randomize patients to 2 groups. One group gets the clinical trial where they just get standard care, what we do today. The other group is randomized to the group where they get this digital app and they get coached along the way and they get phone calls from the provider. And we try to manage them to get everybody to, it's called go to green. If we can drive everyone to get into the green category, we think we can reduce the number of times they go back to the emergency room, reduce the amount of time that they get rehospitalized, and reduce their burden after surgery. We're now launching this across the enterprise to other Mayo Clinic sites, and we've partnered with Mayo Scottsdale, Arizona to launch the app. And this is just a video that shows you, just like you were looking at the liquid biopsies or the circulating tumor cells, you can take one patient score, look at the way that it looks, and then all of a sudden you step back. And I call this the 30,000-foot view. A provider can look at thousands of patients over years, over time, within the same patient population, and you can easily now pick out who's in trouble, who's doing well, who needs education. The ability to pick up those people that are lost and track them and scoop them up and save them is the very goal of this project. This is just a sample of one of my patients who came in. They took the test and this is their real score. You can see on the bottom, dumping gastrointestinal score was almost 100. This patient was eating nothing but ice cream, just like the story that you told earlier. They were eating chunky meat. They were eating right before they went to bed, and they were not elevating the head of their bed. So we coached them, we gave them the education, and the patient got better. This patient, you can see, has very bad mental health. They have a very high pain score, and their dysphagia score was very bad. This patient, because of their score, was identified to have what we call post-thoracotomy pain syndrome. They did not have a minimally invasive esophagectomy, and in fact, their chest was cut open, their rib was cut, and their muscles on their chest wall were spread open. We sent them for ablation of the nerve, and they had some blockage at their feeding tube. We took the feeding tube site down, got rid of the blockage, and this patient improved as well. Many of these patients would have gone undetected with their problems for years had we not had an easy way to pick up the problems. This patient actually had their conduit, which is the way we rebuild the esophagus, blocked by a hernia in a twisted conduit. And this is a picture of all the partners in my group. They would go back to one of these fine surgeons and have that blockage fixed and get better. Sometimes the answer is a surgical answer. This patient developed a stricture in their esophagus and was dilated and got better. This patient had early cancer recurrence in the gastric conduit. We took the gastric conduit down and we rebuilt the patient's esophagus with colon. This is a picture of Dr. Eric Dozwa and Dr. Samir Mardini and myself, all three working together, 3 different specialties, to give a patient a novel solution and rebuild their esophagus. This is a perfect example of why I love working at Mayo Clinic. We can give patients these beautiful solutions to novel situations that other places might throw their hands up and say, well, you know, you've gotten your second cancer, that's it. And I'd just like to take a second to recognize the team. Dr. Grotz has helped run the esophageal tumor board every Thursday morning. David and Amy and all the other research team members have helped to consent over 500 patients to take this app. All the teams that we've partnered together to propose the clinical trial, the survey methodologists, the psychometricians, the Center for the Science of Healthcare Delivery, the CDH group, the Center for Connected Care. I could go on and on. It takes a village to build a team like this and to get these kind of results. And I'd just like to say thank you to all of you who've helped us to do this tremendous work. In the words of Dr. William Worrell Mayo, no one is big enough to be independent of others, and certainly not us. Thank you.
All right, thank you so much, Dr. Blackman. That was very inspiring and very neat to see what you're doing for your patients even after surgery and extend beyond. Our next, we're going to have a little patient panel and a Q&A session for the previous speakers, Dr. Kasai, Dr. Kendrick, and Dr. Blackman. And so if, I think Bart is joining us remotely, and
Yes.
then Jennifer Higgins-Spires is here, and I think then that's it.
Travis, are you okay if I just say a quick thing about Bart Frazada?
Yeah.
So Bart Frazada is someone that I've partnered with for about 11 or 12 years. I met him first at the General Thoracic Surgery Club. He had esophagectomy at Memorial Sloan Kettering Cancer Center, and since he had that surgery a long time ago, he's run the Fight Esophageal Cancer Support Group. It's a national esophageal cancer support group that's run by him and his team, and invites other surgeons, medical oncologists, and specialists in the realm of esophageal cancer to join and support for those support groups. He's a tremendous resource to all of us and a voice of inspiration. He frequently speaks at most of our national meetings because he's so inspiring. And he really continuously teaches surgeons how to be better surgeons. So I just wanted to give him a little shout out. Thank you.
Thanks. Is he? There's.
Thank you.
Oh, all right. Great. Well, while waiting for questions to come in, maybe we'll get started with Jennifer Higgins. Myers, if you don't mind, just kind of telling us a little bit about your experience and your story a little bit.
Hi, everyone. So my name is Jen. I'm from Boston. When I was 26 years old, 12 years ago, I'm 38 years old now, I was diagnosed incidentally with stage 1 adenocarcinoma with signet ring cell features, poorly differentiated. It was completely a surprise to everybody. I'd been having pain in my lower abdomen. It ended up being a neurofibromatosis tumor, but they didn't know that then. So I had this whole GI workup, and instead of finding the reason for my pain, they found this little polyp in the upper part of my stomach, and so they focused on that instead of my pain, so that actually made me angry. And when they took out the polyp, they're like, don't even worry about it. It looks like nothing. It's probably a neurofibroma. And then 10 days later, they tried calling me, and I ignored the phone call all day because I was angry because every result that I had just didn't answer anything for why I was feeling so poorly. And so I was a teacher, and so I was in class, so I kept getting the phone call, and I turned off my phone. And finally, I was on a break, and I got the phone call in the teacher's lounge. And so a month later, I had a partial gastrectomy, and instead of having like a Roux-en-Y type of construction, I had a Nissen, which was very rough on me, and I dealt with acid reflux for 10 years before I relented with my surgeon to get the rest of my stomach removed, and the rest of my stomach was removed in February of 2019, so I'm about 2.5 years out from that, and I'm actually much better for that now. And I'm, of course, been cancer-free for 12 years. I actually just celebrated, if you would say that, my diagnosis anniversary last Tuesday on July 27th, so that's my story.
Still no. Any questions in the audience right now for any of our speakers?
Bard, do you want to tell your story?
Sure, I'd be happy to. Can you hear me?
Yeah.
Okay. I was diagnosed with a stage 3 esophageal cancer, adenocarcinoma, went through chemo, radiation, and surgery. And as Dr. Blackman said, in May of this year, I celebrated 21 years anniversary post-surgery. Heartburn was the cause of my esophageal cancer. And at the time, we realized there were over 18 million people in the United States that had persistent heartburn. So my wife and I decided to give something back, and we formed the Esophageal Cancer Education Foundation. And basically to help some of those people recognize that heartburn can cause this disease. The mission statement for the foundation is to bring awareness and educate the public about this disease. And the second statement is to walk the journey with patients who have this disease. We have, as Dr. Blackman mentioned, 4 Zoom monthly support group meetings for post-surgery patients, stage 4 stomach and esophageal cancer patients, as well as recurrence patients. We have a 24-hour hotline for quality of life questions. And we produced a book called Esophagectomy Post-Surgical Guide, Questions and Answers. As Dr. Blackman said, we've got a fairly extensive medical advisory committee of well over 50 doctors, surgeons, oncologists, gastroenterologists, and our whole team is volunteer, and we basically are there to support people however best we can. I think that's about it.
Wow. Still no questions online. Anyone else have any questions? Yeah.
Mainly for the surgeons, what advice would you give to patients that are at a more regional hospital or get diagnosed externally, maybe rural, about the benefits of traveling to a center for excellence or a specialty center versus going with a surgeon that might have only done 5 gastrectomies, but they're close to home for their recovery? What are some of those perspectives?
I think any one of us can answer that. I love this question. Oh, I'm sorry. She asked if we had any advice for someone that maybe is diagnosed with something and they live in a rural area and they're maybe seeing a surgeon. How should they approach that? I think the first thing to acknowledge is that there are excellent surgeons everywhere. One of the things that I think we appreciate, Dr. Blackman beautifully outlined that several times in her talk, though, is the team approach. And I think certainly for cancer care, it really has to be the team and the hospital resources. So for instance, I've done quite a bit of minimally invasive gastric surgery, as has Dr. Blackman and Dr. Grotz. But I think every one of us would admit that if we went to a smaller community, it's not just about us. It's about the nurses. It's the interventional radiologists. It's the imaging. It's the support structures that really make the difference in the outcome. So it's not that I would answer you in a way to take away a negative aspect for that surgeon who probably does well, but if they don't see this regularly, if they're not operating regularly and they don't have the support structure, I think there's lots of studies in just about any area that you want to look at. That's why volume matters. It's not so much that it's just the surgeon so good after doing so many, but it's the support. So I would say, for certain things, it's very appropriate to stay in the community. But for some of this complex cancer care we're talking about, I would suggest they get care somewhere where they have that entire big team, lots of volume, so that they're very comfortable with the complications that can happen. Because as Dr. Blackman talked about, even if things go really well from the surgeon's point of view, it doesn't always go so well for the patient. And they may not understand that that's not the way it's supposed to be. And to be honest, even that surgeon that doesn't see the volume that Dr. Blackman does may not recognize that that's something they can do something about. So I do think volume matters, and I do think a lot of these complex problems should be taken care of in a bigger center, but again, not to detract from that surgeon's ability.
I agree with Dr. Kendrick. The situation we have with our 24-hour hotline is we'll get calls from different parts of the United States saying a person's been diagnosed with esophageal cancer and doesn't have somebody to deal with. And the person that they are dealing with is basically a general surgeon who maybe has done this once or twice a year. And we kind of emphasize to them the fact that they need to solicit and look for a hospital, and we do provide them if we have somebody in the area that can do esophagectomy surgeries and have done them several times, obviously during the year, and mostly a part of the General Thoracic Surgical Club. And basically we emphasize the fact that it's not only the surgeon, as Dr. Kendrick said, but it's also the medical team behind that surgeon that provides the positive results that the surgeon has completed in his surgery. So it's very important, I think, that patients look for the number of cases that a particular hospital and surgeon have done, as opposed to whether an individual surgeon has what he says is expertise.
I would just add that the inconvenience of coming to a place like Mayo, if you live 13 hours away, is markedly reduced now that we have video visits and remote patient monitoring and all of these other features. You literally can come in, have your surgery, have your recovery, and then go home. And it's not as disruptive as it used to be now that we have these new tools that help us to manage you remotely.
Jennifer, maybe you said you experienced a lot of reflux for a very long time. Did you kind of struggle with what Dr. Blackman was saying, just a tough time recognizing that that wasn't normal, or that providers not knowing what to do about it, or did you have those kind of experiences?
I honestly thought it was just something I had to deal with because it was surgery and it was a normal thing and I just had to deal with it. That's actually how I felt about it. So I never said anything. And when I had endoscopies every year, and every couple of years it'd be a benign cell change, and my surgeon knew about this and he didn't seem to ring any alarms about it. He just said, well, I can take the rest of your stomach out. And since I had such a rough recovery from my first surgery, I was like, no, you're not. I'll just deal with it. And just kept taking acid reflux. I tried to reduce acid type foods in my diet, and I elevated my head, but none of it really did anything. And so finally, I think I had an endoscopy result that was pre-Barrett's, and so I thought, okay, I really need to do this because I don't want to have esophageal cancer, and the earlier I can have the surgery, the earlier I can bounce back. Because if I'm going to be, because maybe like when I was, it was 2 years ago, so I was like, all right, so I'm 36 now, and if this can keep going, and what's going to happen when I'm 60 years old? What's going to happen when I'm 70 years old? Am I going to have cancer in between then again? So I just thought, all right, this just needs to go.
I have a question for Bart and our other patient survivors. Bart, what would you say is one of the biggest needs amongst the patient survivor community right now? We have a lot of different things that we can offer patients, but it'd be nice to hear from you because you've got your finger on the pulse.
I think most patients feel like this is a journey that they themselves are doing and there's no help out there for them. We find in our Zoom conference meetings that what we provide is a source that they're not in this thing alone, that they have other people that can not only work with them, but are in the same situation that they're in. So creating that opportunity gives them a way of expressing themselves, a way of feeling part of something bigger. It helps with their positive attitude, which we think is a key element going forward. And the issues that we're discussing are issues that they're experiencing. So the basic results are ones that they can take on and look at and implement into their own recovery process. And we think that positive result helps for better outcomes. And I think that's one of the key elements in what we're doing in a group environment.
Bart, I know this sounds a little silly, but I'm completely serious. One of the things that I was thinking about is when I was early in my career, in the first 4 to 5 years of my practice, this type of surgery is a huge surgery and the impact on a patient is huge. If you make a mistake or you have a patient with a leak or you have a patient that has sepsis, it has a tremendous psychological effect on you as a provider. And I know our focus today is on patients, but I've often thought that we should have provider support groups to help the surgeons get through this so that we don't become blunted to our patient's illness or unemotional. I don't think I've ever had a time when I haven't cried with a patient if their cancer came back, or I haven't really felt that pit in the bottom of my stomach if a patient came to me and told me the story that you told me. I mean, the thing that I find the most inspiring about our project is seeing patients over and over again who come into clinic and say, I have been struggling with this for years and everybody's just been telling me to hang on and I know something's wrong and I don't know how to tell you that something's wrong. I had a patient who came to Mayo a couple of years ago and he took this test and he scored in the red zone on almost every area. And he said that his provider just kept telling him to hang on, hang on, hang on. And he was already 5 years out from the cancer, but he had actually tried to commit suicide because his quality of life was so bad and he was so miserable and he was losing his job. And he finally decided that he would scrape enough money to fly here and come for a consult because he had heard that perhaps we could do something for him. And we've since then operated on him and fixed the bile reflux that he had by bringing a roux limb up to the bottom of his conduit, which actually I was never trained to do. And we rarely ever do that. But his reflux was so bad that we were able to fix the bile reflux and his quality of life has gotten so much better. It's stories like that that really are inspiring to us, but the burden to patients and providers is quite tremendous.
Yes. Just to add to that, that's what I really, really love about Dr. Blackman's work, because I would argue there are very few surgeons out there that really don't care. I think they do care, and they don't know what to do with some of these issues. And I think, they feel just as helpless. And I do think that this work that she's doing is going to be able to identify, and as she publishes, what to do about when they score in this area. I think that will just enable surgeons to be able to not only help their own patients, but really have a better attitude and feel good about helping patients. Because that's what I think all of us want to do, but at times I think surgeons don't know what to do, and they just assume you just got to, you got to deal with it. Maybe this is how it's supposed to be. So I think the work she's doing is extremely important, not just for patients that are there, but for the providers to be able to offer a trip to Mayo, or if they can't do it there locally, or at least be able to identify those problems.
We have a
If I could add
situation.
real fast,
Oh,
that if all patients had access to an app like this, I really think the quality of life of everyone's recovery would be so much better, because a lot of us don't know what's normal and what's not normal. Like for me, there was a lot of suffering that I had, but I thought it was normal and I just had to deal with it. And why am I going to go complain to my doctor when I just had this major surgery, and the recovery is going to be rough? And I think, and then mental health goes down, because it's like, why can't I feel better about this? Why am I being a baby about this? And if patients know that no, it's not normal, and yes, things can get better if they know how to deal with it, I really think all surgeons should have buy-in for this app, and so I hope it gets published very soon.
and the other thing I would like to mention is that as Dr. Blackman has participated, we have these Zoom meetings, and we have 2 surgeons on every meeting. And it's interesting to note that at the end of the meeting, they're thanking us for the things we told them as happening in a post-surgery mode that they weren't aware of, that they weren't totally informed of. And one of the funny issues, one of the patients eats popcorn as a way of eliminating acid reflux. He takes a bowl of popcorn at night and hasn't had acid reflux as a result of it. And one of the surgeons said, I've told that to one of my patients. And apparently it works. It's interesting.
Well,
These things
you
that
do
come
have to
out.
be careful about the popcorn. Sometimes that doesn't go through so well.
Exactly. I realize that, but I mean, it's just funny. Some of these things work.
I think that makes it hard, because recovery is different for everybody. What
Yes.
works, like what's a trick for one person, it could be someone else's nightmare. And so
Exactly.
it's really hard to have like a protocol for, these are things that you can try to make yourself feel better, because it's not going to be the case for everyone. And that's frustrating about this type of surgery.
Yeah, I think the surgery is unique and the people are unique. And there are differences in what you eat and what you drink. And, people will ask me, you're 21 years, what's your secret? I say, I have a glass of orange juice every morning. And people go crazy. How can you do that? And basically that's what I've done, but that works for me. May not work for the next guy. So that's the key element. And that's really the process, is learning from keeping a food diary to watching what you do, to your persistence, to your whole mental approach to this is a trial and error approach. And once you find what works, lock it in and then do that. And it works.
And just to tie it all together, like Pashtun from his talk that was so eloquent, talking about circulating tumor DNA, and what you just said, Bart, everyone is unique, and everyone's DNA is unique, and everyone's tumor heterogeneity is unique, and everyone's symptoms are unique. Fortunately, Dr. Kendrick is working very hard to help those of us in the Department of Surgery to use machine learning and augmented human intelligence ways to recognize these complex patterns, so that we can start to recognize the phenotypes and diagnose patients quicker and work patients through that gauntlet of evaluation more efficiently, so that they can get to solutions in a more novel way. That takes tremendous resources, tremendous digital operation, and tremendous attention and focus. But we are finally in a time and day where things like that are within our grasp. And so just as a beacon of hope to those of you patients who are still out there suffering, don't worry, we're going to get to you soon. We're working hard.
Dr. Kasai, do you have
questions in the chat box, if I could take them live?
Yeah, please go ahead.
So there's one question from one of the attendees asking, how and where do I get a ctDNA test or a liquid biopsy test? So these are, for at least advanced or metastatic cancers, commercially available through multiple platforms, and even Places like Mayo Clinic, MD Anderson, some of the institutional platforms, including University of Iowa, they have their own panels as well. So it is something that you can ask your medical oncologist. So it is commercially available, and in a couple of instances, FDA approved for advanced or metastatic cancers. And for earlier stage cancers, it is available through expanded access programs, again, some commercially available platforms. And there's one more question about, can somebody's liquid biopsy be still negative even if they have lymph node involvement? Again, it's one of those things that comes up all the time. A positive is nearly 100% an ominous, meaning that if somebody's liquid biopsy is positive, very likely they have leftover cancer. Negative doesn't mean that there is no cancer. Negative could also mean that the test didn't pick it up, or there wasn't enough shedding. So a negative is better than a positive. However, it's not 100%, but with the timing of the test, depending on which cancer you're looking at, and also with better assays, the negative is also getting a very high sensitivity.
And Dr. Cassie, I actually had a question for you, and it kind of stems from one of the other questions in the chat. But one of the questions I get asked all the time is signet ring cell, right? So we can't see it. And so then after we do surgery, you know, we tell them, well, we're going to do surveillance and get scans, right? And how are we going to catch it when we couldn't even see it preoperatively on scans? So is there any data yet on circulating tumor cells specifically for signet ring cell? I mean, is it as sensitive for signet ring cell tumors as for other tumors, or is it still sneaky even in the blood?
So it's less sensitive. Some of the mucinous tumors, even from the colorectal, as well as similar to the signet cell in gastroesophageal and even signet cell signaling features in other malignancies too, they tend to have quote unquote less shedding. So again, going back to the previous comment, a positive is ominous, and a negative is not 100%. And it's not just the cancer, but like features like you mentioned, signet cell, mucinous features, even gastric, which is esophageal, the shedding is different. In colon cancer, even the right side colon cancer, the shedding is different than left side. Location of metastases make a difference. For example, metastases in the peritoneum or the abdominal cavity or the belly itself, they have less shedding compared to the folks who have metastases in the liver. They have the highest shedding, and then somewhere in between, the lowest shedding actually is seen in patients who have lung metastases. So it's not just the cancer, even the location of metastases, whether it's the liver versus the belly versus the lung, and the other biological features, the mutations, they all have to be taken into account. So again, you know, the liquid biopsy, like all the other aspects mentioned, it's not going to be the answer for every clinical question and for every patient. So all those variables have to be kept into the context in addition to the assay itself.
Thank you. Guess maybe this one could be for Dr. Blackman. You talked a little bit about the post-thoracotomy pain syndrome, and so maybe if you could just expand for some of our online viewers what options patients might have for treatment.
So patients who have a minimally invasive esophagectomy, by definition, do not have the rib cut or the muscle on the chest wall spread. It is possible to do the thoracic part of an esophagectomy without cutting the latissimus or the serratus muscle, but typically in that case, it still involves cutting the rib. As most of you know, the nerves run on the inside surface of each of the ribs. And so anytime one of those nerves gets disturbed, stretched, torn, or cut, it can result in postoperative pain. We think for sure that that is less frequent with minimally invasive surgery, but it can even happen after VATS because of the instrument cranking on a rib. And so we're always careful not to do that as much as we can be. When a patient is about 6 months out from surgery and they have persistent greater than 5 out of 10 pain, we call that post-thoracotomy pain syndrome. Having a clear definition of that is really important before you can diagnose a patient with it. We want to make sure that it's not associated with neuralgia or inflammation of the nerve. However, sometimes the first treatment is to try to send them to the pain clinic where they would do what's called a trigger point injection. if they can get rid of the pain by injecting numbing medicine right into the nerve and they identify where it is, now they've got a target. They've identified and diagnosed the problem. Then they can inject medication to keep it numb for a while. They can put a nerve stimulator into that area. They can put the patient on a drug called Lyrica or gabapentin or some type of neuromodulator to make the nerve not send the signal that it's irritated. And if all of those methods fail, we could try to ablate the nerve. We have interventional radiologists that work hard here to try to help work in partnership with the pain clinic to use a technique called cryoablation. And in rare circumstances, if we're operating on a patient for a different reason, but they have post-thoracotomy pain syndrome, I will take a freezing probe and freeze the nerve while I'm already in there for surgery. It's not a standalone reason to do surgery, but if they have chronic pain and I have to go back and operate for a different reason, then I will take that opportunity to freeze the nerve root in that region where it's been localized. So it's very important that you first make sure that that's the correct diagnosis and then go see an expert who specializes in that problem. Each of those techniques should happen in a stepwise manner. You certainly wouldn't go straight to ablation because that could cause more problems than it starts.
Thank you. Any other questions in our audience?
Travis, there was another question regarding if the liquid biopsy for surveillance purposes, if they are available or not. While they're not approved for stomach and esophagus cancer, during COVID, they do have expanded access program with no out-of-pocket cost for the patient if they have stomach or esophagus cancer, if they wanted to use the blood draw for that purpose. Again, it is not clinically endorsed or tested yet, but it is available for GI cancers patients through expanded access program at most centers in the country right now.
Break early or? Yeah, okay. Well, there's no more questions. We'll go ahead and break early and take a little break, and then we're going to come back and have the dietitian and a cooking demo. For the people who are here, I actually get to taste some food, and then we'll wrap up. So thank you very much, Bart and Dr. Kasai and Jennifer and Dr. Kendrick and Dr. Blackman for being here for our patient panel.
Thank you.
Have a
Thank
good day.
you.
Now that everyone's had a nice taste of that delicious little snack, we're going to go back to making eating fun again with a cooking demonstration hosted by Jason Ewalt and Jen Welper. They both work at the Mayo Clinic Dan Abraham Healthy Living Center at the Healthy Living Program, and they're going to help us look at ways that we can provide food that should be good nutrition, good tasting, and good for your new anatomy. Thank you.
Very good. And thank you everybody for being here again. My name is Jason. What I will be covering as the dietitian, a few different topics. Nutrition goals through therapy. I'll be looking at managing common problems, nutrition and fluid tips after surgery, and then healthy habits long term. So I think with the making eating fun again, the fun part will probably be Chef Jen. So just bear with me, please. So when we're going through therapy, generally speaking, the nutrition goals tend to be maintaining our weight. And most oncologists, they set a goal of between 5 and 10% of that starting weight with therapy. And with that comes getting enough calories, proteins, and fluids, as well as managing the side effects. So when it comes to tips with weight loss, you'll kind of see this throughout, but one of the biggest things is eating small, frequent meals and snacks, and really focusing on getting higher calorie items, especially in those snack times in between meals. So ideally, you'll see that last point, if something sounds good, eat it. That's obviously what we want to focus on. But also, if we're able to, getting more of those healthier types of meals and snacks. So, focusing on things like nuts or seeds, or guacamole and toast, and oatmeal and cream, and those types of items that tend to have some nutrition, but also they're giving us more calories. Drinking between meals can be a big one, especially so we're not filling up on liquids, thus we're maybe not eating as much at the meal. And then even choosing some of those more supplemental drinks, things like Ensure or Boost, obviously can have their place. High calorie, higher protein, tends to be a little bit easier to get in. When it comes to weight loss, again, similar tips, generally speaking. So eating calorie-dense foods, obviously calories are your body's first priority, so that's really what we should be looking at. If I don't have an appetite, I'm losing weight, let's just get anything that sounds good, number one. Eating a variety of foods, so gradually adding foods back into the diet, including fruits and vegetables and whole grains when we're able to. I think the big thing here is we don't want to have fruits and vegetables replace other higher calorie items. So making sure we have those higher calorie items on our plate, including fruits and vegetables if we're able to. Add calories whenever possible. So this would be things like using olive oils, butter. There's supplements that you can, flavorless powder that you can add into drinks and smoothies and things that add calories that can absolutely help. And then when we're talking about fluids, ideally drinking only nutritious beverages, so things that contain calories, milk or milk alternatives, unsweetened fruit juice if we're able to tolerate it, those types of items. Ideally water, obviously we want to get in, but we want to get more of those calorie-containing beverages if possible. So just a few ideas when it comes to nutrient-dense snack ideas and meal ideas. Things like oatmeal with whole milk and butter, or even brown sugar, banana and peanut butter. You could do things like spaghetti or pasta, adding olive oil to the noodles, extra sauce on top, Parmesan cheese, really anything addition to that meal that can add a higher significant calorie load. And then making every bite count. And I kind of reiterated this here, but just looking at, instead of skim milk, things like whole milk, again, effectively almost doubling the calories. Instead of just plain oatmeal, adding, cream or brown sugar. So if we are trying to maintain our weight, we're having trouble maybe with appetite or getting food in, again, getting those calories are going to be the #1 priority. Now, when it comes to nausea, I think first and foremost, taking our medication as prescribed or scheduled. We don't want to wait until we're experiencing nausea that then we're taking medication. Rather, you take it as scheduled to help reduce nausea throughout the day. Choosing foods that are easy to digest, so foods that essentially can quickly exit that stomach or into that small intestine. So things that tend to be more bland, pasta, crackers, toast, those types of items tend to help with nausea. Again, eating small, frequent meals and sipping fluids between meals, ideally not at meals, or at least reducing how much we're drinking at meals. really reducing the instance, one, of potential dumping syndrome, but also two, that feeling of fullness at that meal. So just a few tips when it comes to a sore throat or mouth: avoiding very hot or very cold food or fluids. Now, some people actually, the opposite is true. Very hot or very cold actually helps soothe that throat or mouth. So we generally suggest doing what works for you. Everybody's different, keeping that in mind. Choosing soft, bland foods, of course, avoiding acidic or spicy foods. And even consider using a blender, so maybe blending the soups or having smoothies or even like blended vegetables, those types of things, can really help with that throat or that mouth if it is sore. When it comes to diarrhea, again, eat small, frequent meals. Probably seen that about 4 times now. Choosing soft, low-fiber foods, limiting caffeine. Caffeine can be a cause of diarrhea. Taking medications as prescribed, and drinking enough fluid. Generally speaking, we want 8-ounce glasses or more of fluid a day if we're able to tolerate it, and that can help with diarrhea as well as the opposite, constipation. So getting enough fluid really tends to be a cornerstone when it comes to reducing some of these symptoms or side effects. When it comes to constipation beyond the fluid, eating fiber that we're able to tolerate, eating at regular times, so more scheduled times, increasing activity. So this is a big one, increasing activity to what we're able to do. And I think the big thing with that activity is finding something that we enjoy doing as well. Probably the biggest component of it all, to continue doing it. And then using stool softeners if and when required, of course. So managing common problems after surgery. So just some quick tips after that surgery: looking for softer, moist foods, as they tend to be more easily tolerated. Taking smaller bites and chewing well. So here again, we want to chew completely. We don't want to be swallowing big chunks of the food that we're eating. Probably starting off 6 smaller meals, having high calorie, high protein types of food items. Over time, you may notice that we could, if your schedule or your lifestyle, really what you're aiming for, you may notice that you can go back to that 3 larger meals over time. There's no reason you couldn't continue doing 6 smaller meals, though, as long as we're getting those higher calorie types of food items. Eating slow and stopping when satisfied. So this, really listening to your body. So as you're eating, kind of checking in with yourself as you're feeling full. We're done. We don't want to overeat, because there again we can exacerbate some of those symptoms. And then just a simple tip of having a quality protein source at every meal. Fluid tips after surgery. So generally speaking, again, 8 to 10 ounces or more of fluid each day. Depending on where we're at, this could be those calorie-containing fluids. Ideally stopping drinking 30 to 60 minutes before meals and waiting to drink 30 to 60 minutes after a meal. And this tends to be a critical component, and a lot of us, or a lot of people, forget to do this, or they're not told to do this. And this is one of those things that can help reduce things like dumping syndrome and nausea and vomiting. Again, the big thing is we want to give it enough time before we start eating, so we're not full from eating, as well as when we're eating, we don't want that potential for that liquid to push the food into that small intestine quickly, where again that dumping syndrome can occur then. And that's kind of the same idea with limiting that liquid at the meal. So it's not that we can't drink during the meals, but we just want to limit it. Generally, the recommendation is around 4 ounces at a meal. So speaking of dumping syndrome, what it is, of course, usually it happens after eating. And how it happens is basically the rapid entry of food coming into the small intestine, and you'll know because you're going to get cramps, stomach pain, diarrhea, nausea. You might start sweating, all these symptoms of this dumping syndrome. So what can we do to reduce this from occurring? Again, the big thing tends to be eating small meals, eat slowly. Again, listen to your body. When we're full, we're done. Drinking liquids between meals, I think, is a very helpful tip a lot of people aren't aware of. Keeping our sugar, and I would include our fat intake lower at meals. High sugar foods, think of very concentrated sugar foods like ice cream, for example, or fatty foods like your fried foods or those types of things can absolutely cause dumping syndrome. And then checking labels for no sugar added or sugar-free, those types of foods, again, just reducing some of those sugar-laden foods at the mealtime or snack time. Reducing heartburn or reflux, so limiting caffeine can help, limiting fatty foods, acidic foods, spicy foods, things like spearmint and peppermint can exacerbate heartburn. Avoid eating extremely hot or cold foods, and ideally stopping eating before bedtime, just so we're not eating and then laying down. That can cause heartburn or exacerbate heartburn, absolutely. And then what to do for gas or bloating if this tends to be problematic. And again, a lot of the similar recommendations: eating and drinking slow. Not using straws is maybe one that people aren't familiar with. And the big thing, same thing with chewing gum or sucking hard candy, is we tend to swallow air when we're using a straw or chewing gum, and that can cause that gas or bloating to occur. Avoiding or maybe reducing things such as beans or cruciferous vegetables, onions, garlic, these foods that tend to be a little bit more problematic when it comes to gas and bloating. And another big one is checking the label for sugar alcohols. So sugar alcohols, for a lot of us, tend not to digest within that gut, so it can ferment, cause issues. And sugar alcohols tend to be in diet products. So if you're, chewing a sugar-free gum, that could potentially contain sugar alcohol. Not all gum that's sugar-free, but there are certain brands that do, or certain like protein energy bars, protein shakes, those types of things can have sugar alcohols. Diet drinks can have sugar alcohols. So that's something just to be aware of when you're looking at that food label. Now, I think that the big thing as far as awareness goes, and this is something that we tend to speak towards even at the Healthy Living program, really regardless of what the goal is, but just the benefits of tracking nutrition, really focusing on awareness with what we're eating and how we're feeling. So tracking nutrition can be as specific, maybe as using an app. So you're looking at things like calories and you're looking at protein and fiber and sugar and all these things, which can be very helpful and very objective information, I would say. But also just tracking nutrition, even writing it down, pen and paper. And what we could be writing down is what we ate, the time we ate, how much we ate. And then from there, we can kind of connect the dots. So after we're eating, tracking symptoms. How am I feeling? Am I feeling too full? Is there pain? Do I have diarrhea? These types of things then can make it easier to kind of tease out in the diet potentially what could be causing some of these symptoms or adverse effects. Now, really speaking long term, and this is where I think the cooking demo will demonstrate this hands-on, or Chef Jen will demonstrate this hands-on. But when we're talking healthy habits long term, generally speaking, we're talking healthy weight, maintaining a healthy weight, staying as active as we can, and ideally eating a diet high in fruits and vegetables and whole grains. So when we're looking at this particular type of diet, and really what we speak to a lot at the Healthy Living program, the structure that comes up most often tends to be a Mediterranean-style diet. And really what a Mediterranean-style diet is simply a plant-based diet looking at fruits and vegetables, lean proteins, so things like your fish or your chicken, whole grains, things like nuts and seeds, other healthy unsaturated fats. So this tends to be the diet that honestly has the most research behind it, really regardless of what the goal is. Whether it, we're looking at health and wellness, reducing chronic disease, improving weight, reducing heart disease, you name it. It really kind of points back to this type of dietary pattern. Now, what we want to really limit, and notice I said limit, not avoid completely, and I think that's important because when we're looking at eating healthier, it is making it realistic. It's not setting yourself up for failure that I ate this, this more processed food and now I feel guilty and shame and I failed my goal. No, I mean, really what we're looking at is if we can eat more nutritious, healthier foods most often, that's really the dietary pattern we're looking for. I mean, obviously we want to reduce these things regardless because potentially it can cause other issues, dumping syndrome and those types of things. But in moderation, some of these foods can absolutely fit. And just looking at it a different way, this is basically the Mayo Clinic Healthy Weight Pyramid. So what I tell people when I say a plant-based diet, I think generally they right away think of like a vegan or vegetarian diet, which it absolutely can be. But also a plant-based diet, in my definition, can include animal sources of protein. But what we got to focus on is the foundation, the focus is fruits and vegetables. So plant-based diets, that's generally the structure we're looking at. That's what we want to build our plate out from. And then on the way up, we have the carbohydrates, ideally focusing more on whole grains. We have the proteins, lean proteins like chicken, fish, even like the beans, the tofu, those types of items. Healthy fats, so the nuts, the seeds, the avocados, those types of foods. And you'll see the tip top of that even includes things like sweets or other items that most of us think, oh, that's off limits. I'm, trying to eat healthy. And really, what we're trying to demonstrate is the context of the entire diet. It's not just a single food item. It's really the makeup of the whole diet. So I can absolutely have, treats once in a while, and it can fit in perfectly to eating healthy. Now, beyond that understanding what we should be eating, it's just that knowledge of how much. So this is just a really quick guide when we're talking about serving sizes. It's not, exact, but it just gives us a better idea of how much something should be when we're eating it. So, for example, when we're looking at carbohydrates here in Minnesota, a serving of carbohydrates would be about the size of a hockey puck. So quite small. I think looking at that from an objective standpoint, about a half a cup. Things like your vegetables or fruit. So your fruit would be about the size of a tennis ball. Again, not real large. I think most of our apples here in Minnesota, they're at least 2 servings of fruit. I think fat is the big one that tends to be the kicker. So a serving of fat is quite small, the size of about 1 to 2 dice. So think of like peanut butter or something like that. Not a whole lot. But with that being said, I do want to have Jen kind of firsthand experience, give you guys a little demonstration on really how we can make eating in a plant-based style a little bit easier, a little bit more doable. I think the challenge is a lot of us want to do this and we try to do this, but it can be a little bit daunting. So I'll turn it over to Jen and we'll see firsthand how we can do it as far as eating in a more plant-based Mediterranean style diet.
I'm really excited to be here. So I want to really kind of dive in and explain really kind of like how do we do this? And a big part of it is just kind of understanding a little bit of the science of cooking. And so really looking at, okay, if I have we'll say a boiled onion or I have a caramelized onion, what one usually has more flavor? Typically it's like a caramelized onion, right? So we're relying on the natural cooking process to help give us flavor. And so when we're so used to especially my background, health food usually has this really bad connotation of being boring, bland, tastes like cardboard, all of these really negative things. And really we just need to add the love to it, right? And just use that natural process to help kind of drive those flavors. So today we're gonna be making a frittata. I'm going to use broccoli. I made some samples out there and it was with cauliflower, just to kind of show the variation, how you can kind of change that up. Also feeling that you can be flexible. I think sometimes we get really stuck on recipes being kind of rigid and think it has to be very like this, but in any normal kitchen, it is never quite just like that. If things don't come on the truck, or if the grocery store doesn't have something good, you have to kind of make a substitution, and that kind of works that way for us. So I'm going to jump in and I'm going to start making the frittata, and I'm going to talk a little bit about the ingredients and kind of understanding the why, okay? So with our frittata, we have some smoked Gouda cheese, which I highly recommend getting smoked versus regular Gouda. Regular Gouda is great, but the smoked Gouda is what really gives us that flavor, right? And that's where you're going to be like, just that hint of flavor makes a big difference in the frittata. The other one is we have a sharp cheddar, and this is actually an extra sharp cheddar. So especially kind of talking a little bit about what Jason was saying about fat, and obviously there is fat in cheese, but so that's where we want to make sure we're picking a really good strong cheese so that we can have a little goes a really long way. And so that's kind of the benefit of doing the sharp cheddar and the smoked Gouda. The other thing is we have like a light sour cream. This helps kind of build mouthfeel and texture. The other thing we have too is Dijon mustard. So this is going to give us a little bit of that tanginess, right? So there's a method to our madness, and sometimes people might be like, Dijon mustard, why is that in here, right? And so that's kind of understanding why we have, is a yellow mustard okay? Absolutely. It's just a different type of tang, right? If you wanted to use like a ground mustard, that would be okay as well. We have some paprika. You can purchase like smoked smoky paprika. That's great. Also adds a little bit of color, and you would have noticed in your sample today there's a little bit of color to that, and I think we need to live life with a little more color in our food, right? A little bit of salt and pepper mixture here, and some chives. If chives is not a realistic thing for you, If a green onion is more like using the top, the green part, the stem, that works great as well. So we have some chives. And then of course our broccoli and our whole eggs. So I'm gonna get this started. This is an induction. So obviously at home, if you just have electric, that's fine, or gas. What's really important for this is we're gonna make sure that when we're cutting our broccoli florets, that it makes sense. You don't want a huge chunk of broccoli. And granted, it's going to be cooked. Kind of cutting the frittata can kind of be challenging at that point. We want to make sure we kind of get the love spread everywhere more evenly. And something I always like to kind of talk about too is in the world of cooking, we always want to kind of kill two birds with one stone. And so it's kind of maximizing my time. So for instance, what I mean by that is I could very well have half of this pan be broccoli. Maybe the other half of this pan could be cauliflower. Maybe this side has the extra sharp cheddar, this has the Gouda, right? So we could do something as basic as that just by changing up just the cheeses and like the vegetable on side. So maybe if you're like trying to like not feel like you're eating the same thing all week, every other day you can kind of switch it up with your frittata. Now this is going to be a little bit more intricate per se, so we've got a few more other ingredients, but just so you can kind of see what you actually can do. So obviously in like a normal kitchen we'd have like a sink and everything, so we're going to just kind of work with what we have and make this so you can know I do this when I go camping and stuff like this. All right, so what I'm going to do is I'm going to blanch the broccoli. I want this pre-cooked. And I think it's probably easier for you to kind of digest this when it's pre-cooked as well. We don't want it super crunchy. So I'm going to kind of break this down a little bit. If I was doing more like maybe an onion in here, I would obviously make sure this is preheated so I could saute it, get that caramelization. The thing with things like cauliflower, Brussels sprouts, broccoli, carrots, they don't release a ton of water, so we actually have to introduce the water to them. So I'm going to put a little bit of water in my pan. Heats up pretty quickly. And I'm going to throw my broccoli inside here. We want to release any little bit of water that we can and get this partially cooked. Now, kind of what I was mentioning a little bit earlier about kind of, you know, when you're cooking and kind of killing two birds with one stone, the other part to that is, let's say we were boiling pasta, or maybe you're blanching some broccoli. Well, you could have a steamer basket on top and steam your green beans at the same time and just kind of keep rotating and have that kind of prep through the week. My biggest thing that I like to teach is that we can literally prep 2 days a week, and the rest of the days we can just kind of assemble and execute. You know, maybe you're not feeling super well, so kind of cooking from scratch does not sound like something you want to do. But if you have things kind of already prepped, it'll be really easy to just kind of throw it all together, assemble, put it in the oven, set a timer, and kind of go on your way. And I think that's something that's a little bit more realistic for most people. So while this broccoli is steaming up for us, I'm going to go ahead and start cracking some eggs. And also kind of depending on where you're at in your process of post-surgery or before surgery or what have you, if the egg yolks is too much like fat content for you, you can definitely bulk up and use more egg whites for this recipe. So you'll kind of know what works best. So we need 6 whole eggs. Another thing you can think about using as well, instead of the light sour cream, you could use non-fat like plain Greek yogurt as well. So if you're like, I don't typically carry sour cream at home, that's okay. All right, so I'm going to grab my whisk. Now in the recipe, it also kind of talks a little bit about You can put your cheese on the bottom and then save some cheese for the top. But if you're like, I just need to be able to feed myself, like I don't want to go through all those steps, that's okay. Just mix it all together. That's okay as well. So I'm just going to scoop up, throw in my Dijon mustard, about 2 tablespoons. All right. And we have our light sour cream. And again, this recipe can easily be made without these items, but it sure does give it a lot of love. Here's our paprika, our salt and our pepper. Okay, so what I'm going to do now is I'm just going to grab my cheese that I already have shredded. I'm going to shred a little bit more of my smoked Gouda here. Okay, it's a small amount. And I have noticed too that in grocery stores, you can now buy shredded smoked Gouda. So if you're thinking, I'm kind of wild for shredding my own, there is an option for you. Okay, so it's just a small amount of smoked Gouda, totally worth it. Scoop this up. I'm gonna check in on my broccoli. And kind of what I'm doing right now is I'm just putting such a small amount of water just so it can kind of evaporate. So then I can just kind of pour my egg mixture right over the top of that. You can hear it doing its thing. All right. I don't know if you can kind of see inside. It's got kind of a nice little yellowish red tinge to it, and that's really a part to the paprika, which I think is kind of a nice addition. Then I'm going to chop up some chives here. Smells good. And again, if you wanted to use some green onions or scallions, the top of that would be just fine. All right, just about have enough evaporation here. And then we will just pour in our egg. So I will say something that's really kind of important when it comes to like frittatas and egg mixtures and things like that. It is very helpful to use a nonstick pan, a good quality nonstick pan. Otherwise, you have to use so much more oil, and we want to avoid that, right? I always kind of joke, you want to like taste your calories. You're not going to like eat the frittata and be like, oh, I'm so glad I put that olive oil on the outside of the pan, right? Like you want to be able to taste the smoked Gouda, the sharp cheddar cheese. Like that's where it counts. That's where it's important. So always make sure you have a good quality nonstick pan, and whatever kind of works for you. This is kind of like one of those like copper ceramic ones. I also have hard anodized ones that work as well. All right. So typically what I would do is I'd get my frittata so we have just barely any water in there. I'm just going to kind of finish whisking this, get all those chives together. Just going to pour it right over the top. And so you can make frittatas and you can do them stovetop. The trick is it does have to be on pretty low heat with the lid, right? Just to create that kind of that vacuum to go keep the heat kind of circulating within versus just coming from up and the other heat going out, right? So it would need to be. So, but at this point, what I would do is just take this out and put this right into the oven. So it's totally okay to get that good little crust on it and then place in the oven. So what I'm going to do now is we'll just let this, turn this down just a little bit. Do we have many cooks in the audience? Couple? That's good. Then this is relatable. All right, so what I'm going to do now, while this is kind of cooking up, what I'm going to do is get ready for our butternut squash fries. Let's see if I can do this slowly on here. And it's one of those things where I love fall. I feel like it's coming in really quickly. I don't like to rush it, but this is a really good fall thing to have on the table. It's these butternut squash fries. You can use other squashes too. Acorn squash is great. I will say the butternut squash just makes it a little bit easier to cut and to make it look more fry-like. If you have a, what are those little fry, well, that's not a fry daddy, the air fryers, gosh, what am I thinking? I've done that with these and it works really well. We can really limit the amount of fat there. I'm going to turn this down even more. Okay, so here is my butternut squash. I have it peeled, but I want to show how easy it is to peel. These Y peelers are extremely nice. I prefer these over the other ones, but it's completely up to you. But you can literally just kind of peel through. Obviously, it's been oxidized a little bit, so it's going to be a little bit tougher, but shouldn't be too big of a deal. So from here, what I'm going to do is I'm just going to try to cut these into some sort of a stick, right? And so obviously from like here up, it's going to be more solid, and then obviously in the globe part, we're going to have the seeds. So, and also remember that when you cook any vegetable, it shrinks down, right? So understand that you don't have to make them really small because then they're going to shrink even more. So I would say it would be safe to completely kind of cut down and use your whole side here. Something I always like to kind of teach as well is that how you hold your knife cutting like a pumpkin, a squash, a watermelon, a cantaloupe, it's really important that we're holding our knife in a very sturdy way. And what I mean by that is typically when I'm teaching classes and I see people cooking, like, and it makes sense, they're holding the handle, but they put their pointer finger on top and they're using the tip of the knife. There's a lot of room for error right there. What I want you to do instead is what I call choke up on the blade. Put your thumb on one side, pointer finger down on this side. These three fingers kind of wrap around. Now you have like more control of this knife. Shut that off. All right, so then we're going to use more of the back of the knife here, okay? So between here and here, I have way more power, I have way more control, all right? And obviously you want to be right on top of it. Now obviously this is a very low table for even a short gal like myself, but I think it's important to kind of understand the leverage idea. If we have, you know, even a tall table and we're cutting over here, it's going to be much harder to have that leverage and to make sure that we have that control, okay? So always be at the core of you, right? And so what I'm going to do is I'm just going to kind of go up here, I'm going to start and push down. It's going to be really hard if I'm trying to do it like this. My pointer finger is going to get a real good workout that way, but I don't want that, okay? So I'm literally making what I call planks. Then what I'll do is I'll take my plank and I'm going to lay it down and then I'm going to make sticks out of those planks, okay? Again, much easier. And sure, we could do the whole thing, but it's a little bit easier the smaller the stack, right? And obviously remember, this is not going to ever be perfect. There's no such thing anyway. All right. All right. Plus, look at that beautiful color. I love it. All right, so I'll do a few more. And of course, you can use your other hand to guide it. And just remember too, it's extremely hard to, I see a lot of times people are just trying to put the same amount of pressure and just like, oh, like push down. That actually is really bad idea, especially if you have a dull knife. You really want to make sure that you're kind of like evening the pressure throughout. And if you are putting too much pressure, a lot of times the vegetable can kick out. And so we want to make sure we're avoiding any accidents. Okay, so here we are, stacking them up again. And kind of another awesome thought process about this is we can think about it this way. Is so if you're like, well, geez, Jen, that's a lot of butternut squash, or that's a lot of fries, I'm not going to eat all that. The way that I would look at this is we could literally take the rest of this, and this would get, maybe it's mashed and pureed, and you're saving this for a soup. Okay, or maybe you're going to add this to maybe some sweet potatoes. But this can be something where you puree it or you mash it, right? It doesn't take much effort for this. And then you can put it in the freezer, and now you have that ready to go for you. So again, one of those nights where you're not feeling the best, you just want a good meal, you want a quick, easy, you don't want to have anything processed. This is a good way to set yourself up for success. You could also just take these, and what I call like individually kind of quick freeze them. So literally put them on a baking sheet like this, keep it pretty spread out, put them in the freezer for maybe 30 minutes. Once they're pretty solid, then put them in a nice Ziploc bag, get all the air out, and then put them in. That way they're not going to stick together. So that's another idea that you have too. So you can pull them out, and then what you would do is you would cook them at a higher temperature from frozen state. So you have to kind of take into a little bit of account for the moisture. And so when you have a higher temperature oven, that'll kind of evaporate that extra moisture, so then it can start to kind of like brown it and cook it right away. Otherwise, what sometimes happens is it just starts to kind of steam, and all that water sits there, and then we don't get like a nice little crispness to it, okay? If that makes sense. So I've got my squash fries ready. The only other ingredients I have is a little bit of oil, I have some salt, and I have some fresh herbs. Something I always like to really kind of remind people is obviously fresh is always going to be best, because it is the flavor is so much more powerful and intense. And when you're doing things like using dry rosemary in this application, it's a little hard because you need moisture to rehydrate that flavor so that it can release. And if we just put dry rosemary on here, A, it's probably not going to stick super well. B, you're probably not get the most flavor. So especially when we're trying to really enhance flavor, it's really important in this application to try to use fresh. And honestly, what I'm doing this fall, once my rosemary plant is on its last leg, is I'm going to take it all up, chop it, put it in Ziploc bags, and put it in the freezer. So I just have it ready to go. Again, some of this stuff is going to take a little time on the front end, but once you are in the kitchen, you're like, man, I'm so glad I did that. So then we have our fresh thyme. And I know this is kind of corny, but it is. It's very time consuming to kind of pick off the leaves. But you don't want to necessarily fill up all your volume with the stem, because it's just going to be really woody and fibrous. So we just want to make sure we get all the love chopped up nicely. All right. The other part to this is we want to make sure that we have really finely chopped herbs as well. So I think a lot of times we get kind of, I don't necessarily want to call it lazy, but you know, if we're not using a proper technique, we can end up having, you know, some people call pine needles in our food. And so we want to avoid kind of that mindset. So what we're going to do is, again, being on top, in the center, using more of the back of the knife, because out here, it's going to be really hard. We're not going to get really anything done. We want to keep more of the tip of the knife on the top. And again, if you are thinking about this, we could very easily do, well, not that you want to have rosemary and thyme and everything in 1 week, but you could very easily kind of cross-utilize this ingredient. I think it's important to kind of know what you have and what you can have, and then just kind of duplicate that. So, and really what I mean by that is, you know, if you're going to have rice throughout the week, you know, it's a good idea to make a large batch of rice, portion it, put it in the freezer or the refrigerator, and then pull it as you need it. Same thing with pasta. That also kind of helps with portion control too, I feel. If I know that this is supposed to serve, you know, 6 meals, maybe you're cooking for 2 of you, and then you know you have to divide it into 3 bags, 2 per bag, right? So I think it's important to know that a lot of these things that we can do, we can cook ahead, and it'd be really easy and successful, but not a lot of work. I think that's always important. Okay, so you see I've got these herbs really, really nice and fine. So what I'm going to do is I've got a bowl here. I'm just going to place my squash fries in here. Now, always keep in mind, obviously butternut squashes come in very different sizes. So sometimes the weight is not always the same. Maybe you have a really big globe, you don't have a lot of stock. Kind of keep that in mind. So if you need a little more oil, that is okay. If you need a little more herbs, of course that is okay. But by putting everything in this pan first, in this bowl first, we're able to more evenly season, which I think is really important so that every bite is a good bite. So by tossing it in a bowl versus throwing the fries on here, drizzling the oil, throwing the herbs on, you don't necessarily get that nice even seasoning. So what I'm going to do is I'm just going to kind of drizzle our oil over the top. I'm going to put in our herbs here and our salt. I prefer to use a kosher salt. I feel that you get more bang for your buck, meaning you get more flavor for the amount of sodium. So even though if you were to look up iodized salt, the sodium by volume would be the same as kosher, but it seems like you need a lot less salt when you're using a kosher salt. It just seems like the quality is better. So at this point, we could literally put this on our baking sheet, put this in our oven for about 15 to 20 minutes. Depends on if you have convection or convention cooking. Sometimes people have both. So the difference is if you have a convection oven that has the fan, and what that's doing is it's circulating the air throughout the oven consistently, whereas conventional oven is just using the heat elements on the top, and that heat is just kind of going up and down throughout. I think sometimes what is beneficial if you're using conventional cooking, just to rotate your pan a little bit and move your butternut squash fries around as well. The other part too is we want to really kind of separate this out because you do get a little moisture, and you probably would have noticed that. Obviously, I had to travel the butternut squash from my kitchen to here, so there's probably not as much crispiness. But if you can kind of see and look up closely, they are shiny. So you are able to notice that you can use a really small amount of oil to achieve kind of that French fry look, right? Versus if we were to dump oil over the top of this, you would have some parts that could get nice and crispy and other parts that couldn't. So that's the biggest difference and why we want to toss it. So whether this is potatoes, this is chicken, this is shrimp, whatever it might be, it is the best to toss it into a bowl, and then we can evenly season. So then we would just put this right in the oven. All right, the next one is one of my favorites, is the turkey burger. So what I love about this recipe in particular is it is so versatile, and you can really change it up, and I mean really change it up. So we could literally we have a foundation, right? The foundation, and we have onion powder, garlic powder, we have some cumin, salt, pepper. That's a pretty good foundation, right? But we could jazz this up. We could substitute the onion and maybe do a really nice roasted poblano, right? After it's been nice and cooked, chop that up and mix that in, right? We can add maybe a little bit of cheese inside. We could almost go Italian style, almost make it turkey sausage meatballs if we wanted to. And we could add fennel, Parmesan cheese, and Italian seasoning versus the cumin. We could still keep the staple of the onion powder and the garlic powder, but we would change up some of the other variables. So it's a really great recipe where I feel I'm kind of sick of that turkey burger like this. We could make this into a meatloaf. I mean, there's so many avenues that we can keep kind of, again, that foundation of seasoning and then build on it how we want to change it up a bit. So maybe if we're doing like the meatloaf, we would probably omit the cumin and the cilantro, but maybe we'd add in a little bit of brown sugar to it. So there's a lot of variation here. Because we are using lean ground turkey breast meat, or maybe it'd be chicken breast meat, the biggest thing is to make sure that you don't overcook it, because then we're really dealing with super dry, right? And what do we do with dry food? We overcompensate with sauce. At least in my family, it's like ranch and barbecue sauce. I'm not saying that I cook a lot of dry food, because I don't, but just kind of knowing that that's typically what we do. And so then that's just more calories, or it's more things that we don't necessarily need or want, or it's just not using our calories in the right way. So what I want to kind of demonstrate here, I'm going to kind of put this to this side. Frittata looks just about done here. Get another pan going. All right. So I'm going to dice up an onion, and this might seem super silly, but I think it's good to kind of know another way of dicing an onion. So I always kind of say cut off North Pole, cut off South Pole, at North Pole, cut it in half. That's really just a point of reference. I have really no idea which one's which. It just helps know which way to cut it. Plus, it makes it easier to peel. So from there, what I want to do, and I don't know if I need to move this for the camera or not, but you want to just kind of lift up, okay? And I always kind of say cut over the rainbow. So I'm just going to kind of slice, pull out my knife, okay? Keep it together. This might prevent a little bit of tearing. I can make no guarantees, however. All right, and then from here, what I'm going to do is I'm going to go in a little bit of an angle, okay? And then I'm going to just kind of chop it. And once I feel like I'm running out of, space to hold it, I'm going to lay it down, because now I have more surface area here. And then I'm going to kind of continue to chop my onion how I need it. Okay? So what I'm going to do is I'm going to lightly saute this onion, because we're making such small little turkey burgers, I don't necessarily want this onion to be crunchy. I want it to be nice and caramelized, because I want to drive that flavor, okay? Give this a little bit of time here. Doesn't take too long. All right, so while that is there, I'm also going to kind of chop up some cilantro, get this ready. So I always kind of say love is in the leaves. Obviously the stems are fine if you get them in there, but just as a general rule, if you're trying to measure things, you don't want to make sure you're not wasting volume on the stems. We want to get all that love from our leaves. Okay. And again, using the back of the knife and chop it really nice and fine. Whether you're chopping, ginger and garlic for a stir fry, you're doing rosemary and thyme, just like for our butternut squash fries, cilantro for a pico de gallo or this burger. It really is important to make sure that we chop it pretty finely. And I do notice sometimes you go to restaurants and they have just really big like stems of it, and I just feel like it's overwhelming, and especially if you have picky eaters, it's a little bit easier to have more of a balanced flavor throughout. So chopping it small, it can be really helpful. All right, sounds like we've got a fairly warm pan. And if you're ever unsure, you're like, I don't know, is it hot enough? You can always take a little bit of water on your fingertips, or just dump it out. You want to hear it sizzle. Again, because we want to rely on that natural process to give us flavor. Because this is a hard anodized pan, it's a non-stick pan, we're able to get away with using a very small amount of oil. Because I'm really sure you're not going to taste the turkey burger and be like, that olive oil is really tasty that she cooked those onions in. Okay, so we want to make sure that we're being realistic. We just want to get these nice and softened, get a little caramelization on it. All right. Some other things that you can do if you're wanting to avoid using like panko, or if there's for some, maybe there's a gluten intolerance as well, you can use things like quinoa in place of panko. And so typically when I have anybody that is gluten-free or gluten intolerant, I'll either use gluten-free rolled oats, or I'll use quinoa as my kind of like my bulk, or to kind of make a little bit of it sticky. This is panko. These are just like a Japanese breadcrumb. They're a little bit lighter. I like that versus a breadcrumb, because those typically are kind of dense and heavy. We want this to be kind of a nice burger. You should be able to see a little bit. It's already kind of getting a nice little brown color. That's good. That is love. That's what we want. So kind of going back to making sure that we don't overcook our turkey burgers, getting a thermometer, a great thermometer, is some of these digital ones are a little bit better. You want to make sure you're cooking it to 165. And a lot of times what I'll tell people to do is cook it to 160, let it sit. You can have the heat off, let it just sit in the hot pan, let it carry over cook. That way you can have a nice juicy burger, and you're not trying to, again, overcompensate with barbecue sauce, ketchup, and all those things. And you can just feel like, oh wow, like I'm okay having something super lean, and you're not like feeling that you're missing out on anything. So kind of talking a little bit back again about our seasonings, we have some onion powder, garlic powder, we have cumin, kosher salt, we have some black pepper, and I'm going to put in some eggs. Now the thing with eggs is depending on the size of the egg. So I'll start off just using one egg, just kind of see how the mixture is. You don't want to get to the point where it's too wet of a mixture. And obviously you can add more panko if you needed to, but we kind of want to avoid that if possible. And again, I think if you can kind of see, I have some really nice color here. And again, this is just flavor. That caramelization is going to taste so nice. I'll let that sit in there just a little bit longer, and then we'll get going here. I'm going to go ahead and add in all my spices. And I highly recommend if you make this recipe like, gosh, that's actually really good. I like that. I think this is really realistic and doable. What I would recommend is to make a large batch of this mixture and patty some out, and then just pull them as you need them. Like, this is always about being more efficient for you. And maybe you just take, maybe it's half of this package of ground turkey breast is going to be turkey burger style. Maybe the other half is going to maybe be like Italian style. And what better way to do it when you're already kind of getting your hands dirty? And you can kind of, again, kill two birds with one stone. And maybe you want to sear burgers and then sear meatballs, let them cool, put them in the freezer so you can pull them, put them in the oven, put marinara sauce over it, put some foil over it, put it in the oven, and then just wait till it's fully cooked. Right? So there's a lot of options to make this much, much easier and straightforward. Throwing in our panko here. I'm going to open this up. And you'll always notice that ground turkey breast meat is going to be much, much lighter in color and probably a little bit more expensive, but it's worth it. All right. Move this out of the way. And then I can just kind of start mixing this in, getting those seasonings and that panko mixed in. And another thing to be thinking about too is maybe we had double the amount of onions in here that we are caramelizing. Take what we need for this recipe, the other part of the recipe, maybe you're going to put that into a frittata or whatever vegetable that you're sauteing. So again, it's always about maximizing your time, right? Sometimes I'll see people, they'll take this part of the onion and they'll put it in a Ziploc bag and then it'll go in the refrigerator and then they'll just throw it away because they didn't have a plan for it. So it's always important to make sure that everything we purchase at home, there's a reason for it, there's a plan for it. Don't just buy things to have it on hand, you know, unless it's like I don't know, extra vanilla extract or something that's not gonna go bad, right? That's not like bad for you. All right, so we're gonna go ahead and toss these caramelized onions in here. Okay, and I'm gonna turn my heat down just a little bit after, because we're gonna wanna sear these burgers. If you wanted, you know, kind of what Jason was mentioning too, there are some things that are not, you know, absolute no's, or there are no limits. If you wanted to do like a mixture of lean ground beef and your ground turkey breast, you could do that too. So if it made you feel better about having a burger and having, you know, your beef, you could probably do that as well. And you would still have to cook it to that internal temperature then too as well. 165. All right, so I'm going to add just a little bit of one egg here. And this is going to make quite a bit. And especially if you're trying to do like small meals, this is maybe one of the better things, because you easily could do just a little 2 to 3 ounce patty as almost like a little slider. So something you could easily do. And typically I would be getting my hands in here, but we'll just use our spoon. Okay. Now again, what I'm going to do is I'm going to put a little bit of oil in the pan, a small amount, and I've got a nice little, you could call it an ice cream scoop, I call it a portion scoop. But you can use this, and this can help, especially if you're kind of planning ahead and you're making a bunch ahead of time. This is something you could easily do. Another thought process that I always like to explain is that we can very easily take, you know, a little piece of this, fry it up, make sure it's fully cooked, let it cool, and then taste it. Make sure it's got good flavor. The worst thing you can do is make a huge batch of it and realize, oh man, I should have seasoned it more, or I could have used a little bit more of this. So that could help you. So we'll just kind of can easily patty that out. And the samples I did outside were about half a scoop, and I just squished them down really far. So you can see if we had one more egg, it might maybe be a little too wet. So this one egg was perfect. And so the idea is at least get a nice good sear on your turkey burger on both sides, and then you can just finish it in the oven. Get 2 in here. And if you're thinking about just doing it for the week, what you could do is sear it on both sides, and then when you come home from work, you know, on a day or whatever it is, then maybe you just put it in the oven, or maybe you put it back, you put it on the grill, maybe you want a grill flavor. There's just a couple different things you can do kind of looking ahead. So after that, we should be pretty much ready to go, ready for a burger. So kind of looking at this big picture, and this is a lot of what we talk about at the Healthy Living Program, really what Jason was kind of mentioning in is we really want to make sure that this is really realistic. So I'm not showing you anything super creative or anything crazy, just doing really good, straightforward things that have a lot of flavor, things that are really relatable for you. If you want to kind of be extra creative, you always can do that, put your own spin on it. But if you understand kind of that foundation of just like the little basic science of cooking, again, preheating the pan, make sure you can get that caramelization. What we're doing here is we're getting what they call the Maillard effect, and that's just the natural caramelizing of protein. And so we want to make sure that we get, again, if I would have just put this into an oven and baked it, it has a bit of a different flavor than having something pan-seared or grilled. And so again, it's just, okay, how can I make sure I'm building flavor, but I don't have to get crazy with salt and sugar and on all those additives? It's just the natural process. So I think it's really being conscious of understanding how to do that. And it can be really easy if we don't overcomplicate it, right? So it's taking normal recipes and just understanding I can have a burger, I just use turkey or lean ground chicken breast, and I got to make sure that I don't overcook it because then it'll be dry, and that's the thing that I fear, you know, things like that. When I'm making pasta, I can have pasta and I bulk it up with vegetables, but to make it more straightforward and easy, I'm going to make the pasta ahead of time, right? And then I have it throughout the week. And so I always kind of say you could literally have like a spaghetti and bolognese, you know, one day, and then you could have like a pesto and pasta dish another day. And, or, you know what I mean? You could kind of really change it up. But the noodles are the same. You know, maybe you have the same protein, but you change up the sauce and maybe the vegetable. And that's very realistic to do. So, ooh, yeah. So we got a nice color here. Very nice. And so you can notice, again, how little of olive oil I used. And so a lot of times people also ask me questions about, oh, I heard about the smoke point, and if you have olive oil, it can be have carcinogens in it. And the thing is, when we're cooking from a wellness perspective, we're not cooking on anything that high of heat. It's pretty low heat. And so because we lower our protection in the pan, which would be the oil, and we have to lower our heat. And so it just is a really short amount of time that we can have any type of high heat. So usually in our cooking classes, the highest we cook is medium high, and that's for about 3-4 minutes, and then we bring it down. The idea is that we can get restaurant quality flavor and look and texture and stuff. It just might take a little bit longer to cook, right? Which I think we can spare an extra 10 minutes, right? Just to have a little bit more flavorful food, but not make us feel like we have to have so many extra of the wrong calories of fried stuff. Any questions I can answer at all? No? Can you smell it at least through the mask? Okay, good. All right, awesome.